cordially welcome Head of Medical and delegates of various steel plants, eminent guest speakers, chairpersons, honorable judges, and medical officers to the much-awaited 42nd All India Steel Medical Officers Conference, Bhilai. It gives me immense pleasure to be standing in front of all our esteemed delegates who have graced this conference from steel plants across the country. I assure you that it will be a stimulating and gainful 3-day stay in Bhilai. To all those who are attending AISMOC for the first time, I would like to brief you about its history. It was the brainchild of Dr. T.K. Bose in 1980, the then HOM of Rourkela, and was held for the first time in Rourkela. Dr. T.K. Bose was a physician par excellence and became the first ED medical SAIL in 1976. He conceptualized the first AISMOC in 1980, which is unique to any public sector undertaking. AISMOC is organized by all steel plants in rotation. Since its inception, we are holding it for the 6th time. During its long journey of 41 years, it has achieved great heights comparable to any national or international conference. It is a matter of great pride that we are conducting the 42nd AISMOC today. AISMOC over the years, has become an opportunity for medical professionals of steel industry to exchange ideas, scientific deliberation, and showcasing their work. In the next few days, we will have guest lectures by eminent speakers across the country, panel discussion, symposium, debate, and the competitive section includes the paper and the poster presentation, and the much-awaited and entertaining highlight of AISMOC, the Medi Quiz. AISMOC is held every year, but due to COVID pandemic, this AISMOC is being held after a gap of 3 years. During the pandemic, we have all learned to embrace technology to its fullest. We have tried to include all those who could not join us by webcasting the event. This would be the first time when such a webcast will be done in AISMOC. I thank our leaders, Director in Charge, Bhilai Steel Plant, and Patron AISMOC, Shri Anirban Das Gupta Sir, CMO in Charge and Chairperson AISMOC, Dr. Ravindranath M. Sir, CMO and Committee Chairperson AISMOC, Dr. Pramod Benaike Sir, Additional CMO and Organizing Secretary AISMOC, Dr. Subodh Saha Sir, for their unconditional support and cooperation. I take the opportunity to compliment our team of guiding lights for their untiring efforts over the past few months in the making of the 42nd AISMOC. I also extend my deepest gratitude to the various organizing committees who will be helping in the smooth conduct of the conference throughout. They have left no stone unturned to ensure that it turns out to be an occasion to be remembered in the years to come. So let us all gear up and sit back to experience the hospitality and magic of AISMOC 2023 Bhilai, and hope you all carry home fond memories as we bond together over the next 3 days over a brainy feast, excellent cuisine, and a cultural bonanza. We will now start the scientific program with the MBBS award session. There are 7 participants in this round. Each participant gets 6 minutes for their presentation and 2 minutes for the discussion. There will be a warning buzzer after 5 minutes, and participants who exceeds the time limit will be disqualified. To chair this session, we have Dr. B.K. Hotha, ED Medical Rourkela Steel Plant, Dr. S.J. Rizvi, former Director, JLNH RC Bhilai. And our panel of judges for this session are Dr. Subodh Hiran, former ED Medical Bhilai, JLNH RC, Dr. Atul Deshkar from Chandulal Medical College, and Dr. Shipra Sharma from DK Super Speciality Hospital. I request our jury to please take their allotted seats. I invite our chairpersons on the dais to conduct the session. I would request the audience to please keep their mobiles on the silent mode.
Hello. Good morning, ladies and gentlemen, dignitaries. Very glad and privileged to be here. It almost happening after 2 years, I suppose. Now I invite Dr. Sudeshna Dasgupta from Tata Steel for our speech. Thank you.
the participants the best of luck. And I think it's an honor for both of us that we are chairing the first session of this conference. Thank you.
अच्छा ये हाइट ठीक है माइक का इसको स्लाइड शो में करेंगे स्लाइड शो में 1 मिनट इसमें नहीं प्रेजेंटर्स भी नहीं
हटाना है प्रेजेंटर
स्लाइड शो में करना है हाइट ठीक है ना माइक का Shall I start? Yes. Name check change कर देंगे ना This is mine, but the name is not participation. I need a participation. No, यहाँ पे. Over here. Yes. Now it is start. Ma'am, just tell me when to start. Start. Good morning, everyone. Today I'll be presenting my paper, Profile of Children with COVID-19 Infection in a Mines Division Hospital. Emergence of COVID-19 has attracted global attention, the WHO having declared it a pandemic in March 2020. In children, the disease is mostly asymptomatic or with mild to moderate symptoms. To date, not much information is available about COVID-19 in the pediatric population from Eastern India. Hence, this study was done with an aim to analyze the profile and outcome of children with COVID-19 infection in Tata Steel Mines Hospital in Joda, Orissa. This was a retrospective medical record review, the inclusion criteria being all children up to 12 years of age with RAT positive for SARS-CoV-2 at our hospital from 26 July 2020 to 13 February 2022. The data source for the inpatient case files and the registration entries. Data collected was analyzed using statistical methods, the Pearson chi-square test and the Mann-Whitney test. Statistical software SPSS version 22 used for analysis, any p-value less than 0.05 considered to be significant. The grading of severity done according to guidelines, where amongst others, the SpO2 more than equal to 94% on room air taken to be mild, 90 to 93% as moderate, and less than 90% taken as indicator to be of severe illness. The results, in my study, out of 183 patients, majority, that is 48.6%, were in the age group of 6 to 10 years, the mean age being 7.6 years, males at 57.4% outnumbered females. Contact history was present in 93.4% cases. The symptoms, fever was the commonest symptom at 43.17%, followed by cough and loose stools. Others like vomiting, headache, etc. were also seen. 65% of the total children were symptomatic. More were asymptomatic during the first wave as compared to the subsequent waves. The severity of illness, 98.4% had mild illness, while 0.8% had moderate and severe illness each. The mean SpO2 at the time of presentation was 98.02%. Comorbidities like asthma, sickle cell, etc. seen in 24% of cases. As per institutional policy, during the first wave, all the children were admitted. During the subsequent waves, 56.76% of the children were hospitalized. The outcome, 98.4% improved, 1.1% referred, while 0.5% expired. Comparing the outcome between the waves, during the first wave, no child was referred or expired. During the subsequent waves, 1.09% of children were referred compared to 1.61% adults, the P being 0.557. However, comparing the mortality, this was 0.55% in children as compared to 4.02% in adults, the P being less than 0.001. The mean days to RAT negativity and duration of hospital stay was 7.35 days. Children with symptoms had a slightly prolonged duration of hospitalization, but out of 119 children with symptoms, 1 expired, P being 0.315. Again, children with comorbidities slightly prolonged hospital stay, but out of 44 children with comorbidities, 1 expired, the P being equal to 0.312. Coming to the discussion, the study highlights the profile and outcomes of 183 children with COVID-19. In our study, children comprised 9.6% of the total COVID cases. Worldwide surveillance data have reported children typically to account for 13% of lab-confirmed cases, as stated in the study by Singh P. et al. Comparing with other studies, first by Jat K.R. et al. And secondly by Sarangi B. et al., the mean age, sex distribution, presence of contact history, percentage of asymptomatic cases, and the most common symptoms were similar to the other studies. However, gastrointestinal symptoms was present at a much higher rate at 18% in our study compared to 10 and 4% in the other two groups. Comorbidities 24% compared to 44 and 4%. Mild illness was in majority in all the three groups. Average duration of hospital stay similar. Mortality 0.5% as compared to 3.2% in the first group. Among symptoms, gastrointestinal ones comprised 18% in our study and only loose stools seen in 5.8%. Adult patients with digestive symptoms without respiratory symptoms are rare, while in children it seems to be more frequent, as stated in the study by Bustos Cordova et al. Mortality rate was low in the present study as compared to the study by Jat K.R. et al. To conclude, COVID-19 can affect children of all ages, but most were in the age group 6 to 10 years with slight male preponderance. Even though fever and respiratory symptoms were the most common presentations, gastrointestinal symptoms were also seen in a significant number of cases, and these should raise suspicion of COVID-19 in children. During the second and third waves, most children had symptomatic illness, but majority had mild illness and recovery was good. Mild disease pattern in the pediatric age group is reiterated. The limitations of the study being RAT was used as a diagnostic test, unicentric with a small sample size. Long-term follow-up couldn't be done. These are some of the references. Thank you.
Thank you, Dr. Sudeshna, for completing before time. And now the topic is open for discussion.
I am Dr. Indranil from Bokaro Steel Plant.
Good morning, sir.
Good morning. How do you account for the large number of gastrointestinal cases in your study? Do you have any explanation for that?
Yes, sir. For the entry of the virus into the cell, the angiotensin converting enzyme 2 receptors as well as the transmembrane serine protease TMRP SS2 receptors, the coexistence of both of these are essential for the entry of virus into the cell. And in addition to the respiratory, the alveolar cells of the respiratory system, there is co-expression of both these cells in the gland cells of the esophagus as well as the absorptive enterocytes of the ileum and the colon. And this tropism for the gastrointestinal tract, these can explain the gastrointestinal symptoms that were seen in the study. Pardon, sir?
I am Dr. Jain from Royal Class Steel Plant.
Good morning, sir.
Did any of your children had complication of MIS?
No, sir. No.
So any mortality, one case?
Yes, sir. Mortality was 0.5%.
So what were the indications for referral of the cases?
Yes, there were 2 children were referred, and one was a child with CP with history of intractable seizures and belonging to a very affluent family. The time this child was admitted, although there were no seizures at that time, the COVID ICU was full, and the parents belonging to a very affluent group, they were very apprehensive that no ICU beds were available because this child had history of severe intractable seizures. So this child they wanted to take to higher center and was referred. And the other company belonging to a company, child with complex febrile seizures history, and they had a history of seizure at home which was aborted with intranasal midazolam. And since their family was staying in Jamshedpur, they wanted to have the support of their family members. And so again, this child was taken to Jamshedpur.
Okay, thank you, thank you. I request the audience, only 2 to 3 questions are allowed to keeping the time limit in mind. She said limited, sir. She said limited, only limited.
As per the institutional policy prevailing at that time, RAT was done at our center, sir. So we did this test.
By that time, not many hospitals have artificial facility. Okay, madam, thank you.
Thank you, sir.
Now I request Dr. Swati, she's from Burnpur Steel Plant, to present her paper on non-IgE mediated cow milk protein.
Should I start? Sir,
Please go ahead.
Respected chairperson, judges, and respected delegates, a very good morning to one and all. I am Dr. Bhilai Niwas from Burnpur SAIL-ISP, and my topic is a case presentation on cow milk protein allergy. A 10-month-old female baby presented in pediatric OPD with a complaint of occasional episodes of blood in stool. Present complaint also involves occasional episodes of fresh blood drop by drop not mixed with any stool. History of similar complaint was presented at the age of 7 months and treated with antibiotics and supportive treatment. There is no history of similar complaints before the age of 6 months of age. Baby is clinically and hemodynamically stable, and whereas all other parameters are normal. Coming to differential diagnosis of lower GI bleed, hematochezia, we can have acute bacillary dysentery, infectious enterocolitis, intussusception, benign hematochezia in infancy, polyps, hemorrhoids, etc. Investigations performed to rule out all the possible surgical causes. Stool routine examination came out to be 10 to 12 RBCs per HPF. Stool for occurred blood came out to be positive, whereas stool culture sensitivity showed no growth. Ultrasound whole abdomen, Meckel scan, and colonoscopy came out to be normal. Meanwhile, symptomatic treatment was initiated with oral antibiotics, zinc supplementation, and probiotics. Child was referred to a higher center for further evaluation and treatment. The child was admitted for 3 days, treated with IV antibiotics and antacids. CBC, COVID-19 test, Meckel scan, and colonoscopy came out to be normal, whereas CT angiogram did not show any arteriovenous malformation. So a diagnosis of intermittent hematochezia under evaluation was made, coming out to be a differential diagnosis, Meckel's diverticulum, allergic proctocolitis, food allergy, most probably cow milk protein allergy is made, and plan to evaluate the child at the time of active bleeding by diagnostic laparoscopy. Also, discharge with an advice of extensively hydrolyzed formula milk for 2 weeks along with breastfeeding, and oral PPI for 2 weeks, multivitamin drops for 3 months, vitamin D3 drop for 3 months, and oral antihistamines and topical steroids to continue until next visit. Even after above treatment, child continued to have the symptoms. So the case was shifted to pediatric department, SAIL-ISP Burnpur. We ran few investigations such as PT, APTT, INR, which came within normal limits. Serum IgA also came out to be within normal limit, whereas serum IgE, which is 51.46 international unit per milliliter, is mildly elevated. Tissue transglutaminase, IgG, and IgA both came out to be negative, excluding out the celiac disease. Allergen for the serum cow milk protein came out to be negative. Since all the investigation came out to be negative and symptoms started after the age of 6 months, there is a high index of suspicion of cow milk protein allergy. Through an open controlled oral food challenge under medical supervision, we confirmed the diagnosis as cow milk protein allergy. Since the specific serum for cow milk protein is also negative, it is called non-IgE mediated cow milk protein allergy. Cow milk protein allergy is a type of milk allergy where a baby's immune system abnormally reacts to a protein in the milk of cows or some other animals. Incidence and prevalence of cow milk protein allergy all over the world is about 2 to 7.5%, whereas in India there is no enough data available, likely enough to determine its local prevalence. Other countries, such as highly populated countries like China, where is about 53.3% of bloody stools in infancy was diagnosed as cow milk protein allergy. Cow milk protein allergy usually presents in GI system, skin, respiratory system, generic symptoms such as problem in sleeping or persistent crying. Out of all the above symptoms, GI system accounts up to 25 to 50%. Coming to our case, non-IgE mediated cow milk protein allergy. There is a delayed reaction which is up to several hours to days after allergen exposure. Mechanism of the reaction is not understood, therefore no specific tests are available. Since symptoms are not life-threatening and less severe than IgE mediated, diagnosis and treatment is often delayed. In our case, diagnostic elimination of cow milk protein resulted in the improvement of clinical symptoms. Subsequently, we reintroduced cow milk protein in the diet to confirm the diagnosis and therapeutically eliminated cow milk protein from the diet. A high index of suspicion is always required for diagnosing cow milk protein allergy, and a dietary elimination of cow milk and introduction of extensively hydrolyzed formula or amino acid formula milk is the treatment of choice in cow milk protein allergy. Thank you.
House is open for questions, please. Limited 1 to 2. But
Sir, it is due to allergy, sir. Yes, sir. It is the allergen, sir. At the time, baby when ingests milk which contains cow milk, casein is the protein which irritates the gut of the baby.
So my point is two. This is a case report, this is not a study, number one. And number two, you have mentioned diagnostic laparoscopy as a diagnostic modality for hematochezia. How do you explain that?
Sir,
Diagnostic laparoscopy.
that we didn't plan, sir. When the child was referred to a higher center where pediatric gastroenterology was there, pediatric gastroenterologist.
This, particularly the normal CT. This the bleeding PR could be due to food protein-induced proctocolitis.
Food protein-induced proctocolitis is also a differential diagnosis, sir. But food protein-induced proctocolitis usually presents in the age of 1 to 2 months only, sir. And also, food protein-induced proctocolitis presents along with mucus, and baby has a symptom of persistent wailing or discomfort whenever the baby is passing stool. In our case, baby is perfectly all right. The only concern was bleeding PR, fresh blood drop by drop occasionally after the age of 6 months. Eosinophilic enteritis could be a diagnostic thing, sir, but if the eosinophil counts are higher. In our case, IgE is very slightly mildly elevated, which can be because of a normal flu also. Since the baby is only 6 months of age and parents don't want to go for a biopsy, we had first had a higher index of suspicion of cow milk protein allergy, sir, and baby responded well to the diagnostic elimination of
Thank you, ma'am, for your nice talk. Now we'll come to the third talk. Coming to the third topic, it is we welcome Dr. Chittaranjit Rai from Dugapur Steel Plant. Dr. Sir, please.
टाइमर यहाँ पे दिख रहे हैं क्या नाम है आपका डॉक्टर चिरंजीत हाँ यस चलो स्टैंड लीजिए हटा दिए स्लाइड्स चेंज कैसे होगा दिस ओके पॉइंटर नॉर्मल स्टार्ट Good morning everyone. Do you know that hypovitaminosis D is one of the most treatable yet underreported nutritional deficiencies across the developing world? Honorable Chairperson, respected judges and fellow delegates, myself Dr. Chiranjit Roy from DSP Main Hospital is here to present a topic on the role of vitamin D in mechanical low backache. Mechanical low backache is defined as low back pain which is not attributable to a recognizable or any known specific pathology. Example, infections, tumor, osteoporosis, inflammatory disorders, etc. Some symptoms of mechanical low backache is increasing pain with lifting, bending, worsening pain when sitting or standing, pain around lower back and upper buttocks, which worsens during the day and not associated with any neurological signs and symptoms. The aim of this study was to determine the efficiency of vitamin D supplementation in patients with mechanical low backache. Vitamin D metabolism. We can see that the sun's ultraviolet B spectrum of light leads to the formation of cholecalciferol, which in turn converts into calcidiol in the liver and then into calcitriol, which is the active form of vitamin D, which maintains the calcium and phosphate homeostasis. Materials and methods used in the study was analytical prospective cohort study, and the period was from February 22 to October 22. Sample size consisted of 30 subjects of the male gender in the age group of 25 to 45 in the absence of any other comorbidities. They were all given vitamin D supplementations, 60,000 international units for 10 consecutive days, and it was approved by the ethical committee. Review evaluation of pain, functional disability, and vitamin D level estimation was done at 3 weeks, and additional evaluation was done at 9 months. Pain and functional disability was assessed with the help of visual analog scale and modified oswestry disability questionnaire scale. Analgesic, muscle relaxant, and H2 blockers were given uniformly to all patients for 5 days. Adverse drug reaction recording chart was provided to all patients, and review analysis was done at 3 weeks and 9 months to conclude the findings. Also, to see the declining level of vitamin D, at 9 months additional blood sample was collected. Here are some of the symptoms of vitamin D toxicity. A total of 30 mechanical low backache subjects were screened for serum vitamin D levels, of which 2 were in the normal range, hence excluded. And of the remaining 28 subjects, 21 reported with chronic low backache and 7 with acute low backache. 25 who were exposed to adequate sunlight, and 3 who were not exposed to adequate sunlight, hence outdoor. So this table here shows that the vitamin D levels in pre and post treatment estimations, which increased significantly after 3 weeks, and also the declining levels after 9 months can be seen. The VAS score was around 5 to 7 before the treatment, which is moderate to severe, and at 3 weeks the VAS score improved for 79% of the subjects, less than equal to 2. At the end of the study, at 9 months, it improved to 96% of the subjects. Modified oswestry low back pain disability questionnaire, it was the gold standard of low backache. We can see a score from 0 to 50, starting with no disability to completely disabled. This is the modified oswestry disability questionnaire scale, according to which the scores were given. The MODQ scale evaluate parameters like pain intensity and personal care, lifting, etc. So in our study, we see that before treatment, the MODQ score was around 20. At the end of 3 weeks, 79% of the subjects had a score of 5, and also 96% had a score of 4 at the end of 9 months. So the results and discussion, the participants showed significant improvement in VAS score and modified disability score after 9 months. Changes in the vertebral disc have been reported with hypo D and low backache. Vitamin D has proven a role in the improvement of muscle strength, neuromuscular coordination, sleep and mood modulation. So supplementation of vitamin D appears to down-regulate the pro-inflammatory cytokines, which leads to pain, and up-regulate the anti-inflammatory cytokines that reduce inflammation. So comparing the pre and post vitamin D levels after treatment, there was improvement in the VAS score and MODQ score. We can see through this graph. So hence we can conclude by saying that vitamin D is essential for the growth and development and maintenance of multiple organs in the body, and its deficiency will profoundly affect the musculoskeletal system. Paraspinal muscles are the dynamic stabilizers of the spine, and any effect on them will adversely affect the physiology of lower back, leading to backache. So we can see that vitamin D has a direct role in the pathogenesis of low backache. Hence we can say that the daily recommending dose is 2,000 to 3,000. The limitation of the study was participants could not include more than 50 years of age, and also tri-monthly samples were not collected in the study. Take-home message would be vitamin D deficiency cannot be neglected in cases of mechanical low backache. Adequate exposure to sunlight is necessary for vitamin D production. Hence, vitamin D supplementation effectively reduce man-day loss. And foods rich in vitamin D should always be included in our daily diet. These are some of my references. Thank you.
Good of you, Dr. Ray. Now, it's open for...
Yes, sir.
See, actually, that was a very interesting study, but
sir.
you know that the incidence of vitamin D is so common in the community that
Yes,
you
sir.
should have a control group to say whether the response you have got is due to the vitamin D or to the supplements which you have given. Because
Sir-
the incidence of vitamin D is so high in the community.
Exactly,
Why can't we
sir.
say that it's a placebo effect?
So, but there was no other parameters included in the study, like the people who didn't have any other comorbidities. So we had to see that the
Yeah, I agree.
hypovitaminasis D
Agree,
was the
but
exactly
for this
causative
study,
factor.
You need a control. You
Control
need a control
group,
of
yes, sir.
30 to clearly say that whatever you have produced
Yes,
is
sir.
because of vitamin D.
Yes, sir. Yes, sir. Thank you.
With low back pain,
Yes, sir.
how can you prove that this is mechanical low back pain? You have not said about this.
Okay.
And how to differentiate other causes of, because many times when you give treatment for 5 days, the muscle spasm goes, the mechanical back pain goes, and then you confuse whether it is because of vitamin D deficiency or something else.
Sir, the symptoms differ. In muscle spasm, the muscles are sore and tight, and mechanical low backache, it's the dull aching pain which is spreading to your upper buttocks and thighs. But it is like a chronic symptoms.
No.
These-
It's not necessary.
It's not necessary, but
Sometimes
some-
acute or
yes.
chronic could not have that much inflammation.
It-
So this only on palpation you can elicit some tenderness.
Yes, sir.
Otherwise, you will not have any other symptom in some acute or chronic low back pain.
Exactly,
So
sir.
differentiation is difficult.
Differentiation is difficult, but not impossible, sir. We can differentiate between those two pains. And any other neurological pain has other signs and symptoms, such as tingling, numbness, and all those radiculopathy. Those pains are completely different from the mechanical low back pain.
Hello.
Only one more question, please.
Yes, sir.
Have you considered the occupation of the participants, whether there is
Yes, sir, yes, sir.
sedentary or heavy work, because there is a...
So the
both are
workers,
exposed to
yes,
low
sir.
back.
I would like to say something about the occupational problem related to my topic. Like this, the workers who are working with heavy, who are doing heavy work. For example, who are working in furnace or melting, casting. All those people who are not getting proper sunlight, who are doing manual hard labor, are more susceptible to get this kind of mechanical low back pain in.
Thank you,
in
Dr.
future.
Ray. Thank you. Thank you very much.
Thank you. Thanks a lot.
I now invite Dr. Shiva Martha from Bhilai Steel Plant to give us the presentation on validity and reliability of a glucometer against accredited reference standards. Dr. Martha, please.
Good morning, respected chairperson and judges and distinguished delegates. Here I am going to present the validity and reliability of a glucometer against accredited reference standards. All of us know diabetes is an emerging lifestyle disease. There is 3% increasing in the mortality in the worldwide in the past decade. In lower middle income countries like India, the mortality is increased to 13%, out of which with cardiovascular disease is 20%, 5% with diabetes nephropathy. Glucometer is most commonly using device nowadays in diabetes mellitus management. Our study aims to quantify the validity and reliability of a glucometer against accredited reference lab analyzer. Glucometer had an advantages as compared with the lab analyzer is its portability and less sampling volume required. No prior sampling method is needed and immediate results will obtain. However, with convenience comes with cost, both monetary and in relation with the results obtained. We have conducted prospective case control study. We have taken 150 population in the study, categorized into 3 groups and 50 samples in each. Those are non-diabetic and highly controlled diabetes, pre-diabetic and borderline diabetes, and uncontrolled diabetic groups respectively. We have included 30 to 60 years of age group with diabetes mellitus and excluded all other comorbidities, age and sex. Capillary blood sample used for glucometer, which works on electrochemical method, and peripheral venous sample used for Beckman-Coulter auto-analyzer, which works on spectrophotometer method. A quality control provided by the manufacturer were run prior to the sample run and compared with the quality control chart and found to be acceptable. Our results are compared and calculated by using SPSS software. When coming to the Quality control observation. Manufacturer provided 3 quality controls for the glucometer. At level 1, our range is at 85 to 135 with the mean, with target mean of 110, and our octane value is 92 with difference of 18 with the mean. At level 2, at level 2, at level 2, our ranges are 180 to 300 with target mean of 240, and our octane value is 208 with difference of 32 with the mean. At level 3, our ranges are 400 to 510 with target mean of 445, and our octane value is 486 with difference of 41 with the mean. Coming to the autoanalyzer values, manufacturer provided 2 quality controls for the autoanalyzer. Our ranges are 91 to 107 with the target mean of 99, and our octane value is 100 with difference of 1 with mean. At level 2, our ranges are 230 to 248 with target mean of 239, and our update value is 238 with the difference of 1. Here we can observe quality control had wide ranges of values. So glucometer may give erroneous results with the actual result. Coming to the sample observation, the mean for the glucometer in the respective 3 groups is 92, 199 and 328. The same with the autoanalyzer is 99 and 136 and 237. The standard deviations are 8 and 46 and 79 for the glucometer. For the autoanalyzer it was 1.53 and 12 and 80. Here we can observe there is high difference between the mean and standard deviation for the glucometer as compared with the autoanalyzer, especially for the borderline controlled diabetic groups and uncontrolled diabetic group respectively. In the bar diagram, the mean represents that there is high difference between the glucometer values and autoanalyzer values in the borderline and uncontrolled diabetic groups. The standard deviation also represents that there is high difference between the 2 groups, especially for the borderline and uncontrolled diabetic groups. In the results, coefficient variation for the glucometer observation was 10%, 23%, 24% in the respective 3 groups. The same with the reference instrument is 2%, 9%, 2% in the respective 3 groups. Here we can observe coefficient variation for the borderline diabetic group and uncontrolled diabetic group is more than 20%, which is globally unacceptable. The standard deviation in the results are 8%, 46% and 80% respectively against the maximum of 20%, which is globally unacceptable. P-value for the borderline diabetic group and uncontrolled diabetic is less than 0.01, suggesting statistical significance. When comparing to the other studies conducted by the Ottawa Hospital, Canada, Wheaton University, USA, and Harrison and colleagues studies are correlated to the study. Here I am going to conclude glucometer results are not highly correlated with the autoanalyzer. Our study found that poor validity and reliability of a glucometer against the accredited lab analyzer. Glucometer may tend to give erroneous results which affecting the treatment when solely depending on the glucometer. Here I am going to give a message. Glucometer is not 100% clinically specific. This may give false positive results, vice versa. One has to know the limitations of the glucometer prior to its application. Glucometer results should be cross-checked with the standard lab analyzer is important in the management of diabetes mellitus. It can be used for patient maintenance with a great caution, not for the diagnosis, treatment and research purposes. Thank you.
The paper is now open for discussion.
That was a very interesting paper. In fact, this is the need of the day. What was the glucometer used and was it standardized? Because the results which you are giving is quite varying. Has it any relation to values which are in the normal stage and hyperglycemic state? Because the tendency for glucometers to be erroneous when the results are high is quite there.
Yes, sir. Mean values are standard deviation for the
Was the glucometer used and was it standardized?
Glucometer used, actually, which standard glucometer which was using in the hospital, in our institute, we were applied with that only, sir.
Okay. But the take-home message is really bad for us because we are all the ADA says the self-monitoring of blood glucose is very, very important. The variation is about 10 to 20% when the values are around 200.
Sir, especially
200. Yes. You have to take the ADA standard, and if it is more than 350 to 450, as you said, it can be to a variation of 20 to 30%.
Yeah, very good study. The only point is, in control group, we have used the standardized equipment of a Beckman autoanalyzer. Yes. While in the study group, we have not specified what brand you have used, whether this was standardized, the vintage of it, whether it's an old one, who was using it. The lab ones are done by trained this thing. Who was doing this, whether they were trained. There's a lot of fallacies in the study done correctly or not? What strips you have used? So there's
Sir,
so many consumables are
actually, in our institute, there is one brand of glucometer is using. So we have compared with that only, sir.
So it is true only for that particular brand. You can't make a generalized statement of across the all glucometers.
But our study is also comparing with the other studies. It was correlated to it, sir.
Strips are old. They can also give erroneous results. So did you consider that also?
No, sir, actually, we have compared with the standard glucometer.
The strips, the use the
Strips, which were not expired, sir.
Yes.
Yes.
Thank you, Dr. Matha. Thank you. Now I welcome the fifth speaker of this category, Dr. Smita Sekhar from Bukarti branch. Dr. Smita Sekhar.
स्मिता पुष्पशेखर इसको कहीं से ऑपरेट करना इसको ऐसे करिए ना इसको स्क्रीन से ऐसे करेंगे मेरा हाथ पहुँचना चाहिए इससे उसको ये करना है इससे इसको ये करेंगे स्लाइड्स को नेक्स्ट ये अच्छा पॉइंटर है इससे कर सकते हैं
Please go ahead. Please go ahead.
Honorable chairpersons, judges, and esteemed audience. Today the topic of my presentation is to study efficacy and acceptance of levonorgestrel intrauterine system in AUB as an alternative to hysterectomy. Abnormal uterine bleeding is a common gynecological problem responsible for 30% OPD visits and prevalence is 17.9%. It adversely affects a woman, which includes her physical health, her psychological health, her family life, work productivity, and adds financial problem. Traditionally, the treatment has been hysterectomy, but modern gynecology focuses on conservative management, which is due to cost effectiveness, and it helps to preserve uterus and fertility in young patients. Levonorgestrel intrauterine system, commonly available as Mirena, is a hormonal contraceptive device, contains 52 milligram of levonorgestrel and releases 20 microgram levonorgestrel per day for 5 years. It causes atrophy of glands and deserialization of stroma, prevents endometrial proliferation, and thickens cervical mucus. It has been advocated in treatment of AUB, so our aim was to study its efficacy and acceptance in AUB as an alternative to hysterectomy. 40 women from age group 35 to 50 years were studied for a period of 4 years. Patients came to OPD with various menstrual complaints. Proper history was taken, general and local examination was done. Besides routine investigations, pap smear, transvaginal sonography, UADNC with histopathology was done to rule out any genital pathology or malignancy. Patients with uterus size more than 12 weeks size and with large submucous fibroid distorting uterine cavity or atypical endometrial hyperplasia was excluded. Women were put on oral progesterone or OC pills for 3 cycles. Those showing good response to this hormonal therapy were counseled for this device. Patients were also counseled about its common side effects like spotting, risk of expulsion, formation of ovarian cysts, etc. Insertion was done post-menstrually in OT. Oral progesterone 5 milligram 1 tablet was given daily for 21 days for a period of 2 months. Follow-up was done at 1 month, 2 months, 6 months, and 12 months. Patients were asked about relief of symptoms, bleeding pattern, and general well-being. During each follow-up, general examination, breast and pelvic examination was done. TVS was done to locate the position of the device, any change in pathology, development of ovarian cysts, etc. Efficacy of the device was measured in improvement in subjective symptoms in relation to pain, duration, frequency, and amount of bleeding, and improvement in quality of life. In our observation, we found that the mean age of the patients was 42.15 years. 75% patients were para 2. 70% patients had no uterine pathology on ultrasound. So 62.5% patients had normal uterus on clinical examination. 25% patients had associated comorbidities. Then bleeding pattern was observed at 6 months and 12 months. What we observed was 50% patients showed amenorrhea at 6 months and 72.5% showed amenorrhea by 12 months. This is evident from this bar graph. Hysterectomy was done in 4 and injection DIMPA was given in 1. So finalizing the result, 33 out of 40 patients showed significant decrease in menstrual blood loss. 35 chose to continue this device over hysterectomy. Removal was required in 5 patients. 3 had continued to have heavy menstrual bleeding. Dislocation was seen in 1. 1 patient had psychiatric illness and could not be counseled. Hysterectomy was required in 4, that is 10%. So coming to the whole discussion of this study, excessive menstrual bleeding is an incapacitating problem which affects quality of life, both personal and social. Exact problem of this cannot be defined because the findings are subjective. Patients are either unsatisfied or non-compliant to oral medication due to its prolonged treatment and systemic side effects. Therefore, we end up doing 30% hysterectomy just to alleviate the symptoms. Now, hysterectomy has its other side effects. Besides side effects of surgery, it causes postmenopausal symptoms, predisposes to many other high risks. So there's a treatment dilemma. There is a treatment dilemma. Now, what to do? So, levonorgestrel, here we have a magic stick which acts locally. It has high concentration within the uterus and plasma concentration are low, so there is no side effect. Results are equivalent to hysterectomy, which we have also seen from our result, 82% efficacy and 87.5% acceptance. Hysterectomy required only in 10% patients. Our results are comparable to the results in the past. So in conclusion, we can say that it's a locally acting device which reduces blood loss effectively. It has high patient acceptance and it can be used in comorbidities. It is safe, cost effective and reversible. Therefore, my take home message is deliver the best, preserve the uterus, consider LNG IUS in treatment of AUB as an alternative to hysterectomy. We should always avoid untimely and unjustified removal of uterus. Thank you.
Now, Kausi Japan for question and answer sessions.
My question is, what is Mirena crash and how do you deal with it?
So Mirena crash is there's anecdotal symptom where the patient undergoes anxiety, mood disorders, and all those kind of symptoms due to sudden fall in progesterone.
When actually does it happen?
Mirena crash usually seen just after a few days of insertion.
No, ma'am.
No.
Mirena crash is a bundle of symptoms which appear when you remove the Mirena. Okay. And there are a lot of symptoms, anxiety, depression, breast tenderness,
Yes, so all those cramping and all those things.
bleeding. These are the symptoms of a Mirena crash and it happens when you remove a Mirena. And how do you deal with that?
So that we can give a supplementation of progesterone.
Actually, it is dealt treatment of symptoms, lifestyle modification, and
Low dose progesterones also can be added, sir.
that is the last line.
Yes, sir.
So
because we can taper the progesterone level.
Yes, initially you start with the lifestyle modification.
Yes, sir.
Then you go for the symptomatic treatments. If there is bleeding, you add a progesterone, and gradually it comes down. So that is Mirena crash, which develops when you remove a Mirena. Thank you.
Look, let me speak.
Yes,
because
sir.
I'm a gynecologist.
Yes, sir, sure, sir.
I doubt that there are many gynecologists here in the audience.
Yes.
So let me take over the charge of a gynecologist.
Yes.
Madam, you said it is widely accepted. I doubt it is widely accepted. Second point is that may I speak you what is the most common reason for rejection of this Mirena by patients?
Most common rejection is that irregular spotting and bleeding which the patient faces, sir. The cycle control in the initial period, first 2 to 3 months.
Periodic amenorrhea and repeated pregnancy test and based to the gynecologist.
So amenorrhea, I think it is acceptable because in our studies we found that patients with amenorrhea were quite happy.
Lady, not accessible to many times for a gynecologist, sitting at home with 8 months of amenorrhea, would she sit idle and relaxed?
No, sir, but amenorrhea, we have seen in our study that patient has accepted it. Irregular menstruation is definitely a matter of concern.
Because there is chance of pregnancy.
There are chances of pregnancy.
Even if it is less than 1%, when taking OC pills, people are repeatedly visiting the gynecologist to check for pregnancy test and why mention not
So,
there.
we have called them for follow-up. We have
Okay,
called
thank
them
you.
from regular
Thank you.
follow-up. Thank you, sir.
Yeah. I now request Dr. P.G. Roy from Rourkela Steel Plant to present his paper on prior calculation of CVC insertion depth while cannulating the right subclavian vein to avoid right atrium. Dr. Roy, please.
Presenters will change. Yeah. Presenters will change. Presenters will change. Respected Head of Medicals, Chairperson, esteemed dignitaries, and dear colleagues. Warm greetings from the fraternity of Ispat General Hospital, Rourkela. I, Dr. Pragya Jyoti Roy, am presenting about the usage of anatomical landmarks during the cannulation of the right subclavian vein to achieve optimal depth of placement of central venous catheters. CVC insertion is a widely performed procedure in hospitalized patients. Spurred by technological advancements, there is a plethora of venous access devices available today. Ideally, the procedure has to be done under ultrasound guidance. However, due to logistical issues, this is not always feasible. The right subclavian is the most commonly cannulated vein while using a blind approach. After insertion in the right subclavian, the catheter should be in the superior vena cava at the junction of SVC and the right atrium, ideally the lower one-third of the SVC. The carina, which is a reliable radiological landmark for assessing the correct placement of the CVC. In various studies, the recommended depth of CVC insertion in the right subclavian is said to be between 13 to 16 centimeters. Apart from other complications of CVC insertion, incorrect placement of the catheter may lead to potentially life-threatening complications like cardiac tamponade, arrhythmias, tricuspid valve damage, pericardial effusion when the catheter is distal or inside the pericardium, and thrombosis or dislodgement of the catheter when the tip is proximal. Thus, the role of cardiac monitoring during the procedure and follow-up X-rays of the chest is very important. The aim of the study was to evaluate the depth of CVC insertion while cannulating the right subclavian using anatomical landmarks prior to starting the procedure in order to achieve a safe and effective cannulation in absence of an ultrasound guidance. The study was done as a prospective randomized case control study at our hospital from January 2021 to July 2021 with the approval of the ethics committee. Adult indoor patients consenting to insertion of the CVC in the right subclavian vein were selected, and standard hospital supply 7 French 20 centimeters CVC kit was used for the procedure. The patients who failed to consent had local infection or anatomical deformities, trauma, restricted neck movements, bleeding disorders were excluded from the study. Based on the inclusion and exclusion criteria, 30 patients were selected and divided into 2 groups, C and T. Group C subjects were cannulated to a standard insertion depth of 15 centimeters. And Group T subjects were cannulated to a pre-calculated insertion depth, which was equal to the distance between the thyroid notch and the sternal angle, with the patient lying in the supine position and neck fully extended. The procedure was done under close cardiac monitoring and was followed up by repeated chest X-rays. to rule out any complications and ensure proper positioning of the catheter tip with respect to carina. The distance between the tip and carina was noted, and the catheter was repositioned if it was found more than 5 centimeters above the carina and or more than 1 centimeters below the carina. There were not much variation with respect to age and sex of the subjects, and the average height ranged from 161 centimeters in group T to 160 centimeters in group C subjects. The depth of catheter insertion in group T subjects varied from 11.2 centimeters to 13.6 centimeters, the average depth of insertion being 12.4 centimeters. And it was a standard predetermined length of insertion of 15 centimeters in group T subjects. The tip to carina distance in group T subjects ranged from 0.6 centimeters below to 3.4 centimeters above the carina, the average being 1.4 centimeters above carina. And it was an average of 1.9 centimeters below carina in group C subjects. Catheters were repositioned in 8 patients of group C and 1 patient of group T, which showed a significant statistical association with a p-value less than 0.05. One patient in group T had a proximally placed catheter, and none of the subjects had catheters placed in the right atrium or had any cardiac event during the procedure. The average depth of catheter insertion was found to be 12.4 centimeters in group T, and there were no complications related to malpositioning of catheter in either of the groups. To summarize, a reliable venous access is the cornerstone for management of patients. In the absence of a right atrial echocardiography in many centers, the right subclavian is the most cannulated vein. To avoid complications, the tip of the catheter should be outside the pericardium. The procedure needs to be performed under close cardiac monitoring and followed up by repeated chest x-rays. And finally, to conclude, despite our study being a limited scale study, the distance between the thyroid notch and the sternal angle was found to be a reliable guide while calculating the depth of catheter insertion prior to procedure. The findings of the study, if explored further, can be used as a guideline for calculating the right subclavian vein in emergency situations where we have limited access to cardiac monitoring. However, the procedure needs to be followed up by repeated chest x-rays to ascertain proper positioning of catheter. Thank you.
Now the paper is open to discussion, please.
Sir.
How do you ascertain where is the tip and what should be the this distance from the sternal notch or the clavicular point? And there are many of the persons where the this chest dimension is little bit higher side and the neck is long neck.
So we have taken standard anatomical landmarks of the thyroid notch and the sternal angle. This does not vary with the increased diameter of the chest, number one. Number two, in case of a chest deformity which is obvious before starting the procedure, we have excluded those patients. And number three, to calculate the distance between the catheter tip and the, to ascertain the position of the catheter tip, we have taken the carina, which is a radiologically identifiable landmark, as standard.
In many times, we usually many times in difficult cannulation, the standard landmark, what is the middle between the,
So the
middle
thyroid
and middle third. Many times we have to go little bit more proximal. At that time, the tip may go little bit lower and near to the RA.
Yes, sir, I accept, sir. Sir, the thing is, our study is not about the point where we are cannulating. Our study is about the distance till which we are putting in the catheter. It is not about the point we are cannulating. The anatomy at the point of cannulation may vary according to the anatomical structure of the patient. It may vary, sir. But the catheter tip has to go till a certain distance to ensure proper catheterization, sir. and avoid any complications. We have to avoid the pericardium to avoid the complications of what I have mentioned, sir, of arrhythmia or tamponade. And we have to also check that the catheter tip is not too proximal so that it may be dislodged during handling of the patient, or it may cause any thrombosis. Our study was about what depth, the length of insertion of the catheter, not at the site of insertion of the catheter.
Thank you, Dr. Rai. Thank you very much.
Thank you, sir.
Thank you. Now let me invite the last speaker of this session of this category. She is Dr. Deepti Soy from Vizag Steel Plants. Dr. Deepti Soy from Vizag Steel Plants.
दीप्ति रॉय यही वाला है
next.
कौन सा है नेक्स्ट
Full slide. हाँ, अच्छा ठीक है.
Respected chairpersons, senior delegates, a very good morning to all. I'm Dr. Deepti Soy from RINL Vizag, presenting a retrospective study of COVID-19 patients with hyperglycemia done in our Vishaka Steel General Hospital. Co-authors are my physicians. Coming to the severe acute respiratory syndrome, coronavirus 2, was seen to be having high rates of comorbidities like diabetes, new onset diabetes. This generated a notable challenge to treat our patients. So several studies have shown that diabetes is associated with a more severe form of COVID-19 and thus a significant risk factor determining the morbidity and the mortality rates. So our aim of this study was the blood glucose management in the outbreak of SARS-CoV-2, which is a crucial preventive measure for our diabetic patients relating to the adverse outcomes of COVID-19. So we studied on 779 patients from August 20 to July 21 on various factors, and the chief ones being the age, comorbidities, glycemic controls, hospitalization, restrictions, drug therapy, and many others. So all patients admitted were screened for hyperglycemia, pre-existing diabetic cases, and new onset diabetic cases were taken in the study. 180 milligram sugar in 2 readings, as according to ADA guidelines said, was defined as new onset diabetic cases. Coming to the result part, we had a high incidences of diabetes, that was 43%. And comparing to the retrospective studies, we see that studies at China and US, ours was a pretty high of 43%. And alarmingly, we had a high incidence of new onset diabetes of 31%. As compared to other studies, it ranged between 5 to 23%, and ours showed an incidence high of 31%. So the age group in our study mostly were the elderly and 50 to 60 years and above 60 years. The comorbid conditions, according to several studies, say that hypertension is the first comorbid condition. Our studies also supports the same, others being the diabetics, the cardiac diseases, and obesity, and others. Coming to the discussion part of pathophysiology of diabetes and de novo, one hand we have a pre-existing diabetes with COVID, with many mental challenges, reduced producing uncontrolled sugars. On the other hand, we have a COVID patient with beta cell dysfunction, reducing the insulin secretion and thus hyperglycemia. In the course of COVID, patients are initiated on steroid and thus to add on this, we have a stress hyperglycemia. So the management protocol, what we had for our patients, all was screened for diabetic status. Pre-existing and new onset diabetics were intensely monitored and followed up. And OHA, which patient responded, glucose were well controlled, were continued. DPP-4 inhibitor was initiated for new onset diabetes. Insulin preferred was either basal insulin or basal bolus. All patients monitored with glucometer twice a day or even more as required. Coming to the treatment part, as said, we preferred the gliptins for new onset diabetic cases as it was relatively safe in COVID conditions, and others were continued, those who were well controlled with it. Coming to the basal insulin dose, we gave in the dosage of 0.1 units per kg, and for basal bolus it was 0.2 to 0.5 units per kg, and it was accelerated as per the requirement. So treatment of COVID, we continued as per the guidelines, and hospitalization required for most of our patients was 10 days. And we had good glycemic control of 45% less than 180, 33% ranging in 200 to 300. Deaths, out of all the deaths and hard times we saw in COVID, 154 deaths in total, we had 33 deaths in hospital in diabetes. And comparing to the mortality matrix, elderly was the most affected. Our studies also said that 11% of mortality rate we had. And to sum up, I would say COVID admitted patients were diabetics 43%, de novo diabetics 31%, 56% elderly in our study group, incidence of diabetes as high as hypertension, most of them required insulin, discharged before 10 days, 53% to stress upon, had good glycemic control, and death rate was as low as 11%. So to conclude, I would say tight glucose control helps in prevents the complications of COVID-19, and the key takers for this is diabetes, a high-risk group, a bad prognostic outcome, intense regulation required. With improved management protocols, we do have a good outcome. References taken for the study. Thank you.
Thank you, Dr. Soe. Now, House is open for questionnaires and answers.
Ashwin, myself, Dr. Amit from Bokaro Shipland. I have a question that you told that de novo diabetes were found in 31% of the patient and ranging from 200 to 300 milligram of blood sugar. So after hospitalization, what is the treatment protocol? Is it controlled by insulin only, or you're with DPP-4 inhibitors?
New onset diabetes has told that they were initiated on DPP-4 inhibitors only.
So all of them responded with your DPP-4 inhibitors?
Because according to ADA guidelines also says that it is in COVID conditions, DPP-4 is of choice, because as in COVID we see the SARS-CoV-2, as said by my previous colleague, that it is seen to be binding to the AC2 receptors in the islet cells of the pancreas. So it is reducing the insulin secretion. So in that way that pathophysiology.
So they needed the lower dose of insulin as compared to the other patients.
Yes, and besides that, it has an anti-inflammatory effect. So it is decreasing the viral markers, and it is decreasing the cytokine storm, and thus reducing the severity of COVID. So it has a dual action, and moreover, it has a competitive inhibitive action.
Okay, thank you.
Okay. Thank you for the question.
Any more? Thank you, Dr. Soy. Thank you.
Thank you, sir.
Thank you all for your excellent presentation. Each one was creative and enlightening. I also thank the audience for their unwavering attention. We will now present a token of appreciation to our chairperson. To do the honors, I call upon Dr. Subodh Hiran sir, Dr. Atul Deshkar sir, and Dr. Shipra Sharma madam. on the dais.
In the meantime, I wish to thank the organizers, the authors who presented the papers within the time limits, and the participants. Thank you, and thank you, Dr. Hota.
Thank you, sir. I please request the jury. Thank you all. I now request our chairpersons, Dr. B.K. Hota sir and Dr. S.J. Rizvi sir, to felicitate our jury. Dr. Atul Deshkar. Dr. Subodhiran sir, Dr. Shipra ma'am, thank you all for volunteering your time and wisdom for this presentation. I request the participants of the poster presentation to please ascend to the dining hall to display their posters and to contact Dr. Benta and Dr. Samir. I request the audience to please announce their name and the steel plants before they ask for any questions. Starting. I request the audience to please maintain silence so that we can all hear the presentations clearly. Thank you, please. After having been heavily shaken by the COVID pandemic, we are now ready to face the long COVID syndrome. This is a great challenge which the entire medical fraternity is facing, from chest physician to the neurologist, to the cardiologist, to the psychiatrist, and to the dermatologist. We now have a panel discussion on approach to long COVID syndrome. There are 7 participants in this discussion. Each participant will be getting 8 minutes. They will be speaking on vascular, neurological, psychological, pulmonary, and dermatological complications, followed by a discussion of 20 minutes. To chair this session, I invite Dr. Malini Ji, former Director, JLNHRC Bhilai, Dr. Jayesh Kumar Dave sir, former Joint Director, JLNHRC Bhilai. Please, ma'am, please, sir. I also call upon our moderator, Dr. Naveen Kumar, General Manager, Visakhapatnam Steel Plant. I request you to please take the I request the chairpersons to please start the session. Thank you.
Good morning, everybody. It's a real pleasure to meet all of you after a gap of 3 years. We all had faced the acute wave of COVID. Now, the after effects are still with us, and we all are facing the long COVID syndrome now. So, to learn more about it and to get more knowledge, today let's start the panel discussion with Dr. Naveen Kumar being the moderator. And I think it's going to be a very long session, so let's not waste time. And if Dr. Dave would like to say something.
we won't like to remember those hard times which we all had, SAIL hospitals cumulatively during COVID times. And now it is time to realize, analyze, and learn from the long-term effects of COVID. So without going into nitty-gritty, let us hand over to Dr. Naveen Kumar.
Moderator slides. They're not coming there? Good morning, everybody. After that very interesting session on MBBS papers, we are now come to the panel discussion. Respected chairpersons and my dear delegates. Well, a slight change in the way we are going to present this, because there's going to be a panel discussion. I asked all my panelists to talk about 5 minutes, and then we have enough time for asking questions. And I request the organizers to please go around and collect the questions and give it to me so that we can have an interesting discussion as such. So we all know, I welcome you to this panel discussion. And we all know that, as Madam has rightly said, that the COVID pandemic was like a bolt from the blue. But what followed was more debilitating and more, more problematic, because the host of symptoms that have been reported in the press, and so nobody had a clue as to what it was. So finally, when we came on to it, a lot of synonyms have been given to all these symptoms, such as long COVID, long haul, post-acute COVID, and so on and so forth, and people talked about chronic COVID. But it was not very long before the WHO woke up and gave us a definition saying that long COVID is defined as a term used to refer to persistence of symptoms beyond 3 months of infection, and those symptoms should stay at least for 2 months and should not be explained by any other illnesses, a tall order. Because if you look at the differential diagnosis in all these patients, they are numerous. So in order to exclude all these differential diagnoses, it's really hectic, and the physician is facing a very big problem in this aspect. If you look at any studies which have been done all the world over, the number of symptoms that these patients have, and this is one study we am quoting, where 73% of the patients had one symptom more than 6 months post-COVID. And mind you, these are only a few symptoms which I am depicting here. My panelists would come along with their respective organs which have been affected and the way the symptoms have evolved. In addition to what we have, the long COVID, it's a challenge, because it's not only the physical symptoms, the functional impairment, the neuropsychiatric symptoms, and the situational overlay is all we're going to talk about. So what are the factors that can affect the long COVID? The female sex is supposed to be more affected. The more elder, the more the symptoms. The more severity of the initial COVID-19 illness, it's more affected. Because if you look at the incidence, most of the studies said about 10%. We had 685 million with COVID, so about 65 million people have long COVID. And mind you, if the data around the world is put into a meta-analysis, 10 to 20% has occurred in non-hospitalized patients, whereas 50 to 80% of these symptoms occurred in hospitalized patients. And the icing on the cake is, all vaccinated people had less amount of long COVID. So that's the take-home message. So it's not being fully vaccinated against COVID-19 is again another factor. As the variants evolved, the incidence of long COVID came down. And of course, as we've been talking all the way over, comorbidities play a very big role as far as long COVID is concerned. So if you look at the studies, they were as less as 7% in a study in China to as high as 79% in a study in Germany. And these are all the factors. If you're looking at the healthcare workers, it's high. If you go into the community, it is less. If you look at the vaccinated, it is less. The socio-demographic factor, a lot of factors are there when you take the long COVID symptoms. Coming to the organ that is affected, you cannot say no organ is being spared. So COVID is such a severe illness that all the organs in the body has been affected. If you look at the pathophysiology, still things are evolving. But what we have got as far as pathophysiology is concerned is reactivation of the virus. And so what is that? The symptoms occur again. Another important factor is the immune cells release high levels of inflammatory cytokines. And so that's what is known as the immunity part of it. And the best part of it is developing autoantibodies. So that's the reason why most of the chronic fatigue syndromes, the myalgia, encephalitis, are all been a very important parameters as far as long COVID is concerned. To summarize, I wouldn't like to go into the pathophysiology because it will take me 1 hour. These are the principal factors, the immune dysregulation. Mind you, the microbiota is coming up. The dysbiosis in the microbiota is a big thing which is coming up now, and the treatment modalities are evolving around this. Autoimmunity and immune, and we all know that the blood clotting factors and endothelial dysfunction is the principal factor for the thrombosis which occurs in all these patients, and of course the dysfunctional neurological signaling which can occur in these patients. So this is one gut biota axis which is really interesting. This is for the tomorrow. So having said that, did we achieve what we want? The symptoms are not defined. It can be varied. Serial comprehensive reviews of systems and physical exams is what is required. And finally, at the end of the day, I see a lot we do not understand. I tried to do it for the last 3 months, but still things are evolving, and I couldn't come to a conclusion. So what we need to do is we need to show a lot of empathy towards patients and address them in a proper way. Thank you very much. And so I call upon my first speaker of today, Dr. Anil Agrawal, who's going to talk about the cardiovascular complications as far as long COVID is concerned.
I would request delegates on flanks to kindly sit in the hall and have proceeding in a smoother way. This is a wonderful session. Please come and have your seats.
ये है ना, ये है डाउन है कि ऊपर ये वाला. Respected chairpersons, my moderator Dr. Naveen, seniors and dear delegates, a good morning to each and all. And on this panel discussion on long COVID syndrome, I will be presenting on the vascular complications. So the definition has already been done by Dr. Naveen. So I would directly go to the vascular complications, which can be arterial complications presenting as transient ischemic attacks, strokes, limb ischemia or mesenteric ischemia. They can be in the form of venous complications presenting as venous thromboembolic, pulmonary embolism, deep venous thrombosis, platelet disorders presenting as immune-mediated thrombocytopenia, and cardiovascular complications presenting as inflammatory heart disease, pericarditis, myocarditis, ischemic heart diseases, various forms of arrhythmias, and other dreaded complications like heart failure, cardiogenic shock, cardiac arrest, sudden cardiac death. Point to be noted here is these conditions do not occur in isolation. They frequently overlap, and patients may experience any combinations of these symptoms. So coming to the symptoms of long COVID, they may be the old COVID coming or carrying forward from the short COVID or the acute phase of the illness, or there may be appearance of new symptoms which may be related to the complication of COVID per se, complications related to the comorbidities, complications related to treatment, or other non-specific effects of hospitalization or even anxiety symptoms. Fatigue, pain, fever remains the generalized symptoms of long COVID, and there may be other symptoms related to the different organs involved. I will be talking about the cardiovascular one, and approximately 1 in 10 people testing positive for COVID exhibit long COVID symptoms. Chest pain, dyspnea, palpitations remain the most common symptoms, and these symptoms can range from mild to incapacitating forms. More common among hospitalized patients with a hazard ratio of 1.8. There have been reported increased incidence within 12 months of infection as compared to controls of various cerebrovascular disorders, various forms of dysrhythmias or arrhythmias, ischemic or non-ischemic heart disease, heart failure, thromboembolic phenomena. The risk is evident regardless of the age, race, sex, and other cardiovascular risk factors. There can be autonomic dysfunction, which can lead to a condition known as POTS, postural orthostatic tachycardia syndrome, defined as a heart rate increase of more than 30 beats per minute, more than 40 beats per minute in children aged 12 to 19 years, within 10 minutes of standing up and without significant hypotension. Patients experience chronic orthostatic tachycardia in such cases. evidence of brain fog, severe chronic fatigue. This condition, although not recognized frequently, but reported in the literature to having an incidence of almost 2 to 14% of long COVID cases. These are various articles depicting about the long COVID cardiovascular outcomes, and we all have come across so many articles in so many journals over the last 2 years. Pathophysiology has already been talked about by Dr. Naveen, and it revolves around 4 important things like the autoimmune response, persistent viremia, organ damage, and development of microclots. It is a very complex mechanism, and pathophysiology, taking into account the direct virus invasion, systemic inflammation, regulation of autoimmunity reactivity, cytokine storm, DIC, formation of DIC, and leading to the long COVID conditions having increased cardiovascular demand, the systolic or diastolic dysfunction, atrial fibrillation, so on and so forth. So once we know what is long COVID and the cardiovascular complications, so how do we assess such patients? A proper history taking is very important as regards any other condition, and we need to review the predisposing comorbidities of coronary artery disease or diabetes, prior cardiovascular events. The severity during the acute COVID illness is very important to be noted, and a proper history needs to be taken, whether it was a mild, moderate, severe, any history of hospitalization, any history of ICU care, need for ventilator, need for ECMO, and the timeline of system evolution. Most common new or worsening cardiac symptoms need to be noted. The tests conducted to date, the laboratory investigation, any ECGs, echocardiogram, chest radiography, and medication history, proper medication history. Symptoms should be characterized to understand the contributing factors that limit activity, that includes the onset, the frequency, intensity, aggravating, and relevant elevating factors. Having taken a proper history, the clinician should conduct a thorough examination of the cardiovascular system, including the heart rate, blood pressure, oximetry, auscultation, peripheral pulses, brew, and signs of volume overload. For individuals reporting dizziness, lightheadedness, differentiation between central or peripheral etiologies needs to be taken care of. And again, the differentiation between the cardiovascular from autonomic dysfunction and isolating the cases of POTS needs to be done. So treatment recommendation, we all know the importance of patient education, the importance of reassurance in such cases, along with recommendation for lifestyle modifications, diet or nutrition care, activity limitations, exercise, medication, risk factors, the management on risk factors for cardiovascular diseases, like to name a few: dyslipidemia, diabetes, hypertension, tobacco use, depression. And then comes the role of pharmacological treatment in the form of symptomatic treatment, VT prophylaxis, and on clinical establishment, the role of oral anticoagulants, and the statins, need for statins for protection of endothelium. For individuals diagnosed with new or worse arrhythmias, structural heart disease, evaluation and management in conjunction with a cardiologist needs to be done. And individuals with a recent history of cardiac events or diagnosis, they need to be identified and should be referred for proper cardiac rehabilitation. So to summarize, cardiovascular symptoms and conditions are common in COVID-19 and may persist in individuals with long COVID. A thorough evaluation for risk factors and the presence of pre-existing or new cardiovascular disease is recommended. Management includes lifestyle changes, risk factor modification, cardiovascular disease management, and proper cardiac rehabilitation when indicated. Healthcare disparities impact outcome of individuals with long COVID and cardiovascular conditions and must be sought and managed appropriately. Thank you.
Thank you, Dr. Anil Agrawal. That was a tall order because you have been both cardiovascular and the vascular complications. But like Shubham Gill of India, you went through it very quickly. Thank you. Well, we all know that the cardiovascular complications are very, very important, especially the POTS, that is the positional orthostatic tachycardia, and the cardiomyopathies and the other factors which he has rightly touched upon. Well, if people still have some problems, then they need to really look at further investigations in the form of MRI or SPECT, and especially the tachycardia should be done by the Holter monitoring and new modalities which are coming up to assess, because tachycardia is a very important symptom with which long COVID patients come to us, and most of them are being referred to the psychiatric patients because we couldn't get a cause. But evaluation is very, very important, and then though rightly said by Dr. Anil, that they should be referred to a cardiologist for further evaluation before we say that it is definitely not organic. And especially the rehabilitation of patients, because you find more of right ventricular dysfunction in long COVID rather than left ventricular dysfunction. And finally, you have what is known as structural disease, especially the athletes. And the high profile person who are dropping dead today is because the myocarditis or pericarditis is still there. And so that's the reason why these people are falling dead. And MRI is a structural abnormality, can be definitely detected in them. So we'll have more questions down the line. I call upon now Dr. Reyaz Ahmed to deal with the neurological complications. Being a neurologist by profession, I think it would be very apt for him to look at the various neurological sequelae that can occur with long COVID. Reyaz, please.
A very good morning, respected chairperson, seniors and delegates. Sorry, I have a sore throat. So now I will just give a brief overview about the long COVID, what is the long COVID syndrome related to the neurological part of that long COVID, because it's not possible to accumulate all the things in 8-minute intervals. So looking to the what is the long term, what is the long COVID? It is a long term clinical residue that followed the COVID-19 infections. That part the clinical symptoms that persist the beyond of the resolving of the acute COVID-19 infections. So in different study, they have the prevalence is different. So in the mild to moderate infection, the prevalence rate is about 10 to 40%, while those hospitalized, the incidence is about 80%. So, which each COVID-19 waves, there is a wane in the long COVID. So, initially it was 48% in the wave 1 and 36% in the 2 and 17% in the subsequently came down to the 70% in wave 3. So, this is a multi-system disorder that involves the pulmonary, cardiovascular, endocrine, hematological, renal and gastrointestinal and dermatological psychiatry, lots of systems are involved. So, in the central nervous system and peripheral nervous system is seen in the more than 1/3 of the patients. So, the pathophysiology, there is a, since there is a robust neuropathological data is not available and there is no biomarkers to what is the pathogenesis, there is some postulation about the pathophysiology, that is aberrant immunological response, endotheliopathy that causes the blood-brain barrier dysfunction that lead to the infected leukocyte into the central nervous system. There is a coagulopathy that lead to the thrombosis of the small vessels that causes ischemic hypoxic neural injury and metabolic derangement. All of these lead to the oxidative stress cascade and cellular apoptosis that propagate the symptoms of the long COVID. So now coming to the complications, the most frequently complications which is encountering the day-to-day practice in the neurology are the fatigue is the most common, then the brain fog, headache, sleep disorder, mood disorder, persistent taste and smell disorder, myalgia, sensory motor deficit, dysautonomia and vertigo. Other less common complications are also seen like the cerebrovascular disease. All of you know that the stroke per se is a very thrombotic disorder and the lots of cases of the stroke and the TIA were seen during the acute infection. But after the recovery of the acute 19 infection, there is also risk of 50% in the first year of the after the recovery from the COVID-19. Other complications like the epileptic seizure, myelitis, GBS, cranial dysfunction also seen, and the one rare case of the autoimmune encephalomyelitis reported 3 months after the COVID-19 infections. So how to approach these patients? Since there is no accepted operational definition for the diagnosis of the long COVID, so as the definition laid down by the WHO, and but there is a various study have we shown that the 3 months after the 4 months of the long COVID, we call the long COVID. Some studies said 2 months and 4 weeks. Some say the 100 days. So the presence of symptoms, sign and abnormal findings that persist beyond the resolution of the acute COVID-19 infection and that do not return to the pre-morbid baseline. and that cannot be explained by any other diagnosis that has been taken as the definition for the long COVID syndromes. So now coming to the most common part, and the most common complication is the fatigue. In the different cohort study, the fatigue has been seen about 13 to 87%, and the fatigue is similar to that what is seen in the chronic fatigue syndrome. The newer terminology now has been opted as the myalgic encephalomyelitis. So there is some difference in the fatigue part of the long COVID and then the chronic fatigue syndrome. That is, there is a loss of taste and smell, cardiac dysarrhythmia, shortness of breath, memory dysfunctions are more commonly seen in the fatigue associated with the long COVID. So the management, how to mitigate the fatigue. So basically it resolves most of the patient, but may be persist in some individual and that be profound. So the management part consists of adequate rest, good sleep hygiene, specific fatigue management strategies like 4P, which include the planning, pacing, prioritizing, and the positioning. And this is based on identifying the level of the activity the patient is comfortable, and we slowly escalate and titrate the exercise so patient can tolerate that. And these all are supervised program to improve the endurance and reduce the fatigue and dyspnea. There is a very insufficient evidence regarding a specific nutritional supplement, any specific pharmacological treatments. So another complication, the alter taste and smells. As we all know that there is an anosmia is there in the acute COVID infection. In the most of the patient, it dissolves in 1 to 3 months, but in the less than 5% of patient, it persists. And there is some prognostic marker like the hyposmia, and the male patient recover more rapidly than the anosmia, and female patients.
Dr. Niwas, please continue.
Myalgia, muscle weakness and neuropathy, these are the muscle pain and weakness all be reported in the patient that persist for the 6 months. The headache, it is seen the 44% of COVID-19 infection. We have to basically rule out the secondary causes of the headache, and treatment consists of the tension type of headache like the amitriptyline drug of choice. So brain fog, this is the condition which the patient feel mentally sluggish and fuzzy, lack of mental clarity, difficulty in focus. We have to look for the other condition that causes the brain fog, like the lack of sleep and increased stress, dementia, medication, hypothyroidism, multiple sclerosis, B12 deficiency. And the management part consists of enough sleep, try new things, avoid multitasking, work on memory, socially active meditation, regular exercise, avoid alcohol and drugs, and appropriate treatment like thyroid and the B12 deficiency. That's, thank you.
You went through the neurological complications very well, and in fact what we're talking about is the chronic fatigue syndrome, and patients who have the myalgic encephalomyelitis is one of the primary conditions, and you have a lot of conditions which can affect the peripheral nervous system as far as long COVID is concerned. And we all know that the ACE inhibitors in the brain, principally across the posterior cingulate gyrus, the hippocampus, are responsible for most of the symptoms that can occur in neurological manifestations of long COVID. We move on to the next speaker. We have Dr. Trinath Das from Bhilai Steel Plant. Okay. So I call upon Dr. Sanjay Acharya, a psychiatrist and who's at Rourkela Steel Plant, and he's in charge of the mental health, and he has several publications in national, international, and is a PhD student guide. So very apt for him to talk about the psychological aspects, because these are the untermed ones as far as the symptoms are concerned, as far as long COVID is concerned. Dr. Sanjay Acharya, please.
Good morning to everybody, and as well as my august audience. So all have been explained very beautiful by Dr. Naveen and Dr. Anil. So I'm not going to be elaborative on long COVID. Okay, coming to introduction, that has been also explained very nicely. This is pandemic, and this invisible war we have fought. Everybody has fought. And the economicity of living of isolation, change in daily lives, job loss, financial hardship, all these accumulated together and bring some mental changes, some psychological impact in our mind that we have faced. And it will not be exaggerated to say that there is a hike in 18 to 20% of the mental health patient in all over India. And Global scenarios is much more. Okay, there are some factors which decides, that is proximal factor, distal factor, protective factor, and outcomes. Okay, so in proximal factors, family issues, violence, stigma, any health precondition, economic crisis, all these things have some effect on the mental health. And distal factors like fear of infection, work pressure, information overdose. When it comes to our domain and when we suffer, we all are ignorant what it is going to do. Lot of speculation were there. That's why we suffered a lot. So there was also some protective factor, like our in amalgamation of our cultural staying in this India, that is Western style of living and thinking of Hindu way of, that gives little bit of anxiety and stress. Positive thinking, spirituality, family support, and community support, these are the protective factors we found in our community. And what is the outcome? Maybe a poor mental health, maybe a good mental health. So various psychological problems and important consequences in terms of mental health, including stress, anxiety, depression, frustration, and uncertainty during the COVID-19 outbreak progressively. Okay. So what is the aspecific and uncontrolled fear, pervasive thinking, this frustration, dissolving loneliness, this come to decrease our subjective well-beingness. What we feel every day, this mental well-being, that has been down. So with support of resilience and social support, we have significant lifestyle changes and profound adaptation. First thing, the thing I want to convey over here is that we have little bit of adaptation of this long COVID syndrome, and we have some mental health and some energy in our mind to face these situations. Inadequate supplies, inadequate information, and alexithmic traits thus give rise to some psychological problems. Mental health infrastructure and challenges. In India, 10% of the population has common mental health disorder, 1.9% of the population suffers from severe mental disorders. And look at this pictorial diagram, how this installation of hope, reading, music, online courses, indoors play and relaxation, yoga, meditation, aerobic exercise have some positive impact in our lifestyle. And schizophrenia, bipolar disorder, depression, anxiety, psychosis, phobia, suicide, mood disorders, all psychiatric illness that has been also increased. Risk factors of suicides. Okay, suicide is not so common, but whenever there was a panic inside the mind and anxiety, depression was overloaded, so there might be risk factors. Talking about these risk factors, percentage of people experiencing moderate to severe symptoms of depression, that is from July 2019 to March 20, and in June 20, it is seen that 16 to 13 years, they're very high, this red one. And among 40 to 70 years, it is about 14%. Change in behavior, sleep pattern, eating habits, erratic behavior, harming self and others, low self-esteem, including feeling of worthlessness, guilt, and self-hatredness, as well as hopelessness also. And no hope for the future, believing things never will get better than nothing will change. That was the effect, mental health effect seen in the mind of the people, those who are visiting the hospitals. What are the psychological effects on children? So we will start from children. Children are likely experiencing worry, anxiety, fear, and fear of dying. That is the greatest trauma they used to experience in their home and outside and isolation. The schools have closed, and part of necessary measure then children may not no longer have to sense of structure, and they have less opportunity with their friends and get social support or essential good mental well-being, because e-connection was there, e-life was there. Now I face a lot of students and lot of children coming with internet addiction. Like other addiction of cannabis, alcohol, marijuana, whatever it may be, so internet addiction is there and is profoundly seen in clinical practices. Risk factor in suicide COVID-19. What are the risk factors there? Talking about the dying and harming himself. Suppose these risk factor you can able to see in some cases, you should be very cautious for that patient also. Recent loss through death, divorce, separation, and loss of interest in the friends, hobbies, and activity I'm previously enjoyed, and he or she maybe prefers to stay alone. Change in behavior, sleep pattern, eating habits, erratic behavior, harming self and others. Low self-esteem, including feeling of worthlessness, guilt, and self-hatred. No hope for the future. This is very important point. No hope for the future. Because in this invisible war, we do not know nothing. Even people are there, they used to take lot of booster doses, and even from anti-helminthic drugs to what not we have consumed. Even hydroxychloroquine. Yes, it is a treatment for that. You think of what are the mental pressure for the sufferers and the people, those who are staying or those who are fighting with this war. No hope for the future, believing things to be never get better than nothing will change. What are the psychological effects in children? So over here I have spelled a word called NEET. That is not medical examination. No education, no employment, and no training. Just isolated and stay inside the home. So children have suffered a lot with this. And I think time is 8 minutes. 8 minutes, okay. So what are the psychological effects in COVID-19? I just switch over speedily. Mental health problem impact on youth. On youth, it is seen that the Herculean force is acting very extensively, and the extensive Indian population, which comprises of youth and all ages, has psychological resilience to isolation and contact transmission. So that is a study called Red Cross study. So I am not going detail about this study. I will tell the result and conclusion. Conclusion, our findings suggest that requirement of psychological intervention targeting youth, living rural areas, especially women, and government schemes irrespective of educational status. What happened in this study, they have seen that the rural area female are much more affected by this news spread. Then this is the abstract and aims of the study. This is a pressing major need for planning longitudinal and developmental studies should be there. Only 67 cases we have gone through it. And what is the psychological for elderly? This picture explains details. This is glucose resistance increase to glucose level, that is hyperactivation of the HP axis. How to help yourself and others, reduce limit of exposure to media coverage and pandemic. To conclude, the current global pandemic situation necessitates the multi-pronged approach towards the healthcare delivery. It needs holistic delivery model to take the cognizance of the multidimensional, physical, mental, social, spiritual. All have been covered by my previous speakers. And public health system must be strengthened to face the future consequences. Because in aspect of healthcare delivery, in making the workforce to more responsive and prepared to handle the burden of pandemic. How to help you and your others? Psychological impact on it. Sorry, I think I pressed wrong button. To conclude, I have said, thank you.
Thank you, Dr. Sanjay Acharya. That was, you have covered everything, including the children, the elderly, and the general population. So it's been very aptly addressed that the psychological aspects are very important in the management of long COVID. And in fact, a lot of studies have clearly showed, especially the addiction to the internet has been addressed as severe as drinking addiction. So a US study has stated that. And a lot of biomarkers are coming up as far as psychological aspects are concerned, because what they found was it is because of the thinning of the gray matter in the brain, which is responsible for most of these psychological factors. So then we go on to Dr. Srinath Das, please, from Bhilai Steel Plant. Is going to talk about the pulmonary complications. And being a person from the respiratory medicine, I think he would delve into the pulmonary complications in a very appropriate way. Over to Dr. Srinath Das.
Very good morning, respected chairpersons, moderator Dr. Naveen, my seniors and friends. In COVID pandemic, all our primary resources were focused on to control the spread of the disease and treatment of the patients. But as the cohort of survivors expanded, it's now realized that a parallel epidemic of post-COVID or long COVID is fast emerging. So this term has been first coined by Dr. Eliza from London in her tweet as hashtag to denote the persistence of symptoms months after initial COVID infection. So I will discuss this topic under those timelines. It's purely evidence-based, definition and classifications, pathophysiology, presentation in particular the pulmonary sequelae, and what are the roadblocks for the diagnosis of long COVID, and management of long COVID, and few take-home messages. So already it's discussed, long COVID is divided into post-acute COVID and chronic COVID. Post-acute COVID from 3 weeks to 12 weeks, chronic COVID is beyond 12 weeks. Combined together, it's known as long COVID. So the global consensus or definition is it's a constellation of physical and mental well-being clusters that symptoms during or after the COVID. And it continues to for more than 2 months have an impact on the patient's life. It's not explained by alternative diagnosis. So the pathophysiologies, exactly it's not yet identified, but various proposed pathophysiologies are sequelae of organ damage, chronic inflammation, sequelae of chronic critical illness, and post-intensive care syndrome. So WHO and the European Observatory has issued a statement that about 5 to 20% of the patients will have symptoms lasting for over more than 4 weeks. So summary of the key studies that has been depicted as the fatigue is the most common symptom, followed by dyspnea and cough. So coming to in particular the pulmonary sequelae, the persistent dyspnea is the most common, that is about 43% of the symptoms. Residual radiological changes in the form of ground glass opacity and fibrosis about 71%. Impairment of the pulmonary function, that is decreased DLCO, is about 47%. So what are the roadblocks in approach to the long COVID? The testing policy differs from countries to countries. It's a common practice during the pandemic to diagnose clinically based on symptoms rather than a confirmatory test. The persistence of symptoms in those who have never checked COVID is a challenge. There are false negative reports. Antibody response to infection also varies, as 20% do not seroconvert. Antibody levels decrease over the time, leading to difficulty in retrospective diagnosis of recent infection. So who are those high-risk group for going for long COVID? Age more than 60 years, smoker, comorbidities, diabetes, hypertension, coronary artery disease. It has been said that the more the number of the comorbidities, higher is the risk. Pre-existing respiratory illness like asthma, COPD, ILD, and those who require oxygen therapy at home, and those who require mechanical ventilation and NIV during acute COVID illness. So how to evaluate these patients? Patient comes with shortness of breath and cough, history detailed examination, SpO2 at rest and post-exertion, 6-minute walk test, get a chest X-ray done. If SpO2 is less than 94% at rest, or there is a fall in more than 4%, that is about 90% during 6-minute walk test, get an or abnormal chest X-ray, or grade 3 or grade 4 MMRC dyspnea, get a compression, get HRCT and blood gas and spirometry as clinically indicated. A compression ultrasonography, CTPA, if high index of pulmonary embolism is there. So coming to treatment, it involves the specific pathology conditions like post-COVID diffuse lung disease, pulmonary embolism, pulmonary infections. It also involves the management of respiratory symptoms. So coming first to post-COVID diffuse lung disease, it may represent either a persistent inflammatory pathology or pulmonary fibrosis. HRCT chest may detect the extent and type of the such abnormalities. There is no conclusive specific evidence to guide the treatment of those abnormalities. Studies have shown that the abnormalities persist, abnormalities resolve spontaneously without any specific treatment. It is recommended that about 20 to 30 milligrams of prednisolone at discharge and tapering it on follow-up depending on the patient's response. The role of antifibrotics, it's not clear. The choice of which drug, whether pirfenidone and nintedanib, still not clear. Those antifibrotics usually take about 1 to 3 months to demonstrate their clinical effect. And this has been proved by different studies. Role of antifibrotics reserved for particular some group of patients like severe ARDS, those who require prolonged ventilation with high oxygen requirements, those who demonstrate radiological evidence of progression of fibrosis. It has been suggested that antifibrotics should be used with steroid as they have a synergistic effect. Coming to the pulmonary embolism, therapeutic anticoagulation should be administered to the patients. The minimum duration is about 3 months. Prolongation beyond this period depend on the assessment of risk of relapse. Prophylactic anticoagulation is generally stopped at the time of discharge from the hospital, may be continued as per clinical requirement under careful supervision. Pulmonary infections should be managed according to standard antibiotic protocol. As there is a history of contact with the healthcare facilities, there is a higher chance of resistant microbes. Fungal infections like mucormycosis should be ruled out in case of fever, sputum, hemoptysis. Cough should be managed with simple antitussive agents like dextromethorphan, gabapentin, and pregabalin also has been used. In case of wheeze, inhaled bronchodilators without inhaled corticosteroids can be used. Cough due to GERD, anti-reflux medications can be used. In case of post-nasal drip breathing, antihistaminic agents can be used. Breathlessness, domiciliary oxygen, if SpO2 is less than 90%, pulmonary rehabilitation, breathing exercise may help to reduce the breathlessness. Pulmonary rehabilitations, optimum exercise sessions are of 30 to 45 minutes for at least 2 to 3 weeks, 2 to 3 times per week for at least 8 to 12 weeks. If done at home, the video conferencing may be useful. It has been asked us whether the vaccines are safe in long COVID. Yes, absolutely they are safe. They are not associated with the worsening of the long COVID symptoms, and they should receive the vaccination as suggested by the national guidance. It has been seen that healthcare workers, those who have taken 2 to 3 doses of vaccines, were associated with the lower long COVID syndromes. The Indian Chess Society has come up with a follow-up toolkit by collecting the data. The data can be virtual or in person, and it has been suggested that they should be followed up for at least 36 months after the discharge. So my few take-home messages: the pulmonary manifestations are common in those who have recovered from COVID. Long COVID manifestations can be varied from mild to more severe. That means mild COVID may go for long COVID, and severe COVID may not go for long COVID. Need to strengthen the pulmonary rehabilitations. Role of antifibrotics, steroids, extended anticoagulants should remain the research priority. Data collection for PC post-COVID ILD registry is to be maintained. Thank you. Thank you for the patient listening.
Thank you. That was a very lucid presentation. You have talked about how the breathlessness should be looked into, the cough, and how the various agents should be given. In fact, most of the studies have said that the interstitial lung disease is progressive, and hence you need to be very careful as to when you start drugs and when you stop them. And the structured rehabilitation program is the mainstay as far as the respiratory complications are concerned. Thank you very much, Dr. Das. May we have the last speaker for the day in this panel, Dr. Bharat Kumar from Bhadravati. So he's going to talk about the dermatological complications.
Just button. Just here button, which button? Just. No, pointer. Left. The big one. Good morning to respected chairperson, moderator, and dear colleague, delegates. My topic is that COVID and dermatological complication. During COVID, there are many dermatological complications. Commonly, we are come across our practice, our clinical, urticarial rashes, maculopapular, papillovascular, papular and nodular, and reactivation of viral and oral dermatitis, and severe hair loss and dermatological infection. The urticarial rashes term is a transient eruption of circumcised edematous occurring especially in knee joints and flexors. maculopapular rashes, a allergic reaction or infection. It is most commonly caused by infection. May appear both flat and raised lesions and erythematous. Papillovascular exanthemat reaction, it appears like a varicella zoster, but anyway it is a virus. COVID is also virus. That features appears to be like varicella zoster. Tailbines. And also commonly we have come across purpuric vasculitic pattern and nodular lesions, especially joints, palm and soles, associated with severe pain. Reactivation of virus infection, herpes simplex, herpes zoster, and viral exanthematous. And also very commonly we are complaining about oral dermatitis, oral thrush, severe irritation, redness, and plaques and fissures. And most common among dermatology practitioners facing severe hair fall, especially from females, associated with severe itching and scales and also secondary infection. And most common again is sudden appearance of dermatophyte infection, exacerbation, and unusual sites, and very difficult to treat both hair loss and dermatophyte infection during COVID period. The severity among all complaints, almost all are treated with mild corticosteroid and routine antihistamines. The conclusion, what may be the common dermatological complication means the COVID affects our normal function of the body system and also immunity decreases. So this leads to the many complications. And also people follow different types of treatment. Single treatment, combination, allopathic, Ayurvedic, self-medication. All these leads to the immunity decrease and unwanted chemical reaction happen in our body, leads to the so many problems. Many other complications also affect the skin. Means that signs and symptoms come across through skin. This is the problem during COVID period. Thank you.
Thank you, Dr. Bharat. May I have all my panelists on stage, please? So I would like to thank all the panelists for doing an excellent job in taking us to this thing. So before the audience come up with questions, I have a few questions to ask them pertinently. The first question I would like to ask Dr. Riaz. See, dysautonomia is very much related to the central nervous system, and this is a very important factor as far as management is concerned. I would like you to briefly talk on how you go about it, how do you identify it?
Thank you, sir. Actually, dysautonomia, the cases has been reported in the post-COVID. The symptom consists of mainly to the involvement of the unmyelinated and thinly myelinated fibers. So, if there is involvement of the autonomic nervous system, there is the standing, there is a fall in the BP, dizziness, that exacerbate the symptom of the fatigue, and other system to be looked into like the gastrointestinal symptoms, early satiety, vomitings, sexual symptoms, erection problem, and there is like sweating problem, anhydrosis, hyperhidrosis. Along with that, there is an involvement of the small fiber neuropathy occur with that because all the fibers, the autonomic systems, and the thinly myelinated fibers carry the pain receptors. So there is involvement of also the small fibers. So there is a patient, most of the patient also have the symptoms of the small fiber like the severe burning pains, like in the distal part of the arm. So all of these are associated with the dysautonomias. So management, coming to the diagnosis part, the central nervous, the neurological parts, we do the sympathetic scan response to look for the involvement of the nervous systems and the small fibers. There is no direct way to verify the involvement of the small fibers. There is indirect assessment. We do the sympathetic response. We apply the sensation, the nerve stimulation to the one median nerve to the one hand, and then we record the gain from the second hand. And we there look for their involvement with the nervous system is not, mainly the small fibers. The other part of the autonomic system, we take the help of the cardiologists who do the Valsalva test and like that table test to confirm the involvement of the autonomic systems.
Thank you, Dr. Ayaz. In fact, the take-home message from this is the peripheral nervous system, especially the autonomic nervous system, would be involved to a greater extent. So you need to do all the autonomic nervous system tests before you say that these patients are not having any pathological problem. And as dysesthesias, neuralgias, a lot of people come with that. Please do not pass them off. They're all part of long COVID, and you need to look at the cause and identify them accordingly. So the next question I would like to ask Dr. Trinath Dash. We have a lot of patients who come to us with recurrent chest pain. Now, the chest pain is the biggest problem. From a pulmonological point of view, what are the factors which we should exclude before we pass it on to the cardiologist?
Thank you, sir. The chest pain, in particular for the pulmonary point of view, basically it could be of pleuritic chest pain, it could be of substernal in location, it could be of the location may be before, above the diaphragm. The chest pain may be of, for cardiovascular causes, we have to rule out all cardiac causes like pericarditis, myocarditis, and angina, both as ST elevation MI and non-ST elevation MI. For pulmonary part, we have to have basically look for any pneumothorax or any pleurisy or ventilator associated any pneumothorax, something like that. For that matter, you have to go for chest pain, even to the extent pulmonary embolism can also be a definitive doubt. For that, you have to go for all serum test of like D-dimer and pro-BNP, then go for HRCT test, then go for even pulmonary embolism, you go for CT pulmonary angiography.
Very rightly said. I think the thing is the markers, the troponins, the D-dimers, then you go on to the investigations, and lastly, you please don't forget the computerized tomographic angiography because of the thrombotic and vascular complications. Thank you very much. Dr. Sanjay Acharya, your talk was very lucid, but the pandemic has shown a lot of misinformation, reinformation, a lot of unwanted information which has created a lot of stress on individuals. On top of that, as you rightly said, there's been a death in the family, the financial instability, working from home. So all this has led to what is known as the post-traumatic stress disorder, which is a big component right now. How do you address it?
Okay, sir. This post-traumatic stress disorder, it is a part of anxiety disorder which involves SP axis as well as sympathetic and parasympathetic nerve system. But I will differ in this case, post-traumatic disorder, stress disorder. What happens? There is a trauma. This is also a trauma due to natural calamity or whatever it may be. there should be, in case of post-traumatic stress disorder, there should be a nightmare. And whenever you remember the issues or event, what happened to you or what happened to your family, then you develop some anxiety symptoms. There is a convulsive episode. All these things are seen in case of post-traumatic stress disorder. What we found in this long COVID syndrome, I mentioned that 18% hike in the mental health patient, they usually present with depression, anxiety, and those who are having another psychiatric morbidities like schizophrenia, bipolar, and other comorbidities, they are accelerated like anything. In case of post-traumatic stress disorder, if there is remembrance, usually when patient remember or individual remember the event, what happened, and the traumatic stage he has or she has continued or faced or experienced, then this anxiety will become and they will be very panic. There is hyperactivation of this anxiety system like increased heart rate, palpitation, dry mouth, decreased energy and restlessness, insomnia, all these things will be seen. And it comes off and on when you remember that issue, even during sleeping time also. What my colleagues explained beautiful way, like the chest pain and all the things. Again, I want to tell that before sending to psychiatry is the last, and history and history and history. Yes, it has a very great importance for diagnosis.
Thank you. You rightly brought it out that we need to really investigate before we pass it on. But I think he has rightly put it. They also do their homework very well before they say that it's psychological. Now, I asked Dr. Anil Agrawal. See, a lot of patients come with dysfunction. There has been a term which is known as Takasubi syndrome in patients with cardiovascular manifestation. Your take on that, please.
Yes, sir. Thank you for the question. And Takotsubo cardiomyopathy is also synonymously known as stress cardiomyopathy or broken heart syndrome. It occurs after a sudden episode of stress, maybe even psychological or even physical stress, and sudden acute onset of chest pain and dyspnea. This occurs after severe and sudden stress. Here what happens that the left ventricle, the functioning of the left ventricle decreases due to the sudden stress and weakening of the muscles. So due to the sudden release of sudden surge of the hormones, the stress hormone, the left ventricle weakens and start dysfunctioning. However, the good point about this, the prognosis is very good. Most of the patient recovers within 2 months and continue to have their normal life activities.
Yeah, very rightly explained, because this is one entity which is reversible, and post-stress, this is one of the effect. The other factors have been. My question to Dr. Bharat Kumar. Well, a lot of dermatological complaints people come up across. You rightly pointed about allergy and urticaria. But is it the cause and effect? Is it because of the infection or is it because of the vaccination? Because a lot of people who have this come with a question whether they should get vaccinated or not. Your take on that?
Yes, it is a...
It's working, it's working.
Allergic reaction means it involves other substances. Without any other treatment, directly is come with COVID, it will take it as an infection. Due to infection, so many complications. But along with infection, so many treatment leads to so many complications. In that way, I take the...
That's what. See, when people come to us, whether they should get vaccinated or not, when they have this allergic and urticaria reaction.
It is a foreign substance, vaccine.
Yeah.
So, without vaccine, it is an infection. With the vaccine, it is a foreign subject, react to so many things.
Agreed. But this is a $1 billion question. As we rightly said, people who get vaccinated will get less symptoms, less severity. So we have to give the benefit of the doubt to the vaccine. So I think that message should be very clear. Unless it is very problematic and it is life-threatening, I think vaccine is the answer for this long COVID. So any of the chairpersons, if you can ask a few questions.
Since we are running a bit short of time to prepare the stage for my inauguration, very quickly, all panelists give one single thing which they have recurrently seen in their clinical practice day to day as a long COVID. One single thing which you have seen clinically, and let us see, enumerate it, please.
Okay, let me explain on this question. Sir, sleep, insomnia is the biggest problem. I see a lot of referrals from my clinician friends, and what is the cause of sleep? Actually, what happens, because of our amalgamation of the cultural systems, our nightlife has increased. Okay, the sweet nectar from pineal gland, the melatonin is not secreting because of heavy light and all these things. Club life, night life, internet life, TV life, then social life and marriage and late night dinner also.
Srinath,
So all these things, okay.
Your single opinion.
Sir, rightly said, in our specialty, it's the dry hacking cough, most
hacking
distressing,
cough. Riyaz.
irritating, very annoying, and we have taken all measures, but it goes spontaneously without any treatment.
Riyaz,
In
your
days to come,
specialty.
it disappears.
One single thing, enumerate please.
Sir, most of the patients which come to the long COVID, we feel in the practice is the myalgia, non-specific fatigues. That is the
Dr. Bharat.
The most common complaint is excessive hair falling.
Excessive hair fall.
Excessive. They are telling that within 3 months everything will go.
I think in cardiological it is the palpitations which is the most common, and we need not forget that apart from the cardiological cause, we need to take dehydration and anxiety as other causes for palpitations before lifting them. But palpitations is the most common.
So I think today we had a very fantastic discussion, and I felt that nobody talked about prognosis and what will happen later, when will you get cured of it. So we are still in the learning phase. So all of us are still learning about long COVID, and it was a very good discussion. Iqbal sir wants to say something.
The moderator and the panelists. Excellent presentation. I appreciate you all. In my practice, I've been seeing that tinnitus is the most common presentation nowadays. Unexplained tinnitus. And I mean, examination-wise, investigation-wise, the ear function looks normal, but there has been tremendous increase in this particular symptom. Can anyone comment on this?
Sir, we also get a referral from the ENT. After they discuss with the ENT, they send back to the neurologist. So what they do, the ENT, especially they do the butyl deficiency, and they counsel that it is due to the related to the butyl deficiency. What is the exactly pathogenesis? I don't know, but you are rightly said, sir. There is no exact etiology about that tinnitus.
Sir, actually, a few studies have gone up where they said that the posterior cingulate gyrus and the amygdala, and these are the ones which are responsible for most of these ENT complaints, vertigo and tinnitus. But again, this is again thinning of the grey matter. Thank you all.
Thank you.
I thank all my panelists for doing an excellent job and trying to tell us what long COVID is. At the end of the day, I'm sure we are not very much, as Madam said, prognosis and treatment is still a long way off. We are doing with whatever we have.
Thank you,
Over to the
moderator,
chairs.
Dr. Naveen, and thank you all panelists. It had been a wonderful session.
Please, all to stay on the dais. Thank you all for your active participation and making it an interesting and interactive discussion. I thank the audience for their patient listening. I request Dr. Naveen Kumar sir to please present a token of gratitude to our chairpersons, Dr. Malini ji and Dr. Jayesh Kumar Dave. Thank you, sir. I request Dr. Malini ji and Dr. Jayesh Kumar Dave to felicitate Dr. Naveen Kumar. I request Dr. Malini ji and Dave sir to please felicitate our panelist, Dr. Anil Agarwal, Dr. Riaz Ahmed, Dr. Sanjay Acharya, Dr. Trinath Das, and Dr. S.R. Bharat. Thank you all. I would like to please I request you to please take your seats. Ten minutes, tea break. I now ask the audience to please go for a tea break. We'll meet after 10 minutes at 11:30 sharp.
To all the esteemed guests and members, I, Dr. Jolly Matthew, on behalf of our Chief Medical Officer in Charge, Chairman AISMOC 23, the organizing committee, and the entire JLN Hospital and Research Center collective, welcome you all to the prestigious 42nd All India Steel Medical Officers Conference, namely AISMOC 23. Ladies and gentlemen, it's a matter of great pride and honor for us to have amongst us the Honorable Director in Charge, Bhilai Steel Plant, Shri Anirban Dasgupta Sir, as today's chief guest. Also to mention, our guest of honor today, Honorable Madam Dr. Soumya Swaminathan, Chief Scientist and former Deputy Director General of the World Health Organization, due to certain exigencies, she could not come personally today. She has consented to join us in the virtual mode. May I now request the dignitaries, our Director in Charge, Shri Anirban Dasgupta Sir, Chief Medical Officer in Charge, Chairman AISMOC, Dr. Rabindranath M., Chief Medical Officer, Committee Chairman, Dr. Pramod Binaike, to grace the dais. Requesting the Organizing Secretary, AISMOC 23, Dr. Subodh Saha, to escort the dignitaries to the dais. Welcoming our esteemed guests with our rich traditions and emotions woven intricately, may I request our Chief Medical Officer in Charge, Chairman AISMOC 23, Dr. Rabindranath M., to welcome our chief guest, Shri Anirban Dasgupta Sir. Thank you, sir. I request Dr. Vinita Dwivedi to welcome our CMO in charge, Chairman AISMOC, Dr. Ravindranath M. Thank you, madam. Requesting Dr. Annapurni to welcome our CMO, Committee Chairman, AISMOC, Dr. Pramod Binayake. Requesting Dr. Vanita Sharma to welcome our Organizing Secretary, AISMOC 23, Dr. Subodh Saha. Thank you. We are honored by the presence of our esteemed executive directors. All the different AISMOC committee heads are requested to present the welcome greetings to our executive directors. ED Works, Shri Anjani Kumar. ED Personnel and Administration, Shri M.M. Gadre. ED Projects, Shri S. Mukhopadhyay. ED Material Management, Shri A.K. Chakraborty. Now we welcome the dignitaries, the heads of medical departments of our sister plants. Dr. B.K. Hota, ED Medical and Health Services, IGH Rourkela. Air Vice Marshal Dr. Sudhir Rai, retired, GMMS, Tata Main Hospital, Jamshedpur. Dr. B.B. Karunamay, CMO in charge, BGH Bokaro. Dr. Susant Sinha, CMO in charge, ISP Burnpur. Dr. Prakash Kudur, CMO in charge, RINL Vizag. Dr. M.Y. Suresh, CMO in charge, VISNL Bhadravati. Dr. Minati Pal, ACMO in charge, Durgapur. In order to keep ourselves updated and abreast with the latest know-how, we as doctors of the steel fraternity have the privilege of this regular, most awaited annual event, that is the All India Steel Medical Officers Conference. But due to the COVID restrictions, we had to take a break. After a long and difficult time, here we are in this AISMOC 23 after a gap of 2 years. Today, we owe our lives and this beautiful planet to all such studies, datas, and interfaces, the technological innovations and applications, and of course, this is an era of artificial intelligence. So, a lot of enthusiasm awaits there as the curtain unfolds. Our scientific committee has picked up topics as varied as the long COVID syndrome, the occupational and environmental pollution issues for a greener earth, the medical ethics and challenges in the medical profession. There will be debate over the teleconsultation. You'll get to know recent advances in skin banking and diabetes. Happening topics like immunotherapy in cancer treatment. These are to name a few. Also, you get to hear eminent speakers of the League of Dr. Amit Dravid, Dr. Sharad Damodar, Dr. C. Narasimhan, Dr. T.K. Joshi, and many more. Having come out of the depressive and panicky times, here's the occasion to celebrate it all and show our preparedness. शिक्षा एवं कौशल की देवी देवी सरस्वती। सरस्वती वंदना एवं दीप प्रज्वलित करना हमारी रीत व परंपरा रही है। दीपों का अलौकिक प्रकाश इस सम्मेलन के औपचारिक उद्घाटन का प्रतीक है। असतो मां सद्गमय, तमसो मां ज्योतिर्गमय। मैं मंचस्थ सभी विशिष्ट महानुभावों से सादर अनुरोध करती हूँ कि वे आगे आएं और दीप प्रज्वलित कर इस सम्मेलन का शुभारंभ करें। पीजी कॉलेज ऑफ नर्सिंग की छात्राएं सरस्वती वंदना के शाब्दिक उच्चारण में स्वर देंगी। मैं डॉक्टर संगीता कामरा से इस कार्य में सहयोग का अनुरोध करती हूँ।
Rama
this illumination of lamps enlighten all our lives. Now I request our chairman, AISMOC 23, CMO in charge, JLN Hospital and Research Center, Dr. Ravindranath M. for his welcome address. Sir, please.
Conversations that stir the mind are bound to stir the soul. Conferences are an occasion where we can discover it. Respected Shri Anirban Dasgupta, Director in charge, Bhilai Steel Plant, the chief guest of today's function. Dr. Soumya Swaminathan, former Chief Scientist and Deputy Director General, WHO, in absentia. Respected Dr. Pramod Binayake, CMO and Chairman, Organizing Committee. Respected Dr. Subodh Daha, ACMO and Organizing Secretary of AISMOC 2023. Honorable Executive Directors, Shri Anjani Kumar, ED Works, Shri M.M. Gadre Sir, ED P&A, Shri S. Mukhopadhyay, ED Projects, Shri A.K. Chaudhary, ED MM, Honorable Heads of Medical, Dr. B.K. Ota, ED RSP, Dr. Air Vice Marshal, Dr. Sudhir Rai, GM Medical and Health Services, Tata Steel, Dr. Bibhuti Karnamai, CMO in charge, BSL, Dr. Sushant Sinha, CMO in charge, ISP Burnpur, Dr. Prakash Kudur, CGM in charge, Medical and Health Services, RINL Vizag, Dr. M.Y. Suresh, Head of Medical, VISL, Bhadravati, Dr. Minati Paul, ACMO and Team Leader of DSP, respected HOM's former Head of Medicals, Dr. Mohammad Iqbal, Dr. Subodh Hiran, Dr. S.J. Rizvi, senior doctors, former senior executives, senior delegates, my colleagues and DNB students. At the very outset, a very, very hearty welcome to all of you for the AISMOC 2023. There were doubts in our mind whether AISMOC 2023 will take off, because by the end of December, as you may be remembering, there have been reports of surge of COVID infections and in Western countries, and also huge rush of tourists in early January. So the conclusion that there will be a surge by end of January was imminent. Fortunately, that did not happen. So we, the medical teams of various steel plants, are all here to unite to deliberate on academics and celebrate the revival of AISMOC. All India Steel Medical Officers Conference is an unique conference in many ways. Doctors of various specialties from the steel industry meet and compete on scientific issues and exchange ideas. The very combination of various specialties and steel units is very unique. In this conference, you will see a dermatologist may be trying to learn and judge an orthopedician's work. Occupational health is a core element or subject that is going to be discussed. Nowhere in the world we would find or hear of a long paper, short paper, MBBS paper, OHS paper and TQM paper, posters, MBBS and specialty presented in a conference. So therefore, this conference is very unique, and maybe to top it all, there is quiz competition. If that is not enough, there are symposia, panel discussions, debate. This is a unique mix not found in the cocktails and mocktails that you are going to relish in the evening. At the risk of sounding foolish, if we apply, we may get a place in the Guinness Book of World Records. But the competition for a coveted prize is intense and genuine. If you have got one such, there is a sense of accomplishment and pride that he or she that will carry laurels to the organization, and you carry a memory to cherish. AISMOC 2023 will be very special. It is coming after the pandemic. we have introduced in this session, in this conference, a third prize also, so that the delegates who have just missed will also be recognized. Moreover, this is the first time that live streaming of the event is also being undertaken. So in these two regards, this is a very unique AISMOC 2023 or the 47th AISMOC. Organizing this mammoth conference was really very challenging and demandable task, nothing less than organizing a marriage. The host is obviously the ladki wala, but with due apologies to the ladies. But it is made easy, enjoyable by the total and wholehearted support of our director in charge, sir, and our executive directors who are all here to grace the occasion. Apart from academic fees, exchange of ideas, there are gastronomic delights and cultural extravaganza to follow in the evening. My team in Bhilai have been toiling very hard to put up the show, and I am sure that you will all enjoy this conference and carry back wonderful memories. I assure that there will be a fair play, and we have fielded neutral judges to assess the quality of paper and the presentation. On this occasion, I want to remember the senior doctors who have passed away on this occasion, who were instrumental in bringing in AISMOC. Dr. Ms. K.B. Dave, Dr. R.J. Chaube, and Dr. J.N. Mishra. These three luminaries are not there with us, but their memories live on. On this occasion, I also, with gratitude, remember my colleagues and also the other colleagues of different steel plant who are working in the hospital to keep it running. And because of them, we are facilitated to attend this conference. So with these few words, I once again heartily welcome you all, and let us all have this wonderful conference. Thank you.
Thank you, sir, for those nice words. Indeed, this is a unique conference. Ladies and gentlemen, our chief guest for today, the Honorable Director in Charge, Shri Anirban Dasgupta, sir. Sir has always been the driving force in all our endeavors. He steered us through during the most difficult times and always supported the scientific and academic activities. I request you, sir, to address today's gathering. Sir, please.
Thank you, Dr. Matthews. Namaskar. Good afternoon to everyone. Doctors on the dais, Dr. Ravindranath, Dr. Binaike, Dr. Saha, my executive directors, Mr. Anjani Kumar, Mr. Gadre, Mr. Mukhopadhyay, Mr. Chakravarti, HOMs from our sister units, Dr. Hota, Dr. Roy, Dr. Karunamay, Dr. Sinha, Dr. Kudur, Dr. Suresh, and our ex-HOMs from Bhilai, doctors, DNB students, nurses, entire fraternity, medical fraternity here, ladies and gentlemen. It's indeed a great pleasure to be here on the occasion of the 42nd AISMOC. As Dr. Matthews told, we had the last one in 2020. 2021 and 22 we couldn't have. Dr. Matthews told, after a break of 2 years, I mean, it was hardly a break for the doctors. AISMOC didn't happen, COVID happened. And we start with my address with a tribute to all the doctors and medical staff who fought relentlessly during this period to keep us safe. It was so extremely difficult time, we are witness to that. And the way the doctors and the other medical staff battled against this devil called COVID was really, really commendable Some of them lost their lives. In spite of that, the spirit was never lost. And they kept on going, kept on going, kept on going. And now, today, I'm so glad to see a room full of doctors without wearing masks. So we can truly, probably say goodbye to that devil COVID and wish this kind of pandemic never ever comes to our planet again. So this fraternity, kudos to them, and the steel plant fraternity, because the most sought after thing during those tremendous stressful times, especially in April, May, June 2021, was medical oxygen. And really the steel plant fraternity, be it in the public sector or in the private sector, SAIL, Tata Steel, JSW, JSPL, everyone put in their bit to ensure that the country gets LMO. And I know the way our people fought. I still remember there were many instances where you may not be aware of. Even, I think our plant was the first to transport LMO in a converted LPG tanker. That kind of precautions, because you know the combination of LPG or LNG in oxygen is what kind of combination it can be, a deadly combination. So they completely sanitized those tankers and LMO could be sent. So a great thank you to the entire steel medical fraternity and the steel plant people during this COVID times. We have seen, in spite of people falling sick, the supply of oxygen from the steel plants were relentless. Now coming to AISMOC 42nd, we are really privileged to have great doctors from our steel fraternity. And we know that the medicine and the health requirements of the steel fraternity are quite unique, as Dr. Ravindranath was mentioning about the occupational health issues. In steel plants, we have certain occupational hazards, although with technology, new technologies, we are trying to bring them down, the dust levels, the decibel levels, toxic gases, heat, toxic chemicals, you name it, we have it. And so this becomes a unique challenge for the doctors to maintain the health of the steel plant employees and their family members. I'm very glad that this AISMOC will see a variety of papers being presented, variety of discussions, which I'm very sure would enrich all our medical faculty here, community here, as well as we have expert doctors coming in from outside our steel fraternity who will be addressing us. And we are indeed privileged to be addressed by Dr. Swaminathan, whom we knew so well during the COVID pandemic as a member of WHO at that point of time. Her words were so reassuring and guiding for us. And also, she is the daughter of MS Swaminathan. So that becomes a double privilege for us. MS Swaminathan was our father of Green Revolution. The progress India made in agriculture, a great contribution came from Dr. MS Swaminathan. So we'd be interacting with her daughter, who by herself is such a good doctor and clinical research fellow, that it will be indeed a privilege to listen to her, and probably we'll get an opportunity to interact with her, albeit not on a personal level, but at least on the virtual mode. So I wish AISMOC 42nd, and the 6th one, this is happening in Bhilai, I understand. All the very best, very enthralling, very informative, and as Dr. Ravindranath was also mentioning, gastronomically also very fulfilling. So I once again welcome you to this beautiful town of Bhilai. And if you doctors, if you find some time, you are most welcome to visit our steel plants. Of the doctors who have not seen steel plants earlier, I think we can arrange some tours for you if you are around. after you get time from this conference, you are most welcome to visit our steel plant. And also discuss about the challenges of the changing profile in the patients, which we keep on discussing with our doctors, that the average age of our patients or the who are taking health services from our hospitals in Bhilai as well as in other steel plants is increasing. There are many ex-employees who depend on these hospitals for their treatment post-retirement. So we are shifting more from pediatric to geriatric. So those challenges would be coming, and I'm very sure this community, Dr. Fraternity will be discussing on this. There are challenges of retaining good doctors, super specialties. I mean, that day we were discussing we can buy equipment, but how do you get very good doctors? So that's also a challenge. We will discuss all this because going forward, next 10 years, how we plan our hospital management, how we plan what kind of business model do we have, so that we retain good doctors and we can provide the kind of services to our patients or our citizens in the steel plant. Thank you very much. Once again, God bless you.
Thank you, sir, for your words of appreciation, encouragement, and acknowledging our efforts. We assure you to keep up the standards as always. Every meet gathers memories and some takeaways, and there will always be summaries to pursue. It's time to release the memorabilia. I request all our esteemed guests for the unveiling and release of the souvenir of AISMOC 23. Requesting Dr. Manisha to present the souvenir to the dignitaries, Dr. Mercy and Dr. Soumita to assist. Thank you, sirs. May I request our CMO in charge, Chairman AISMOC 23, Dr. Ravindranath M., to present memento as a token of our gratitude and respect to our chief guest, the Honorable Shri Anirban Das Gupta, sir. Thank you, sir. May I now request our dignitaries over the dais to come over and occupy the front row seats. Please, sir. Now is the time to go ahead with our keynote address. While evolving out of the worst ever pandemic, one of the prominent luminaries the world looked up to during the difficult time was our own Madam Dr. Soumya Swaminathan, the then chief scientist at the World Health Organization. An eminent pediatrician and former Deputy Director General at the WHO, Madam was the former Secretary to the Government of India for Health Research. She is a globally recognized researcher in tuberculosis and HIV with more than 450 peer-reviewed publications to her credit. Madam Dr. Soumya Swaminathan was to come here personally and deliver her keynote address. Due to certain preoccupations, she couldn't do so. She was kind enough to send her recorded message, the keynote address. We would like to share the recorded message of Madam Dr. Soumya Swaminathan.
Afternoon, ladies and gentlemen. First of all, let me thank Dr. Ravindranath for having invited me to be with you all and address you. And I was really looking forward to coming and being in person in Bhilai. And please do accept my apologies that I'm not able to come in person. I do look forward to visiting you all at a future date. And thank you also for accepting this online connection with you. So I wanted to just reflect on my experience as the chief scientist at the World Health Organization during these years of the pandemic, and perhaps talk a little bit about the lessons that we have learned, which are relevant and applicable for us as a medical community, but also as society in general, because I think the pandemic has changed a lot of things. And we should probably think about positive lessons learned, the good things that happened. How do we incorporate those into our day-to-day activities and life to make things better? And at the same time, also learn from the not so good things or the challenges and see how are we going to address those so that it doesn't again pose a barrier for us in the future. So maybe I can start with a little bit of context. In 2000, I joined the WHO at the end of 2017 as a Deputy Director General of Programs. Dr. Tedros had recently taken over as the DG and he invited me. At that time, I was the head of the Indian Council of Medical Research and Secretary to the Government of India for Health Research. I had no intention of leaving India. I was not looking for any position at the WHO, but Dr. Tedros actually was very insistent and the Indian government very kindly supported my proceeding to WHO. Now, my role was a bit different then as a Deputy Director General, but then what we did is we went through a process of transformation that every organization periodically needs to go through, and Dr. Tedros felt that after 70 years of existence, we need to relook at our structure and functional abilities. As you know, WHO works at 3 levels. There's the headquarters in Geneva, but there's the regional offices. We have 6 of them, including the one for Southeast Asia in Delhi. And then we have country offices, about 150 odd country offices. So it's complex because there are 3 levels and there are also multiple technical departments. And it's a huge organization. So it was a really steep learning curve for me in the beginning to understand both how WHO works, but also understand getting into the deep technical content. And it's impossible actually to know everything. But one thing I did really like about working in WHO was the very committed and passionate people who work there, and with a lot of knowledge and a lot of experience, people from all over the world. So you have a very international group. And at the same time, I saw that even one person, excuse me, it's recovering from respiratory infection. Even one person who's very highly committed and hardworking can actually change things. So, you know, we say, there's this famous saying by Margaret Mead, which says that a small group of people, if they are committed and dedicated and they have a good idea, they can change the world. And in fact, she says, it's only such people who have changed the world. So it's a lesson that, okay, you know, you sometimes feel lonely, you're trying to do something new, something different, something you feel is good. You don't have a lot of support or people around you, but if you keep on and you persist and you have a plan and you have a vision, then you can succeed. But that's about WHO. So then in 2019, as part of the transformation, a science division was created, and I was asked to be the first chief scientist of WHO. This was a huge honor for me because firstly, it actually very much suited my interests and my profile, but also WHO was sending a strong signal to the world that all of the work that is done on the basis of science and evidence and data. And that WHO's work is normative. It sets recommendations, guidelines, etc. So it has to be based on strong evidence. I like that part very much. And then I was given the freedom to design the science division and its functions, and looking at 3 major areas. One was around how to strengthen our normative work, our guideline work, and there's a lot of new, technical advances that we can use to actually transform, to streamline, to accelerate how often we are putting out our guidelines so that we are more up to date and we're informing the world in a timely manner. Second area was around research. How can we build research capacity? What are the norms and standards for research? The kind of guidelines. How do you set priorities? How do you network? How do you actually get low-income countries to participate in research? And then how do you use the evidence to make policy? So all that was in that research bucket. And the third area was around digital health. And there's a lot of obviously to be done in digital health. There was a strategy that was adopted by the World Health Assembly in 2020. That was a mandate, the structure. I was working on that. And then, of course, came the pandemic at the end of 2019. So from the beginning of 2020, I got very much involved with the response to the pandemic. On the one hand, of course, we have the emergencies program who actually do the hands-on response work. And Dr. Mike Ryan is leading that program. So I had to figure out, what is a chief scientist role? And it turned out that because it's an unknown virus, and of course, we very soon knew that it was a novel coronavirus because the Chinese scientists actually sequenced it and put it on a public database by January 10th. So we knew in January 10th it was a novel coronavirus, but we didn't know much about the properties of the virus, how it transmits, what are the clinical presentation. Okay, we were getting a lot of information from China. One thing they were very good at, the doctors in the hospitals were sharing the information, both with us on calls, but also publishing. And you can see in January, there were a lot of publications coming in Lancet and other journals which describe the clinical manifestations. So we were learning very quickly. Treatment, there was no treatment, there was no vaccine. In fact, diagnostics, a PCR protocol was developed on January 14. so that all countries could start testing. But very few countries had the capacity to really do it at scale. In fact, the whole of Africa, there were only 2 labs that could do sequencing, and a few others that could do PCR. So that had to be built. That capacity infrastructure had to be also built at the same time. So in February of 2020, we decided to have a global research and innovation meeting that would look at the gaps, knowledge gaps, and set the research priorities for COVID. That document we published in February 2020 turned out to be very, very important because it set a path for the global research activities around COVID, because it identified the gaps, it laid out very clearly the priorities, and we had follow-up. And what happened after that was a lot of expert advisory groups were created. Hundreds of scientists were part of those groups. People were meeting on a daily or a weekly basis as the need, and everyone was sharing data, sharing information, and we were making rapid progress in our understanding. So we would have these big calls with thousands of people every 3 to 6 months, or even more frequently, depending on the topics. And then we would share, the latest. And of course, we were also putting out the guidelines on treatment. It was in July of 2020 that we found out that dexamethasone reduced mortality in severely ill hospitalized patients who were receiving oxygen. In April, we had also set up the Solidarity trial, which was a multi-country trial, essentially set up to look at repurposed drugs. Like there was a lot of hope on hydroxychloroquine and lopinavir and ritonavir, other such existing antivirals. So we said we have to test it in a clinical trial. And the trials we found that were going on in China and other places were very small, few hundred people who could not come to a definitive conclusion. So this is why the Solidarity trial, which today has 50 countries participating in it, was set up by WHO. We had an expert group who would look at the list and prioritize the drugs which should go into Solidarity. We had an independent data safety monitoring board and a steering committee. And that actually showed that most of the drugs we tested were not effective. But even that is important. When you're dealing with an unknown disease, you have to do the good clinical trial with enough sample size, to determine whether something is effective or not. Otherwise, it's a waste of resources. There was less attention paid to outpatient treatment of COVID. So a lot of inpatient trials were going on. Inpatient trials in severely ill patients, but not outpatient. So I think that's something we have to learn for the future. And in terms of India, yes, India was part of the Solidarity trial. And of course, there were other trials being run by CMR on convalescent plasma and a few others. But I think India could have done more. We could have done many more clinical trials, both outpatient and inpatient, to find out, the optimal clinical management. Again, one thing that was neglected was oxygen. We found, and you'll all remember, that oxygen was the mainstay of treatment for patients who got sick, supportive treatment, of course, dexamethasone. But without oxygen, you really couldn't save the patient. Now, there was low flow oxygen, high flow oxygen, many different types of oxygen delivery systems. And people are not familiar with those. Nurses and doctors, especially in peripheral settings, may not have ever used these things. So it actually reminded us that we have not paid enough attention to certain very basic things like oxygen, which actually is a life-saving drug, which should be available in every setting, healthcare setting, because you can save lives, whether it's pneumonia, in a child or an elderly person. And we found in a country like Somalia, that there was no oxygen, and therefore lots of children were dying of pneumonia because of that. And so we set up solar-powered oxygen concentrators in some of the district hospitals in Somalia. So again, looking at, the essential needs, we talk about essential drugs, essential diagnostics, and training of staff. So we were running a lot of online training programs using different digital platforms like the ECHO platform, where several hundred doctors and nurses would join a series of training sessions where cases would be discussed, difficult cases, and experts would answer the questions. And this is how the capacity was being built. I was a part of some of those sessions in Nepal, in Chhattisgarh, as well as in Gujarat. And maybe some of you actually took part in some of those ECHO sessions that used to happen in the summer of 2021, actually when the Delta wave was quite severe in India. So lesson from all of this is, and then of course the vaccine story. WHO set the benchmarks for the vaccines. We developed the target product profile so that all the regulators knew what the benchmarks were. Then as the product started coming out, we had to evaluate safety and efficacy based on the data that was submitted by the companies. And we were very particular about safety because obviously a vaccine is something that's given to healthy people. You want it to have a very high safety profile. And this is often a question that people ask, how did people develop vaccines so quickly in such record time? And it was because of a number of reasons, including a lot of funding, a lot of collaboration and cooperation, and harmonization. Harmonization, knowing well in advance what is going to be your sample size, what is going to be the end point, what are the regulators going to look at, and regulatory alignment and harmonization, so that if WHO said this is emergency use approved, then countries went ahead and approved it. So what's called a collaborative registration procedure, where every country does not have to go through the same thing over and over again. We also set up COVAX, which was meant to develop and procure and deploy vaccines, especially to low and middle income countries. To date, it's deployed around 2 billion doses of COVID vaccines, but our problem was that the countries that were manufacturing the vaccines, especially the high income countries, they kept it for their own populations and they did not allow the companies to sell it to COVAX. And so even though we had the money, we had put the orders, COVAX was at the end of the queue because many countries also put export restrictions for raw materials as well as for finished products. So these were some of the challenges that we face at the global level, and which resulted in this horrible situation of inequity where we could see, high income countries' population vaccinated increasing in 2021, and Africa was waiting and waiting for vaccines. So now, of course, there is clearly a recognition that this should not happen again, that this was not a good situation. And therefore, the pandemic treaty is being negotiated. It will be a legally binding treaty that all the member states of WHO must agree to abide by some rules in the case of any future pandemics. The bright side of all this was that science and technology provided us the solutions ultimately, so that if you invest in science, you invest in research, you believe in data, you analyze it properly, you use it properly, you can actually solve many of the big global problems, health problems, etc. So I always, because I'm a TB researcher, think, why can't we solve the problem of TB? Why can we not develop a better TB vaccine by just bringing all of this expertise together? And of course, providing the funding as well as creating the ecosystem for the trials to be done quickly, for regulators, to be clear about the data, and of course, then for procurement and deployment also, you have to plan in advance. Now, one thing that did come up from time to time was vaccine hesitancy, or what I would say was almost an anti-vaccine, anti-science type of movement that had started. Again, starting mostly in high-income countries, but then obviously impacting everybody everywhere because of social media. So the WHO coined a term called the infodemic very early in the pandemic. And in fact, at one press conference, the Director General said that we have this pandemic, or at that time it was not called a pandemic, epidemic, going on of SARS-CoV-2, but we also have infodemic. And this is equally dangerous because it's spreading a lot of false information. You're overloaded with information. Some of it is good, credible, some of it, a lot of it is false, rumors, misinformation. People were purposely spreading. Even today, you find on social media platforms a lot of doubts being sown about the vaccine and about its effects. Yes, all vaccines will have side effects. Nothing is 100% safe. But what is the benefit risk profile of something? That's what you have to look at. If it's going to save lives and you have a side effect which occurs, let's say 3 or 4 in a million, then you should be willing, especially if that side effect is something which can be treated, then you have to learn how to manage that adverse effect rather than say that, this vaccine should not be used. So people forget that, in fact, there are modeling studies which show that the vaccine rollout, saved about 20 million lives just in 1.5 year period. So imagine what would have been the death toll, which today officially is around 6.5 million. We know that it's actually much more than that. But the reported deaths would have been much higher if the vaccines had not been rolled out. So there's a huge benefit risk profile there. And again, people need to understand that any medical product has its benefits and it has its risks, and it's always a question of weighing them. Now, of course, people were exposed to a lot of scientific information on their television channels and newspapers, but also a lot of misinformation. So one of our challenges for the future, for doctors, I think, for scientists, for public health, is going to be how do we educate and make our population scientifically literate, make them health literate, so they understand a little bit about biology, they'll understand a little bit about what are pathogens, how do they interact with the body, what are vaccines, how do they protect you, and a lot of things which basically require some clear basic understanding of science, and then applying some rationality and how to question things which sound irrational or which you're not getting from a very credible source. So positive side of science, but then this, especially in the social media age, we need to manage misinformation. And then I would say that the other big takeaway and lesson from the pandemic is the importance of public health and primary health care, because we saw those countries which had systematically invested in primary health care actually did much better, even though they did not have high technology, they did not have the best tertiary care hospitals or ICUs. They ended up with lower mortality because they were able to educate people, empower them at the community level, do the triaging. Community health workers were there who were trusted, and primary health care very often was able to take care of a lot of the illness and the disease. And of course, public health means also investing in surveillance, investing in epidemiology at the district level, being able to look at data and make decisions, and also to be able to connect what's called One Health, now the animal sector, both wild animals and domesticated animals, because we know that many times these zoonotic infections are coming from animals to humans, and this is likely to continue. We're not going to be able to stop that from happening. So I think looking ahead for the future, we need to think about health as being not just curative, but also preventive, and on the promotive side, how do we reduce risk factors for poor health, right? Because today, if you look at India, a lot of chronic disease, diabetes, hypertension, chronic respiratory disease, mental health issues, these are increasing. As we live longer, we're going to see Alzheimer's, dementias, neurological diseases increasing. But the risk factors are diabetes, hypertension, obesity, air pollution. Of course, water and sanitation are very important for communicable diseases. So we have to go upstream a little bit rather than looking at patients. Of course, we're all doctors, you see patients when they come to seek care, but there's an opportunity to educate them and their families so that they improve their health-seeking behavior, but also the risk factors are reduced, and you promote good health among healthy people. That depends on the environment. It's not the doctor's responsibility alone. It's really the community and society that needs to create an environment which promotes good health, right? Where you can walk or cycle and you can breathe clean air and you can get a nutritious diet which is affordable, etc. So I think that's very important. The second thing we have to do is we have to remember that we are interconnected. Our environment, the animal kingdom and the human beings all live together on this planet. We keep on destroying the environment. We are going to pay the price for that. So we need to learn to live in harmony and not overexploit our environment. The third area is how do we invest more in science and research. Government should really encourage more young people to take a career in science, but also building interdisciplinary teams, right? Most of the advances today in science are made by interdisciplinary teams working on different aspects and coming together to create something really, which is a game changer. So science is advancing very fast. We all need to keep up with it, and we need to leverage that and technology. Like I didn't talk a lot about digital, but all of you were using digital technologies, telemedicine, telehealth, apps, and all of this to do our work today. How can we use our devices to actually help us to do our work better? Not replace human beings with that, but these are tools which now enable us to get more information, to be up to date, to be able to do mentorship and training and things like that with the digital platforms. So I'm going to close there. It's been a pleasure talking to you. Good afternoon, ladies and gentlemen. First of all, let me thank Dr. Ravindranath for having invited me to be with you.
We wish you graced us by your presence, madam. She was kind enough to send her message despite being unwell. We thank Madam Dr. Soumya Swaminathan for sharing her experiences, the challenges she faced, and as you see, a lot has changed in the healthcare system. The mammoth work she shouldered, the need for training, and the infodemic we all have faced. May I request our CMO and committee chairman, Dr. Pramod Binaike sir, to propose the vote of thanks.
Thank you, madam. A very good afternoon to all of you. It is my honor and privilege to give a vote of thanks to all those who helped us to make this assembly happen. On behalf of Organizing Committee, AISMOC 2023, I convey deep regards and hearty thanks to our chief guest, Honorable Director in Charge, Shri Anirban Das Gupta sir, for always supporting and guiding us. Your generosity and kindness towards our committee has been overwhelming, sir. Thank you very much, sir. Our sincere thanks to Shri Anjani Kumar, sir, ED Works, Shri M.M. Gadre, sir, ED P&A, Shri S. Mukhopadhyay, sir, ED Project, Dr. A.K. Panda, ED F&A, Shri A.K. Chakrabarti, ED MM, Shri Samir Swarup, CGM in charge Mines, for their wholehearted support to conduct this conference. I also sincerely thank the head of the various departments and all the executives of various departments of BSP management who smoothly handled this event throughout, especially the Secretariat of Director in Charge, Secretariat P&A Department, and F&A Department.
A special thanks to Madam Dr. Soumya Swaminathan, former Chief Scientist and Deputy Director General WHO, for addressing us online today, despite of her extremely busy schedule. Madam, your thoughts have truly inspired us. I would like to extend my heartfelt gratitude to all the honorable guest speakers, faculties, judges, and chairpersons who blessed us with their presence and supported us to shape this conference. Special thanks to Dr. Divatia, Dr. Bhosle, and Dr. Kothekar from Critical Care Center, Tata Memorial Hospital, Mumbai, for conducting a very nice workshop on hemodynamic monitoring. Special thanks to Dr. C. Narasimhan, who is a renowned cardiologist of India, who will be delivering lecture. He is from AIG Hyderabad. Dr. T.K. Joshi, again occupational health specialist, technical advisor, Environment and Health, United Nations Office of Project Services, India. Dr. Achal Gulati, again occupational health specialist, Professor, Maulana Azad Medical College, Delhi. Dr. Amit Dravid, consultant HIV medicine and infectious diseases, Ruby Hall Clinic, Pune. Dr. Sharad Damodar, senior consultant hematologist and specialist in bone marrow transplantation, Narayana Group of Hospital, Bangalore. Dr. Jatin Ahuja, consultant infectious diseases, Indraprasth Apollo Hospital, New Delhi. I need to mention my deepest sense of appreciation to all heads of medicals and delegates for their enormous inputs in this grand event. Thank you, Dr. B.K. Hota, sir, Executive Director, Medical and Health Services, Rourkela Steel Plant, and his team. मेरा करबद्ध निवेदन होता सर एंड टीम आरएसपी आप खड़े होंगे और पूरी डेलीगेट्स आपका अभिवादन करेंगी टीम आरएसपी काइंडली और मैं अनुरोध करता हूं सारे डेलीगेट्स से कि सारे स्टील प्लांट्स के डेलीगेट का वो अभिवादन करें होता सर एंड टीम आरएसपी टीम आरएसपी थैंक यू सर थैंक यू वेरी मच देन respected Air Vice Marshal Dr. Sudhir Rai, Tata Steel Limited and his team. Rai sir, thank you very much, and team Tata Steel. Thank you very much sir. Dr. Vibhuti Karunamay, CMO, Bokaro General Hospital and his team. Thank you sir, thank you very much for being here with us. Dr. Sushanta Mishra, CMO in charge, Burnpur and his team. Sinha sir, thank you very much sir. Dr. Prakash KH, CGM Medical and Health Services in charge, Vizag Steel and his team. Thank you sir. Dr. M.Y. Suresh, Head of Medical, VISL, Bhadravati and his team. Thank you all being with us in this AISMOC 2023. Dr. Minati Paul, Head of Medical in charge, Durgapur Steel Plant and her team. Thank you madam, thank you very much. Thanks to Dr. Vinita Dwivedi madam, CMO and Team Anesthesia for conducting a successful pre-conference workshop yesterday on hemodynamic monitoring and basic life support. I am very much thankful to all sponsoring agencies and pharmaceutical companies. It would have been impossible to organize this event without their support. A wide round of applause and thanks to all media people who made the event a memorable one. An event of this dimension cannot happen overnight. The wheels had started rolling months in advance. We have been fortunate enough to be backed by excellent team of JLN Hospital and Research Center and dedicated organizing committee of Dr. Subodh Saha, organizing secretary, along with joint secretaries Dr. Kaushlendra Thakur, Dr. Aniruddh Mene, Dr. Manish Devangan, Dr. Gurmeet Singh, Dr. Amit Agrawal, Dr. Rajiv Paul, and many more. I sincerely thank all committee members for the involvement they have shown and the willingness they have expressed to take the completion of tasks beyond their comfort zone. It is nostalgic to see our ex-head of the medicals, directors, joint directors. Thank you very much for being here. Dr. Subodhiran sir, Dr. S.K. Issar sir, Dr. Iqbal sir, Dr. Rijvi sir, Dr. Iqbal, Dr. Shailendra Jain, Dr. Khan, Dr. Rintu Guha Niyogi is here, Dr. Govardhan, Dr. S.K. Sethi, many more I am not able to see. Thank you very much for being here. Dr. A.B. Dave sir, Dr. Khurana sir, Dr. Malini, Dr. Jayesh Dave, thank you very much. My sincere thanks to Team Steel Quiz, which will be conducted on Sunday. And don't forget to miss this event because it is a very interesting event. And thank you, SPS Jaggi sir and Jacob Korean sir, for hard effort for putting this, to conduct this quiz. SPS Jaggi sir is corporate trainer and HR consultant and quiz master. He is ex-director personnel at Shipping Corporation of India. And Jacob Korean sir is working as general manager, L&D department and public relations at Bhilai Steel Plant. Thanks to management and staff of Bhilai Niwas for providing excellent hospitality. At the end, I would like to take this opportunity to thank CMO in charge, our team leader, Dr. Ravindranath sir, who joined hands to organize this dream conference whose seed was embedded in a simple discussion. If a time is money, then today you have spent millions for us. Thank you all of you for making this event successful. Thank you, sir. Thank you very much. Now, I request Jacob Korean, sir. Thank you, sir. Thank you very much, sir. I request Jacob Korean, sir, to come on the dais, please. Jacob Korean, sir. Okay. Now I hand over mic to Dr. Jalu Matthew, madam. Thank you. Thank you very much.
Thank you, sir. And as Dr. Rabindranath has mentioned, we all thank you also, sir, Dr. Pramod Binayaki, being the key person in arranging this conference. I invite all the dignitaries and delegates to the venue for the inauguration of Scientific Stall Exhibition by Dr. B.K. Hota, Executive Director, Medical and Health Services, Rourkela Steel Plant. The venue is the lobby of the first floor. I request Dr. Manish Devangan and Dr. Amit Agrawal to assist to proceed to the venue. Thereafter, we have lunch in the dining hall downstairs. And gently reminding all the delegates to please assemble here again in this conference hall at sharp 2 p.m. I know it's difficult, but we have to do. For the long paper session and for the scientific feasts to follow thereafter. Thank you all. Thank you very much.
And treatment as per the reports. And beyond the first month, an MRCP and ERCP may be done after an LFT and ultrasound of the abdomen, and conservative or surgical treatment is followed depending on the results of the investigations. For the patients with postoperative dyspepsia, the line of management is similar. However, these patients require ursodeoxycholic acid and pancreatic supplements for relief. Coming to the results and analysis, first the preoperative data. So between 2013 and 2022, a total of 478 patients enrolled in the study, and females obviously outnumbering males by more than 3:1. Looking at the age and sex distribution, between 2013 and 2017, the maximum number of female patients were from the 41 to 60 year age group, while in the later half of the study, 2018 and 2022, the maximum number of patients were from the 15 to 40 year age group. So there has been a change in the age group from the perimenopausal age to the childbearing age group. Regarding the pre-op duration of symptoms, obviously patients with pain symptoms presented much earlier than patients with flatulent dyspepsia. Regarding the pre-op nature of the symptoms, males mostly presented with history of acute onset pain abdomen, while females mostly presented with dyspepsia for more than 6 months. After an ultrasound for diagnosis, 123 patients underwent MRCP as a further line of investigation, and 44 patients needed ERCP, sphincterotomy, and clearance of the CBD. Looking at the post-operative data, when pain was the main presenting symptom, most of the patients responded well to reassurance and conservative treatment. Only a few of these patients had symptoms beyond 1 month. They were subsequently investigated. However, when dyspepsia was the main symptom, though a majority of the patients responded well to pancreatic supplements, ursodeoxycholic acid, there remained a small but significant group that had symptoms beyond 6 months. Most of these patients came from the perimenopausal age group. And when dyspepsia was the main symptom, most of the patients presented early after surgery. However, there was a small group who presented after 1 month, who are termed as late onset dyspepsia. Here I have tabulated PCS over time and compared pain and dyspepsia. So after the first week when symptoms persisted, patients underwent an LFT and an ultrasound. It is significant to note that a small group had a normal LFT but an abnormal ultrasound. When indicated, an MRCP was done, and when the MRCP dictated so, 18 patients needed ERCP, and 8 patients required repeat surgery for causes as shown here. So when pain was the main preoperative symptom and a biliary cause of postoperative pain was identified, most of the patients did well to reassurance and conservative treatment. Even the younger age group females, especially with dyspepsia of short duration, that is less than 3 months dyspepsia, they also did very well after surgery. However, patients in the middle-aged or the elderly-aged female patients with pre-op dyspepsia less than 3 months, they had an intermediate response. They required pancreatic supplements and ursodeoxycholic acid and dietary modifications for relief. And when the dyspepsia was more than 3 months, usually 6 months or more, in the middle-aged patients with underlying psychiatric disorders, these patients often the response was suboptimal, despite the various dietary and drug modifications. So, looking back at the 3 case scenarios, for Mr. Singh and Mrs. Shah, the outcome was good. However, for Mrs. Lal, the outcome was suboptimal. She needed various dietary modifications, various form of treatments were followed. The opinion of psychiatrists was taken for underlying anxiety and depression, and still the response was not consistent. So to conclude, the high-risk group for PCS remains the female patients in the middle-aged group, that is 41 to 60 years, with underlying psychiatric disorders, and dyspepsia more than 6 months appears to be statistically significant. The limitations of my study include a single observer bias, a memory bias, and access to diagnostic modalities like endoscopic ultrasound and sphincter of body manometry, which are not available in my locality. These are the references I have used for my study. So with the increase in the number of cases of cholecystectomy, especially laparoscopic cholecystectomy every day, identifying the high-risk group may be the way forward for diagnosing these patients early and treating them well. Greater awareness among clinicians is needed so that they may diagnose and recognize the problem early, and free-op counseling for PCS may soon be made the norm rather than the exception. Let's bring back the smiles on the faces of our patients. On behalf of SAIL-ISP, I thank and congratulate Dr. Rabindranath sir and the Bhilai team for organizing an AISMOC after the period of COVID. From our suffering days, they have returned the smiles on our faces. Thank you, sir. Thank you, everyone, for patient listening.
The house is open for questions.
The incidence in your study of PCS, you not mentioned that.
Yes, sir. Sir, actually, if you have to specify the incidence, it depends on the timing after surgery when you are thinking about the.
The patients who underwent, the definition is very clear.
Yes, sir.
Those patients who underwent cholecystectomy and had persistence of complaints
Yes, sir.
after other causes were excluded is only PCS.
Yes, sir.
And it has to be after 2 months. So you have started including patients after 1 week, after 1 month.
No, sir,
and
not
there's
2
no
months.
Incidence you have not given.
Sir, it can be immediately after surgery because I have
But
seen
that is
patients.
not PCS.
No, sir.
That is not PCS.
Post cholecystectomy, sir, depends on the timing after surgery when they are presenting to you.
So in
It
your
doesn't-
study, what is the PCS incidence?
Sir, it is almost 40 to 50%.
Very high.
Yes, sir.
Extremely high.
Yes, sir. Because the incidence of PCS also reflects the underlying dyspepsia that is in your local population. In our population, the underlying long-standing dyspepsia is pretty high. And so the incidence of PCS is also more. Sir, if you go through the various studies, you will see that the underlying dyspepsia in the local population determines the rate of PCS. Like in England and Scotland, they have shown that almost 40% of their patients have dyspepsia.
So it may be so that you're operating patients for their dyspepsia and not for their gallstones.
Sir, actually, yes, sir, you are very right. Sir, because
So
a
that is
patient.
why you are having such a high incidence.
Yes, sir. Patients with long-standing dyspepsia, they have a maximum risk of developing PCS after operation. Various studies are there, sir, and they are corroborating the fact.
I see you using UDCA for PCS. I thought it is choletyramine. Why are you using UDCA for a post-cholecystectomy syndrome?
Sir, for the patients with flatulent dyspepsia, we have good response with pancreatic supplements on UDCA. Sir, cholestyramine is actually not available in locality, and there are various studies showing that cholestyramine is theoretically helpful.
No, UDCA. You've been using UDCA.
Yes, sir.
How does UDCA benefit PCS?
Sir, actually it decreases endogenous bile secretion. When you're giving exogenous bile acids, the endogenous secretion comes down. That is a theoretical benefit.
I think now we are going to stop on this particular discussion. No.
Sir, can we preoperatively assess which type of patient are going to develop post-cholecystectomy syndrome?
Yes, that is the main topic of my discussion.
Do we need
Female
MRCP? Do we need MRCP preoperatively? If there is patients
I think we are going for the third person. Hello.
Yes, USG indicated then.
Thank you.
I request people who are getting the clarification done from the speaker, let their questions be very short, crisp, onto the subject, please. No long discussions. Thank you.
So we move on to the third speaker, Dr. Orgodas from DSP.
Good afternoon, Honorable Chairperson, respected judges and dignitaries, and our delegates. I am Dr. Orgodas, consultant DSP Main Hospital. My topic is on phacoemulsification in challenging cases. Cataract surgery, as we all know, is most commonly performed and widely performed ophthalmic surgical procedure. It dates back to 2000 BC when our eminent Saint Sushruta performed first cataract surgery. From there, cataract surgery evolved drastically over the last century, where from intracapsular cataract surgery, where total cataractous lens was removed along with capsule without placement of lens. After that, PCIOL evolved. Extracapsular cataract extraction, where large incision were made, and from there, small tunnel incision, the SICS, and then to phaco. And phaco also evolved to femtolaser assisted cataract surgery, where laser power, femtolaser power used to make the wounds and astigmatism correction and nucleus fragmentation. But till date, phacoemulsification is the most preferred choice for the patients as well as for the surgeons. Though each case present with unique challenges, but there are some complex cataract cases which present as difficult surgical environment. So we need proper preoperative assessment, planning, intraoperative decision making, and decent surgical skill to overcome these challenges. The first case is a middle aged lady presented with diminution of vision. On a careful examination, we have found cataract in left eye, right eye, along with iris coloboma and lens coloboma. But there was no phacodonesis. And the retina was normal. There's macula sparing retinal coloboma. So coloboma is a keyhole defect. It is due to the non-closure of choroidal fissure in embryo. So we planned the case and proper patient counseling were done, and capsular hook, capsular tension ring, iris claw lens is made available for any post-operative complications or intraoperative complications. And when we proceed to the case, first incision and wounds are made. After that, careful capsulorrhexis is done away from the defect without giving the pressure in the capsular bag, and then phaco done with moderate parameters. And while chopping, we made very less amount of power and stretching without stretching the capsular bag. After that, irrigation aspiration done and IOL placed with multi-piece IOL is placed here with haptic towards the defect. After that, iris pupillary pupilloplasty was done. The pupillary defect was repaired with single pass 4-through pupilloplasty, where a straight Prolin suture was passed to the defect and suture was made. And the post-op vision was very good, 6/9. Second case was a female with a history of chronic uveitis and presented with nuclear sclerosis grade 3. Fundus was normal. The main challenge in this case, the pupil is not dilating, and the patient also had high intraocular pressure. So first we have controlled the intraocular pressure with anti-glaucoma medications, and these uveitis cases also poses a challenge of severe inflammation post-operatively. So we started pre-operative steroid coverage, and also pupil expanding devices were ready for that pupillary dilatation. But we preferred iris hook because of less cost, but various iris expanding, pupil expanding devices available like Malusigin ring or BHEX ring. In the case, first we tried the synechuliasis and made a plane under the pupil for insertion of the iris hook. After that, capsulorrhexis done and phacoemulsification done with moderate parameters. After that, irrigation aspiration and IOL placed in the bag. After that, iris hooks removed carefully, and the post-operative vision was immediate post-op vision was not very good. There are severe post-operative reactions and membrane formation, or there's also slight hypopian formation. After that, which was controlled by intensive oral as well as topical steroid therapy, and vision improved to 6/12. Third case is a high myopic female. The spectacle power is more than -10 diopter in the both eyes, and nuclear sclerosis grade 3. And the fundus was almost normal, only myopic changes, but no significant peripheral lesions like holes. And IOL power calculation is very important in myopic cases. In this case, we use SRK-T formula or Barrett's Universal 2 formula. Barrett Universal 2 formula is readily available in online internet. And in this case, we measured the IOL power, and that is around 6. There's few tricks while proceeding this case, because this is large eye, there is chances of rupture, so we avoided perivalvular block, and we done the topical anesthesia with paracaine drops. After that, one challenge also is deep anterior chamber, so we maintain low infusion pressure by lowering the bottle height. There's also chances of AC fluctuations, and there's also weak zonules. So we avoid too much pressure while chopping, and there's also chances of reverse pupillary block, which is avoided by lifting the iris with second instrument or irrigating cannula. Intraoperative step, there's a central capsulorrhexis done, is very important in myopic patients. After that, phaco done with low parameters, like bottle height is low. Then irrigation aspiration done, and this cataract eyes is very deep, so we done phaco very carefully. After that, IOL placed in the bag, and the patient was happy with good vision. So take-home message is, with proper counseling and reassurance, we can take calculated risk and perform phacoemulsification cataract surgery in challenging cases with great success. Thank you.
this particular presentation is open for discussion.
I have only one question. Where are your series? You spoke about 3 cases. Is that the end of the paper? I thought there'll be some series.
Sir,
Because cataract is a very common surgery.
yes, sir. I have many, but due to the time limits, I have given the 3 cases here.
I mean, I don't know. I was expecting like a study and a comparison of your various cases with results. 3 is a very small number.
Thank you, sir.
So what is the message of your study from these 3 cases? Everybody knows phaco is an established standard care which can be done with low. Anything special?
Sir, the specialist is in challenging cases, we can do small incision cataract surgery or ECC. But the phaco in these cases, without very small pupil, these are challenging cases. So we just want to present that we can do these in our hospital to just without in other surgeries, we can do the premium cases in our hospital, just like outside or other hospitals.
Good afternoon, everyone. This is Dr. Pranay from Banpur Hospital. So indeed, excellent presentation, and these are actually very risky cases. I would like to know, in the second case of coloboma, whether you preferred in-back phacoemulsification or out-of-the-back phacoemulsification, and could you have gone for SICS rather than phacoemulsification in that case?
No, ma'am, that was done in intravac phaco, because there is no phacogenesis, and on table we have seen the lens capsular bag is very stable, and we also made ready the CTR should be there, and CTR should be there, and also the iris claw lens. If any time the bag, if there time any zonular instability, we can convert the case to SICS, and then we may go for the iris claw lens and other procedure.
Thank you.
Okay.
Thank you, Dr. Das. Now we move on to the next presentation. Another disaster, horror, interesting topic in post-COVID area. We invite Dr. Prachi Menon from Bhilai Steel Plant to present her paper on COVID-associated mucormycosis, a multidisciplinary team approach.
Respected Chairperson and Honorable Judges and Delegates, a very good afternoon to all of you. It's COVID-associated mucormycosis, a multidisciplinary team approach. The health scenario of entire 2020 has been dominated globally by COVID-19. And while we were overcoming the pandemic, another devastating threat, it emerged in the form of mucormycosis. It is caused by the fungus of the order Mucorales. Globally, the prevalence has risen up 910,000 cases annually, and India being the diabetic capital, the prevalence was further enhanced by 80 times. Today, we will be focusing on rhino-orbitocerebral aspect of mucormycosis. With this background, we aim to analyze the clinical presentation, diagnosis, and the treatment of mucormycosis. Our biological data, microbiological workup, the treatment provided, and histopathological finding were interpreted, and the observations were plotted. Of the total 5,757 COVID cases till August 21, total 350 cases were screened in view of high risk of suspicion, and 63 were notified to the national health authorities as mucormycosis. Due to complex interplay of various factors, there was enormous and sudden rise of the cases during the second wave of COVID, with maximum cases in the month of June. Most common age group affected was between 51 to 60 years, with male predominance. Majority of the patients presented within 4 to 8 weeks of COVID, confirmed either by the RAT, TrueNat, or RT-PCR. Diabetes was the topmost comorbid condition associated, and the lethal trinity of uncontrolled diabetes, the steroid therapy, O2 therapy were the major predisposing factor, suggesting immune suppression and progression of disease. CT severity score of HRCT was moderate to severe in maximum cases, suggesting poor pulmonary reserve. And these are the few CT scans of our patients showing the mild, moderate, and severe parenchymal lesions. Maximum number of the patients clinically presented to us with orbitofacial pain, edema, paresthesia, followed by the nasal complaints, few with the orbital and dental complaints too. Due to aggressive screening, the lot number of our cases were in the stage 2, hence recommends that the early diagnosis, it forms the backbone for successful outcome. Clinically, the disease has been staged from stage 1 to 4. Stage 1 being limited to the nasal cavity, stage 2 with the extension to the paranasal sinus and the palate, stage 3 extension into the orbital margin, that is the orbital, stage 4 extension into the cavernous sinus or the central nervous system. Diagnostic methods included were the KOH mounting, nasal endoscopy, CT, MRI, culture, and histopathology. Direct microscopy of the deep nasal swab is a tool for rapid diagnosis, characteristically showing pauciseptate, aseptate, broad, irregular, ribbon-like hyphae, characteristically showing branching at 90 degrees. We had other staining method used was LPCB stain. KOH has got 90% sensitivity. With the lowest of suspicion, the patient was subjected to 0-degree rigid nasal endoscopy, even at the bedside, even in the COVID-positive patient, characteristically showing the black eschar, black turbinate, necrotic discharges, crusting, and ulceration of the nasal mucosa in few of our patients. Radiology, it formed the cornerstone of investigation, defining the extent of disease, up to paranasal sinus in 42 patients, orbit in 7, brain in 2, and cavernous sinus in 2 patients. Bilateral and pan-sinus involvement, it illustrated the actual burden of disease. MRI with contrast is better at demonstrating the early mucosal abnormalities, that is the black turbinate sign, mucosal reactions of the paranasal sinuses, that is maxilla and ethmoids in the paranasal stage, then optic neuritis showing the peripheral enhancement of the optic nerve, 4th stage showing the extension to the cavernous sinus, frontal lobe, and bifrontal cerebritis. CT showed the involvement of the septum, the maxilla, ethmoids in the paranasal stage, extension to the orbit, extension into the extraocular muscles, then pan-sinus involvement could be illustrated in this last image. Culture of the nasal secretions on the sabrods agar, it grew mucor in majority of our cases. SDA is highly specific for fungus when incubated in the test tube, characteristically showed cotton woolly growth of mucor. Following diagnosis, management was a big task with numerous challenges. Procuring the life-saving IV liposomal amphotericin B was a big task. Making the drug availability, channelizing the drug movement was a very tiresome, but very well guided and supported by our higher authorities and the faculties. We acknowledge the management for the same. Following the diagnosis, 33 patients underwent extensive surgical debridement of the necrotic tissue, devitalized tissue, followed by IV liposomal amphotericin B, and the tapering doses of oral posaconazole. Endoscopic approach was performed in 23, 2 underwent external approach, and 8 underwent combined approach for achieving the disease-free margins. Endoscopic sinus surgery, it formed the mainstay of treatment, varying from endoscopic debridement to endoscopic medial maxillectomy. These are few the intraoperative endoscopic view of black fungus characteristic debris, which can be well distinguished, and the devitalized tissue. Partial maxillectomy and total maxillectomy with orbital accentuation were performed for the extensive disease. Specimens were subjected for histopathology postoperatively, showed classical mucor in 15, 7 showed mixed mucor and aspergillus. Varying thickness of aseptate and pauciseptate invasive hyphae was seen in histopathology. We had a good diagnostic yield even with a thrombosed vessel within the tissue. Controlled doses of IV liposomal amphotericin B from 5 mg per kg were given according to the extent of disease and patient's tolerance. 22 received up to 3 grams of cumulative dose of amphotericin, well monitored with renal functions and electrolytes. Average hospital stay was 2 to 4 weeks for 33 patients, and we had 60 disease-free patients, 2 recurrences, and an unfortunate death. We compared our data with Sharma et al. And Mishra et al. It coincided in view of the most common symptom, uncontrolled diabetes, FES surgery, and IV liposomal amphotericin B. Due to our outstanding, consistent, multidisciplinary team approach, we were able to achieve the successful outcome in this black fungus emergency. To conclude, uncontrolled diabetes, steroid therapy, and O2 therapy were the major predisposing factors along with COVID. Fungal smear for KOH and nasal endoscopy, it played a crucial role in mass screening. Culture and histopathology laid a pathway for confirmation of diagnosis. CT and MRI raised a high index of suspicion. and endoscopic surgical management, it formed the mainstay of treatment. IV liposomal amphotericin B proved to be the tower of strength for the effective management of COVID-associated mucormycosis. Early diagnosis and multidisciplinary team approach led us to an excellent outcome. These are few references. Thank you.
Thank you, Dr. Prachi. Case is open for discussion.
The third image which is shown in the MRI picture, that was the note of the contrast image, that was the T2 image of the MRI.
Yes, sir.
Which was
T2.
showing the, yes, but you have mentioned that this is the contrast image. That was not a contrast image, that was the T2 image of the MRI.
No, I said, sir, MRI with contrast is an investigation of choice.
Yeah, but you
Yes,
have
sir.
shown the picture of that contrast enhancement of the optic nerve.
Yes, sir.
But that was not the contrast enhancing image.
Yes, sir.
That was the T2 image.
T2 image, sir.
Yes.
Excellent study and excellent results. I compliment you for a good presentation.
Thank you, sir.
I just have a small thing. You said this is a retrospective study and
Yes.
you went to your ethics committee for clearance. What were the ethical dilemma or concern you had?
Sir, the study is in process for publication, and that's why we have put it with the ethical committee, and it has been approved by ethical committee.
No questions. Thank you, Dr. Mene.
So, thank you, sir.
We invite Dr. D. Bhaskar from Visakhapatnam Steel Plant for his presentation on hyponatremia and pituitary adenoma, an uncommon relationship.
Good afternoon, everyone. Today my topic of presentation is hyponatremia and pituitary adenoma, which is an uncommon relationship. I am Dr. Bhaskar from Visakhapatnam Steel Plant General Hospital, RANL Vizag, and these are my co-authors. Coming to the hyponatremia is generally defined as sodium levels less than 135 milliequivalents per liter. It is not an uncommon laboratory finding, but the hunt for etiology is a challenging issue for any clinician. So it can lead to symptoms like decreased ability to drink, lethargy, headache, and nausea and poor balance, to severe symptoms like seizures, coma. So the cause of hyponatremia may be depending on the fluid status, like hypovolemic, euvolemic, and hypervolemic hyponatremia, and these are the causes enumerated here. There are various CNS causes which can cause hyponatremia, mostly are subarachnoid hemorrhage, severe head injury, and pituitary adenoma. Pituitary macroadenomas are most common cause of hypopituitarism, and the majority cases are non-secretory adenomas. The pituitary adenoma usually manifests as bitemporal hemianopia due to compression of optic chiasma, and other symptoms like headache, psychiatric symptoms, anxiety may be present, and some hyperpituitary features like secretory adenoma can be seen. Hyponatremia can occur secondary to hypocortisolism or rarely due to SIADH. And secondary adrenal insufficiency can also cause hyponatremia in pituitary tumors. So here the pituitary adenoma to cause hyponatremia before other common symptoms like headache and decreased vision is unlikely. Here we present a series of cases which initially present with episodes of severe hyponatremia and eventually found out to be having pituitary adenomas. Coming to the case number 1, he is a 53-year-old male, came with complaints of headache and altered sensorium. Initially he is conscious but incoherent. Cranial nerves were normal and plantar was flexor. Hemodynamically he is stable. Past history there was TB lymphadenopathy for which he took treatment. And when evaluated he is having severe hyponatremia of 120 milliequivalents per liter. And all other examination findings were normal. All other investigations were found to be normal. So besides treating hyponatremia, as he is not getting improvement, we have sent for MRI, where they are showing pituitary macroadenoma. It is extending from paracellular to cellular and encasing the cavernous segment of right ICA. We have sent for hormone analysis. So in that only prolactin has been markedly elevated to be 470 nanogram per ml. All other hormones were found to be normal. So we have consulted with ophthalmologist for any refractive error or visual defects. There was no such thing. And we have, besides giving hyponatremia management, we have went for medical management for pituitary macroadenoma with steroids and dopamine agonists with like cabergoline. Now the patient is on regular follow-up and stable condition. This is post treatment with cabergoline. Now coming to the case 2, he is a 56-year-old male, came with the history of vomitings to casualty. Previously twice he was admitted with the same complaints and he was diagnosed as hyponatremia and was treated. Now the patient is coming with recurrent hyponatremia, and when thoroughly evaluated, when we asked for thorough history, the patient then gave the history of recurrent headaches and temporal field blurring of vision, which was progressively worsening. When we sent for routine examination, there was sodium levels 122, which suggests of severe hyponatremia. And past history, there was a history of loss of weight in the past 1 year. And ophthalmologic examination, there was bitemporal hemianopia with other cranial examination to be normal and other neurological examination found to be normal. Here, there is a T1 eye intense imaging in the subcellular and supracellular region, deforming the anterior recess and third ventricle. We sent for hormone analysis. There was only mild hyperprolactinemia is seen, other than all other were found to be normal. So patient consulted with neurosurgeon and was advised surgery, and excision of tumor was done. Post surgery, the patient was in stable condition. Serial electrolytes were found to be normal, and he was on supplementation with thyroid and steroids. These are post surgical pictures. And coming to the case 3, it is a 31-year-old female, came to casualty with history of recurrent headache and multiple episodes of vomiting and 1 episode of seizure. She was, at the time of presentation, was delirious and irritable. Hemodynamically, she is stable. On routine examination, where we have found out to be having severe hyponatremia. For evaluation of her seizures, we have sent for MRI, where we found out to be having the features of edema with hemorrhage and suggestive of pituitary apoplexy. So neurosurgeon consultation was done, and in meanwhile we have sent for hormone analysis, where there was mild hyperprolactinemia and low LH levels. But during the surgery, there was found to be no hemorrhage that was drained, only fluid was drained. So there was a differential of TB over the sarcoid was made, and both entities workup was done and was found to be negative. Post-surgically, patient status, sodium status was also improved, and he was kept on anti-epileptic steroids and thyroid supplementation. These are post-surgical pictures. Coming to discussion, so evaluation of hyponatremia needs to be having complete biochemical, hormonal and radiological assessment. We are reporting these cases for this important clinical lesson. And pituitary hormone deficiency to cause hyponatremia, and the presence, here we have sent the patient for imaging because the persistence of symptoms even after the correction of hyponatremia were present. And hyponatremia due to CNS cause may be due to SAIDH and cerebral salt wasting syndrome. Apart from these two, pituitary mass leading to secondary hypoadrenalism and hypothyroidism can also lead to hyponatremia. And here are some study case reports which say that initially the patients present with hyponatremia, and eventually when found out to be having pituitary macroadenoma. Bhupet et al., Jagar et al., and Rajput et al. Here the patient's initial symptoms, by their symptoms we have diagnosed as hyponatremia, but eventually when the total workup was done, they were found out to be having pituitary macroadenomas. Vargas et al. Stated that 8 to 10% of pituitary adenomas are pituitary apoplexies. Jovan et al. Study stated that their case also had initial presentation of hyponatremia, but here sometimes there may be a suspicion that recurrent vomitings may be the sole cause for electrolyte imbalance. But Dinuka et al. And Nawal et al. Studies where the patients have recurrent vomitings as an initial presenting feature, and they was diagnosed as hyponatremia, but eventually when the total workup was done, they were diagnosed as pituitary macroadenomas. Here, until now, there were only case reports stating that there was hyponatremia as a presenting symptom for pituitary macroadenoma. Ours is the only case series where there are 3 cases reported to be having severe hyponatremia as an initial symptom, which were eventually found out to be having pituitary macroadenoma. In conclusion, as hyponatremia is not an uncommon finding, but etiological diagnosis may have multiple overlapping DDs. These 3 patients have 3 varied presentations, but correct diagnosis and timely intervention may be life-saving. Our cases here highlights the importance of assessment of hyponatremia by timely normal test with adrenal, pituitary, and thyroid function test and imaging. These are my references. And thank you.
This topic is open for discussion.
That was a good presentation. In your 2 cases, you have mentioned the pituitary macroadenoma, but the prolactin level was only marginally elevated, 50 to 60. Give me the one reason why there is a prolactin level was normal, near normal.
If there is no mass effect to the pituitary stalk, there may be need not to be high levels of elevation of prolactins in those cases. And other than that, if there is only the lactotope, if the adenoma is rising from lactotope, then can be forming into prolactinomas. Then there may be, excessive raise of prolactins in those.
This is not the reason. Have you ever listened to the hook effect? What is the hook effect? Do you know? Sir? Hook effect.
Hook effect, sir. So,
Okay, thank you. Now I invite Dr. S.K. Tiwari from Rourkela Steel Plant to kindly come up.
पोल्टर कैसे काम करता है दिखा देना जरा. जब बोलेगा स्टार्ट. Already started? Okay. Good afternoon and namaskar, respected chairperson, judges, seniors and colleagues. In this study, we'll see how the peroneus longus tendon behaves in comparison to the hamstring for primary ACLR. Well, an ACL tear is very common injury, is perhaps the most common injury in the knee joint. Essentially, it is a rotational injury. And ACLR surgery is one of the most common surgeries performed in sports medicine. Untreated, it can lead to severe knee instability, meniscal injuries, and for a sports person, it can mean an end to a sporting career. Arthroscopic assisted ACLR is the standard treatment of these injuries. Currently, the bone, patellar tendon bone, and hamstrings are the most commonly used autograft. And graft size is very important, especially the diameter. And it can happen to anyone, not just the elite athletes. The aims of this study was to compare the clinical results between the much less commonly used peroneus longus versus the much more popular and commonly used hamstrings. It's a prospective study between 2017 to 2022. We have a small sample size of 27 patients. In the peroneus longus, we have 12 patients, 9 males and 3 females. In the hamstrings, we have 15 patients, 13 males and 2 females. Age was 24 to 26 years. Our inclusion criteria was symptomatic unilateral ACL tear, isolated ACL tear, with or without meniscal injuries. Multiligamentous and bilateral injuries were not part of the study. Standard post-op rehab was followed in both the groups. Patients were evaluated at 1, 3, 6, and 9 months up to 2 years. Knee was evaluated for pain, stability, range of motion, and numbness, thigh for pain, hypertrophy. Knee was evaluated clinically as well as using the IKDCL Lisdom scores. Ankle, foot were evaluated by FADI and EOFAS. And finally, the data was analyzed. This is the procedure we did, spinal anesthesia followed by examination under anesthesia. Then we proceeded to do a diagnostic arthroscopy to confirm the findings. Then we did the graft harvesting and preparation of the graft, then preparation of the femoral and tibial tunnels, and finally graft fixation. Basically what we do is, we make a tunnel in the tibia, we make a tunnel in the femur, and the prepared autograft, we just anchor it in the tunnel. And in this study, we have used interference screw, bias screw for tibia, and a suspensory type fixed loop for femur. Using various landmarks, and finally, it should look like this, a conical on an end-on view.
Tibial tunnel is prepared with help of jigs and anatomical landmarks. Then for graft fixation, we have a lot of options. In this study, we have used the bioscrew and we have used fixed loop. This is a small video of the procedure. The femoral tunnel is being prepared. This is the femoral tunnel. Since we are using a fixed loop, the length of the tunnel is very important for us. Then the tibia, using this jig and guide wires, it is prepared. And finally, the graft is put and it is put to range of motion and checked for impingement. Well, what is an ideal graft? An ideal graft is one that is easy to harvest and fix. It should have no minimum or no donor side morbidity. It should be sufficient in length and diameter. It should be strong, at least more than the native ACL. It should undergo early ligamentization. And there should be no issue regarding the graft rejection or disease transmission. There is no consensus which is the ideal graft. The graft options we have today are autografts. Amongst these, the bone pellet tendon bone is the gold standard since 1980s. Hamstrings are currently very, very popular. And then we have many grafts, including the peroneus longus. Allografts from cadavers and synthetic grafts are not commonly used in our country, not easily available. This is a bar diagram showing the demographic profile, number of patients, the follow-up, and the age. Now, this is a very important slide regarding the diameter of the prepared graft. In the peroneus longus group, it is 8.66 versus 8.1 in the hamstring group. Regarding the range, it was 8 to 10 in the PL group versus 7.5 to 9 in the. The 7.5 diameter is not, these are the patients who are problematic, they may have a re-rupture. Regarding the length of the harvested graft, again we can see in the peroneus longus, 299.16 long grafts we got in comparison to hamstring 272.26. Looking at the range also, 280 to 320 versus 220 to 320 in the hamstring group. The IKDC score we compared pre-op, 6 months and 9 months. And both did very well, equally well. Nothing much to choose, if at all, slightly better with the peroneus by just one marks or something. Regarding complications, we did not find any foot or ankle pain or instability in either of the groups. And in the hamstring group, we found 3 patients who had paresthesia around the knee, and in one it persisted till 9 months. So to summarize, in the PL group, the mean graft diameter was 8.66 plus minus 0.53, as against 8.10 plus minus 0.47 in hamstring group. P-value is statistically significant. The length also, PL group 299.16 plus minus 12.40 against 272.6 plus minus 28.41. This is also statistically significant. No ankle foot instability and IKDC score were similar. Now, head to head, why peroneus longus or hamstrings? Peroneus longus is easy to harvest. We get a consistent, predictable, and adequate graft size, irrespective of gender, athletic ability, obesity, and other factors. No ankle foot instability or pain, no numbness around the knee joint. Hamstrings, they are technically more demanding, unpredictable graft size. There is weakness of knee flexion in all cases, and numbness around the knee in 30 to 80% reported in literature, and there is always a thigh hypertrophy and pain. So the take-home message is that very simple, it is loud and clear. The peroneus longus is a very, very good alternative to hamstrings from primary anterior cruciate ligament reconstruction. For the occasional recreational sports person, peroneus longus may be the better option than hamstrings. However, in the elite athlete sports person, bone pellet tendon bone or hamstrings still remain the preferred choice. Cosmetically also it is very good. One knee is operated, other is not non-operated, we cannot see any scar. And we always have a look in the Siam to see that the endometrium is placed nicely. These are some of the references that we have used. There are not many studies about this, at least not from Europe and America. Most of the studies are from Asia. So to conclude, when it comes to autograft for ACL reconstruction, the size graft does indeed matter. Thank you.
It is open for discussion.
Yes, ma'am.
Very good afternoon to you. I am Dr. Pratibha from Bhilai. Nicely you have explained each and everything, and here whenever we are doing MRI, we are getting most of the time the tear towards the femoral attachment in ACL. So what was your arthroscopic finding? Which site you got? Towards the femoral or towards the tibial or in the mid portion?
We found most in the femoral attachment. However, if you look at the literature,
Yeah.
it says that mid-substance tear is most common.
Yeah.
Second is femoral site attachment, and from the tibia, there's no tear. Usually, it is an avulsion because it's a large attachment in the tibia. So we got mostly what you find
So
in
all
MRI.
of your patients have undergone MRI before going
Yes,
to the
yes,
arthroscopy?
MRI definitely. All.
And in this partial tear also you have done repair or
No,
only complete tear?
no, for partial tear, our protocol is that we advise the patient to use braces, to do exercises, to prevent another twisting injuries, because see, literature says that most of the partial tears are actually full thickness tears. So one option is to do a diagnostic arthroscopy. But I'm scared that while doing a diagnostic arthroscopy, if I pull that partial tear, I may convert it into a full tear. This is my personal thinking. I don't know how right or wrong I am. So we tell them that for 3 months, stay away from sports, do exercises, rehab, and come back after 3 months. So at the end of 3 months, if they still have instability, knees giving away and other things, then we go for a diagnostic arthroscopy, and if we confirm a tear, then we go for a ACL reconstruction.
Did you find anything that which has been explained or which has not been explained in the MRI, but you were getting it in the arthroscopy?
It is usually it is usually about this meniscal tears.
Meniscus.
Posterior root, oblique tear. We get many such reports, but when we go down and we see, most of the times
Interstitial tear also somewhere.
Yeah, but most of the times they don't need anything. We just have to just.
Thank you so much.
Thank you, ma'am.
Thank you for the wonderful presentation and sharing with us your experience in your hospital. 2 quick questions. One is, what was the effect size, because this was a study, what was the effect size you were working on? What was the primary outcome of your study, and how did you decide the power of the study based upon what was the alpha and beta error? The first part of it. Second part of the question is, you were actually differentiating between the 2 grafts through the size of the graft. Are there any outcome parameters through which this study could have been giving better results? Because ultimately post-surgery what we are looking at is functional outcomes beyond recovery.
You see, what is the function of the anterior cruciate ligament? We must understand the basic anatomy and the physiology. The job of the anterior cruciate ligament is to prevent the anterior translation of the tibia in respect to the femur. Okay. Now, hamstrings are very important posterior stabilizers of the knee joint. In an already unstable knee, if you take the hamstrings, then you are further destabilizing the knee, at least for the 2-3 months, 6 months at least. So that is one bad reason. Then further, if a patient is having a grade 1 or grade 2 MCL tear, again that is a contraindication to take hamstrings. And the gold standard bone, pelvic tendon bone, which is in vogue since 1980s. It has its own problem, anterior knee pain, and especially in India, patients need to squat and kneel. So, and regarding the alpha-beta part, I could not really understand your question. Maybe at dinner or banquet, maybe we can discuss later. The alpha-beta part, I could not understand. I'm very sorry.
Thank you. Thank you. We'll move on.
I am Dr. Dave from Bhilai. Just a minute. Excuse me, Dr. Tiwari.
Sir.
In your hands, PL substitution for ACL has given excellent result. But why fraternity is not shifting fully to PL? Still a lot of people, because exactly similar paper was there and recently concluded Chhattisgarh State Conference at Kanha, and there was a lot of discussion on this. But a lot of dedicated arthroscopists.
Please, we are concluding this particular subject. We will answer you later.
Let me answer it quickly.
He will answer you later, please.
Thank you, sir. Sorry, sir.
Thank you. We'll now call on the last speaker, Dr. Deepti Pieka from Bokaro.
Good afternoon, everyone. I'm Dr. Deepti. Respected judges, chairpersons, and the esteemed audience, I am going to speak on ocular health in high heat and investigation among steel plant workers exposed to high heat. Steel making is basically a high temperature process. The various departments of a typical steel plant such as blast furnace, hot strip mill, coke oven and the steel melting shop, there is everyday generation of huge amount of heat. India being the world's second largest producer of crude steel, thousands of persons are exposed to high heat on a daily basis. The workers of these industries have been suffering from different types of diseases and injuries, including eye problems. But ironically, there has not been adequate surveys or studies in this aspect. So the aim of this study was to assess the ocular health among steel plant workers exposed to high heat. It was an observational cross-sectional study from September 2020 to September 2022. We took two groups. One was cases where we took workers posted in high heat zone of the plant, such as the blast furnace, steel melting shop, and the coke oven. Controls were from the non-heat exposed regions, such as the marketing unit, personnel, and finance. Both the groups were age matched and with maximum of 2 years difference was allowed. Informed consent was taken from all its participants. We included persons of age group 30 to 50 years who were working in the high heat zone of the steel plant. Persons who had previous history of ocular trauma, ocular surgery, diabetes mellitus and long-term steroid use were excluded from the study. Data was collected through face-to-face interview of the respondents by using a pre-tested questionnaire where we asked regarding the duration of the job, temperature of the site, lifestyle, occupational, medical and ocular histories were taken. A comprehensive ocular examination was done to each and every participant, starting from uncorrected visual acuity, Schirmer test and tonometry. Coming to results, all the participants were male. We took 92 cases and 92 controls. The mean age of the participants was 36.2 years with standard deviation of 5.2 years. Then we divided the number of distributed respondents according to the workplace temperature. In our study, maximum, that is 58% were working in temperature of more than 500 degrees Celsius. We had even had workers from blast furnace who were even exposed to 1200 to 1500 degrees Celsius. These are the different ocular presentations such as the dry eye, conjunctival inflammation, itching, corneal inflammation and cataract. Out of this, dry eye and conjunctival inflammation and cataract were present in significant higher proportion in cases than in controls. Then coming to lenticular opacity, in controls had 38.04% of lenticular opacity. In cases, 54.34% had lens opacity. When we calculated the odds ratio, it came out to be 1.9, which means almost twice the risk of getting cataract in the heat zone. Then when we compared the duration of years of posting in the heat zone with the number of persons getting the symptoms, we found that after 10 years of exposure, there was a steep increase in number of persons having these ocular symptoms. When we calculated the Pearson correlation coefficient, it came out to be 0.9, which signifies a positive correlation. These are some of the photographs of some of our patients, slit lamp photographs showing posterior capsular cataract, nuclear sclerosis, mature cataract. This is a very interesting slit lamp photo of capsular delamination. Capsular delamination, there is a splitting in the anterior capsule of the eye. In the textbook description, it is found to be described in glass blowers. But the fact that we had two patients having capsular delamination further emphasizes the role of heat on the lens of the eyes. These are some more photographs of showing conjunctival inflammation, inflamed pterygium, and corneal inflammation. Then coming to the pathology of heat on the eyes, heat causes altered tear film instability, leading to inflammation and apoptosis on ocular surface, leading to dysfunction of the lacrimal functional unit, and this in turn leads to various symptoms such as dry eye, conjunctival inflammation, and itching. Then coming to the pathology of heat cataract, the exact pathology is still debated. But under the influence of heat in PIX lenses, it has been studied that the alpha crystalline protein molecule of lenses undergoes native partial unfolding, leading to cataract. Then summarizing, the present study emphasizes the various ocular problems faced by steel plant workers in high heat zone. The key points of my study was that when compared to their non-heat exposed counterparts, the workers in the heat zone had increased dry eye, increased conjunctival inflammation, greater prevalence of cataract, and a positive correlation was found with the duration of exposure. A similar study by Hassan et al. In Bangladesh in a rolling mill documented that workers who worked very near to the furnace area between 40 degrees Celsius to 800 degrees Celsius had eye irritation. Then coming to the limitation of the study, when we analyzed these workers, we also found that they were exposed to infrared radiation, which can serve as a confounding factor, especially in the formation of cataracts. Dose-effect relationship also could not be assessed. Then coming to the recommendation, the first and foremost important thing is awareness. Both management and workers should be aware of all the ocular hazards of working in high heat zone. And so according to that, engineering control measures such as installation of thermal barriers, improving of ventilation and provision of AC rooms should be done. Persons who had long years of exposure to high heat could be shifted to less heat exposure areas. Protective goggles and helmets with shields should be the norm. Not only the plain goggles, which only provide protection against the foreign particles, goggles with installed thermal shields, and the regions where we expose high flash injury, even full covered helmets with appropriate filters should be strictly adhered to. Periodic eye checkup should be done at least once a year of each and every worker, where not only the visual acuity but a complete and comprehensive eye examination should be done. For dry eye, preservative-free lubricating eye drops should be given. Allergic conjunctivitis, we can give cold compress, tear substitutes, topical vasoconstrictor, topical antihistamines, and mast cell stabilizers. So I would conclude that ocular health and productivity of labor are highly correlated. This is, I think, the best platform to emphasize that heat is a potential occupational hazard. And for that, job rotation after long years of exposure, mandatory regular eye examination should be made compulsory. And just like in plant, the safety helmet and safety shoes are compulsory. Like that, protective goggles with thermal shield should be the norm. These are my references. Thank you.
This particular subject is open for discussion, please.
I am Dr. Puspa, ophthalmologist from the IGS. So
Okay,
it is a very good study, but I want to know what more fact you concluded from this study. So what is the novelty of this study?
Ma'am, first thing we noticed that compared to the non-heat exposed exposed counterparts, persons who were posted in high heat zone, first they were getting cataracts at the earlier stage, where both the groups were age matched. So first they were getting there was increased prevalence of cataract, they were getting in a higher age, that higher incidence of conjunctival inflammation, itching than non-heat exposed.
It is already known fact.
No, ma'am.
It is already known fact, it is already proved. So what extra point you extrapolated from this?
First, they were not, like the protective goggles. There is lack of awareness among the workers, so that they don't know that what are the effects of working in high heat. So they are not like, they don't strictly adhere to protective goggles, though they are provided with that. Yes. So once they'll be aware that yes, if I am posted in blast furnace, I have twice the odds of getting more cataract than from my HRD fellow, then he'll be strictly adhering to protective glass with thermal shields. That is my take-home message also.
Actually, everybody knows, all are aware. Yeah. But to use the protective device, the intention, that psychology is absent.
Is absent,
so
yes,
we
ma'am.
have to induce it.
Yes, ma'am. That is why. That was the purpose of my study also.
Thank you. If there are no more questions, we conclude this particular session. I must tell you that this particular long paper award session is one of the best long paper award session I ever witnessed. We heartily congratulate all the presenters, because all the subjects have been covered, starting from eye, ENT, pathology, orthopedics, surgery, medicine, everything has been covered. Thank you very much for this excellent presentations, and we also like to thank the organizing committee members of AISMOC 23, led by Dr. Ravindranath, for giving us this opportunity.
Thank you all.
This brings us to the end of this wonderful session. Thanks to our chairpersons and judges. I request the judges to kindly come over to the stage. I request our judges to felicitate our chairpersons, Dr. Sushant Sinha and Dr. S. Muhammad Iqbal. A big round of applause for our chairpersons. I request the chairpersons to felicitate our judges, Dr. Sandeep Chandrakar. He's from Medical College, Raipur. Dr. R.K. Panda. He's from Medical College, Raipur. And Dr. Naveen Verma from Sri Shankara Medical College, Durg. Thank you all.
Antiretroviral therapy has come a long way from zidovudine in 80s to the highly active antiretroviral therapy in 90s, turning the deadly HIV/AIDS into a manageable chronic disease. We will now learn about the nitty-gritty of ART and tailoring it to specific population like pregnant females, those suffering from tuberculosis and other opportunistic infections. We have now our eminent guest speaker, Dr. Amit Dravid, consultant in HIV medicine and infectious diseases, Ruby Hall Clinic and Pune Hospital, who will be speaking on the basics of HIV and antiretroviral therapy. To chair this session, I call upon Dr. B.B. Karunamay sir, CMO in charge, Bokaro General Hospital. Dr. S.K. Kirolkar sir, former Joint Director, JLNHRC Bhilai. Thank you. I request the chairpersons to please conduct the session. I would invite Dr. Amit Dravid on the dais, please.
Very good afternoon, everyone in this session. I feel privileged to chair this session for infectious disease after a pandemic of corona. The days we were in the medical graduate students at that time, around 80s and 90s, the HIV was like that. But now, lot of being resolved, and we are in the day, today, all patients to be treated. So, it is a chronic disease and not patient to be treated. To enlighten us the basics of the HIV and the therapeutics, we are having with us Dr. Amit Dravid. He is an consultant in HIV medicine and infectious disease in Ruby Hall Hospital. He has an advanced course in HIV medicine in France, awarded scholarships to attend the research courses in HIV medicine, and a junior researcher award of 11th International Congress in Drug Therapy in HIV Infection, Glasgow, UK. He is a member of American Academy of HIV Medicine, AIDS Society of India, a member of International AIDS Society, and member of European AIDS Clinical Society. So, with this introduction, I request my co-chairperson to say a few words.
It's really a matter of pleasure to have gathering like this. Good afternoon, everybody. And the field of HIV is enormous. And with the recent past pandemic of COVID, the subject has been given less importance. It is better to have listened to have a speaker, Dr. Amit, who is from Pune, about this menace known as HIV. I request him for his deliberation. Please.
Thank you, sir, and thank you, Jawaharlal Nehru Hospital and Research Center, Bhilai, for inviting me all the way from Pune, and thank you, my friend Dr. Binaike and my friend Dr. Amit Agrawal, whom I am meeting after almost 20 years. So, as sir has rightly said, I am going to talk about HIV and antiretroviral therapy. And last 3 years, we were treating only COVID. And we suddenly forgot that there was another epidemic which was smoldering in our country. We are still reporting around 60 to 80,000 HIV cases every year. And we have been the third largest HIV affected country in the world. So we are still having a big HIV pandemic to cater to. We have around 22 lakh people in India who are HIV affected, out of which almost 15 lakh are on antiretroviral therapy. So you can see the big number which we are treating. So in the next half an hour, I'll try to tell you a bit about where HIV treatment is today and where it is going tomorrow. And hopefully, I'll try to make a very complicated topic easy for you. So, where are we in 2022? When do we start antiretroviral therapy? It is very clear, we start antiretroviral therapy on day 1. So, we don't even wait for the CD4 count of the patient to come back. If the person is there in our OPD, he is found HIV positive, and you are reasonably ruled out that there is no opportunistic infection for this patient, you can start antiretroviral therapy on day 1. No need to wait for the CD4 count to come back. So whether the CD4 count is 20, it is 50, it is 500, it is 1000, it is immaterial. Everybody goes on antiretroviral therapy. So the mantra is antiretroviral therapy for all, irrespective of CD4 count. Whether the CD4 count just doesn't matter. All that matters is the physician rules out opportunistic infection. So once you have ruled out opportunistic infection, just start antiretroviral therapy and continue it for life. But the problem is, every patient who comes to us has some or the other opportunistic infection. Almost 60% patients in our OPD come with HIV and another opportunistic infection. And that is when the consultant decides what is to be done. So there also the guidelines are clear. If antiretroviral therapy is the only treatment available for that opportunistic infection, that means the patient has come with HIV-associated diarrhea, cryptosporidiosis, microsporidiosis, where there is no other treatment available, or PML, where there is no other treatment available other than antiretroviral therapy, start it on day 1. What about tuberculosis? What about PCP? In tuberculosis, first treat the tuberculosis. Within 15 days, once the patient has tolerated the anti-tubercular therapy, start on antiretroviral therapy. So within 15 days, you can start, after starting anti-tubercular therapy, you can start on antiretroviral therapy. What about PCP? What about toxoplasmosis, where specific treatment is available? Again, guidelines say first treat the PCP, first treat the toxoplasmosis, within 15 days, start on antiretroviral therapy. What about malignancy? Many patients are today coming to us with lymphoma, cervical CA. What to do then?
There again, it is clear that if you put the patient on chemotherapy and antiretroviral therapy, there the prognosis is much, much better. So if you have a patient of HIV-associated lymphoma, give the chemotherapy and antiretroviral therapy together on day 1, the prognosis of the patient is far, far better. The only two instances where we stop antiretroviral therapy and treat the OI for a longer time is tubercular meningitis and cryptococcal meningitis. So these two CNS opportunistic infections, you treat the CNS opportunistic infection first. So you give the antitubercular therapy, you give steroids, treat the patient, treat his headache, reduce the intracranial pressure, wait for almost 4 to 6 weeks, and then start antiretroviral therapy. And why do you do that? Because if you hasten with antiretroviral therapy, the tubercular meningitis or cryptococcal meningitis can worsen, the patient can have increased intracranial pressure and die because of your antiretroviral therapy. So only in tubercular meningitis and cryptococcal meningitis, you wait for almost 4 to 6 weeks, rest everywhere, you hurry the antiretroviral therapy so that it starts early. Now we know when to start. Then the question arises, what to start? So what to give to these patients? So the question needs to be asked as, what do we want to achieve by starting antiretroviral therapy? So WHO has clearly given us guidelines that every country in the world has to attain something which is called as 90-90-90. So every country has to identify 90% of the epidemic, out of which 90% have to go on antiretroviral therapy, out of which 90% have to be virologically suppressed. So this is the guideline given even to India. But where are we? In 2020, we have identified only 79% of our epidemic. So out of 22 lakh, we have only identified around 18 lakh, out of which only 70% are on treatment. That means only around 10 lakh are on treatment. And how many are virologically suppressed? We don't know, because we don't do viral loads routinely for all our patients. So maybe only half of our patients are on antiretroviral therapy, and how many are suppressed, we don't know. So we have a long way to go while controlling HIV, and then people ask, when will HIV end? It won't end until India achieves 90-90-90, and we are way far behind that. And why it is more concerning is because an African country, Botswana, which is very, very poor than us, has achieved something called as not 90-90-90, but 95-95-95. That means they have identified 90% of their pandemic, they have put 95% of them on treatment, and 95% of them are virologically suppressed. So Botswana today, a small African country, a much poorer country than us, can boast that they can stop the HIV epidemic by 2030, but India doesn't know. So if you want to stop HIV as a public health emergency by 2030, we have to achieve this. So then what are the options in front of us? Are there any drugs which we can give so that all of our patients can be on antiretroviral therapy, all of them can be suppressed, and we can say safely that we can make HIV a less dangerous public health emergency? Yes. In 2022, there are 5 drugs which I am going to talk about, which can be given to our patients, and they can suppress HIV to a big extent. Number 1 is dolutegravir, second is bictegravir, third is a new version of tenofovir, which is called as tenofovir alifenamide fumarate. Then there is efavirenz, our old drug, but at a lower dose, 400 milligram, and a protease inhibitor, which is darunavir. So first we go to dolutegravir. What was the study which proved that dolutegravir is better than efavirenz? This was a study published in NEJM, where they compared a single pill of abacavir, lamivudine, dolutegravir against our old drug which we used to use, that is tenofovir, lamivudine, efavirenz, and found that it was virologically and immunologically superior. So for the first time, a drug was found superior to efavirenz, which we were using for almost 10 years. Not just that, they found that the virological and immunological superiority is not because the drug is virologically superior, but it has less side effects. So any of your patients who has got efavirenz will tell you that patients keep telling कि sir चक्कर आता है, sir घूमता है, concentration नहीं जमता है, and this is seen in almost 10 to 20% of our patients. So in 2014, 2015, almost 20% of our patients who were on antiretroviral therapy used to say that sir, I can't concentrate. Especially truck drivers, they said, I get sleepy at night. I can't concentrate on driving my truck. I feel I might get into accidents. I feel depressed. And because of which they were discontinuing that antiretroviral therapy. But now there is a new drug, which is dolutegravir, where the side effects are only 2%. So you can see it is far, far better. So virologically superior, immunologically superior, less side effects, because of which dolutegravir became the drug of choice. Then people said that, okay, but efavirenz we could use with rifampicin, and 50% of your patients are HIV TB co-infected. So can dolutegravir be used with rifampicin? The study came saying dolutegravir can be safely used with rifampicin. As you know, rifampicin is an inducer of the hepatic enzymes, reduces drug levels. That's why efavirenz 600 can be safely used with rifampicin, but here you have to give double dose of dolutegravir. So double dose dolutegravir with rifampicin, safe in tuberculosis, TB HIV co-infected patients. Then they said that what is the role in pregnancy, and then there came a paper in NEJM which said that dolutegravir might be associated with higher neural tube defects. And then it created a problem, because if you are going to give dolutegravir with tenofovir lamivudine in pregnancy and you have neural tube defects, then there might be babies who are born with anencephaly. And then they said, okay, let's not give it in pregnancy. But more and more data came out saying this is not so. This was a retrospective observational study. When they did it in a randomized control trial, they found that the risk of having neural tube defects was same as efavirenz, same as dolutegravir. And especially if you give your pregnant women folate tablets every day, then the risk of neural tube defects is far, far lower. So not giving dolutegravir during pregnancy and insisting on efavirenz today is actually causing more problems than giving dolutegravir in pregnancy. So dolutegravir is safe in pregnancy, dolutegravir is safe in tuberculosis, dolutegravir is safe in normal HIV infected patient as well. Does dolutegravir have no side effects? No, it does have side effects. Some of them are neuropsychiatric adverse events where patients can complain of small amount of insomnia. But as I said, efavirenz side effects are seen in almost 20% of patients. Dolutegravir side effects are seen in only 2% of patients. So almost out of 100 patients, if you give dolutegravir blindly, 98% will be virologically suppressed. Only 2% will discontinue the drug because of adverse events. What about bictegravir? It is another brother drug of dolutegravir. It also an integrase inhibitor. And there are trials which have proven that tenofovir, lamivudine, bictegravir, which is also available in India as a single pill. So tenofovir, lamivudine, dolutegravir is available as a single pill in India. Tenofovir, lamivudine, bictegravir is also available as a single pill in India, although in the private sector, not in the government sector. It was found that even bictegravir is doing virologically and immunologically very, very well. Almost 90% of our patients are suppressed and doing well virologically and immunologically. So the WHO guidelines then changed in 2019, and WHO made it very clear that from now on, we are not going to use efavirenz as the first line drug. Tenofovir, lamivudine, dolutegravir will be the most preferred first line antiretroviral therapy. And now in government sector as well as private sector, it is available as a single pill. Out of 15 lakh patients, almost 12 lakh are on tenofovir based, tenofovir, lamivudine, dolutegravir based first line antiretroviral therapy in India. What do Americans say? Americans say you can use bictegravir as well in addition to dolutegravir, but it is still not available in the free ART centers of India. It is only available in the private sector. What about TLE400? So this is, what is TLE400? It's our old packaged drug in a new bottle. What we were using is tenofovir, lamivudine, efavirenz 600. Then why did we suddenly shift to TLE400? Why did we reduce the dose of efavirenz by 200 milligram? Because more and more data came out over the last 10 years saying that if you keep going with efavirenz, then the risk of suicidality and the risk of actually committing suicide is double. So any drug which is associated with suicidality or the patient killing himself has to be withdrawn or the dose has to be reduced. So the people said that fine, let's not give 600 milligram, let's try 400 milligram. Let's reduce the dose and see whether the same thing is repeated. So they compared head to head TLE400 versus TLE600, and they found that by reducing the dose by 200 milligram, the virologic efficacy was not changing. Virologic efficacy was the same. Immunologic efficacy, same. And the side effects came down by almost 15-20%. So all this while, we were overdosing our patients. We were giving excess dose, but because in 2005 there was such a global health emergency, everybody wanted to push out the drug at the highest dose. We ended up giving 600 milligram to our patients when 400 milligram was also enough. So TLE400 was doing as better as TLE600. Then they said that it's fine, then let's compare TLE400 with dolutegravir. And they found that even against dolutegravir, TLE400 was doing same. It was virologically doing same. Across viral loads, it was doing same. Then they said, what about rifampicin? TLE 400 or efavirenz 400 given with rifampicin was doing well even in HIV TB co-infected patients. What about pregnancy? TLE 400 was doing well in pregnancy as well. So across the board, pregnancy, tuberculosis, everywhere, a lower dose of efavirenz was doing well and the side effects were coming down drastically. And then we realized that for the last 10-20 years, we were unnecessarily overdosing our patients. And this is a problem with HIV, that now with decades of antiretroviral therapy, we have realized that we might be overdosing our patients. And there is another study where 200 milligram of efavirenz is coming up. Maybe it will prove that even 200 milligram of efavirenz was sufficient, 600 milligram was not necessary. So WHO has said that TLD or tenofovir lamivudine dolutegravir will be our first choice antiretroviral therapy, and TLE 400 will be our alternate antiretroviral therapy. So these two now are established as our first line preferred and alternate antiretroviral therapy. What about TAF? What is TAF? It's just a new salt of tenofovir. What we have today is tenofovir disoproxyl fumarate, which we use for HIV, which we use for HbSAg, but it has bone and kidney toxicity. TAF is a new salt of tenofovir, and it has very, very low toxicity because it does not go to the renal tubules, it does not go to the bone, does not cause nephrotoxicity, directly goes and destroys the HIV in the cell. And study after study has proven that by removing TDF and putting in TAF, virologically and immunologically the patient is doing the same. So now hopefully maybe 2-3 years down the line, Government of India will also remove TDF and put TAF as the preferred tenofovir in our regimen so that we have lower bone and kidney toxicity in our patients. What about pregnancy? People said that fine, but TDF was safe in pregnancy. What about TAF in pregnancy? Now studies have shown that in fact TAF can be safer than TDF in pregnancy. So not just it suppresses HIV during pregnancy, other pregnancy adverse events like stillbirths, low birth weight babies, earlier premature births are lower when you give a tenofovir alifenamide based regimen than a TDF based regimen. So for pregnant HIV infected patients, TAF with dolutegravir can be a very, very good regimen. Even in tuberculosis, TAF can be safely used with rifampicin. So everywhere now, maybe 2 years down the line, we will be replacing TDF with TAF. Does TAF have no side effects? No, that is not the case. No drug has a side effect. Just like dolutegravir had insomnia as a side effect, TAF has something which is called as weight gain. So if you give TAF with dolutegravir, we are suddenly finding that our patients initially used to say that I have no issues, but today they are coming back saying, doctor, I have had 10 kg weight gain in six months. I have had 20 kg weight gain in a year. So now my patients who initially used to look thin, they used to look malnourished, today are looking obese, and we have now had to perform obesity surgeries for 2 of our patients because their weight went from 80 to 160 kg in 2 years. So that has happened, and maybe TAF and dolutegravir both are contributing to the weight gain. So maybe 4 years down the line, I'll be saying that don't use dolutegravir, don't use TAF, because it is causing too much weight gain, and that weight gain is causing lipids being deposited and causing higher risk of cardiovascular illnesses. So this is a continuum, this is a science which we are still knowing, but TAF, although today looks like a very good drug, does have an adverse event in inordinate weight gain. So we know that first line antiretroviral therapy, we use tenofovir lamivudine dolutegravir, and as an alternate regimen, we use tenofovir lamivudine efavirenz 400. What happens when the patient fails first line antiretroviral therapy? And almost 20% of our patients will fail first line antiretroviral therapy. So this study was done to compare whether using dolutegravir in second line is superior to using protease inhibitors in second line. And it was found that instead of using protease inhibitors in second line like atazanavir and lopinavir, if we compare it with dolutegravir plus 2 NRTIs are doing better than protease inhibitors plus 2 NRTIs. So WHO had to change the guidelines saying not just first line, even second line as a backbone, you have to give dolutegravir plus 2 NRTIs. So WHO made it clear that if your patient is on older regimens like zidovudine, lamivudine, nevirapine or tenofovir, lamivudine, efavirenz and he fails, then for second line give dolutegravir plus 2 new NRTIs. If the patient is on dolutegravir in first line, then you can use protease inhibitors in second line. Further studies confirmed that you don't even need to change the NRTI. So if the patient is on tenofovir, lamivudine, dolutegravir and he fails, you can just use tenofovir again in second line. You don't need to shift from tenofovir to zidovudine. What is the future? We know that first line is TLD, first line is TLE 400, second line also we are using dolutegravir. What is the future? The future is 2-drug therapy. Initially, we were harping for last 20 years on using 3 drugs, tenofovir, lamivudine, dolutegravir, tenofovir, lamivudine, protease inhibitors. But gradually, we are moving towards just 2 drugs being sufficient. And those 2 drugs are, one is dolutegravir, the second is lamivudine. And now trials are showing that if you are on first line antiretroviral therapy, you have never failed in the past, and you are virologically suppressed on say tenofovir, lamivudine, dolutegravir or tenofovir, lamivudine, efavirenz, just shifting you to 2 drugs, dolutegravir and lamivudine, 2 drugs alone can maintain your virologic suppression for a very, very long time. So maybe the future, I'll not be talking about triple drug antiretroviral therapy. I might be talking about just 2 drugs being sufficient for suppressing the virus. And the most exciting discovery is about injectable antiretroviral agents, that is cabotegravir and rilpivirine, which has come up, where I can tell my patients maybe 2-3 years down the line that you don't need to take 1 pill once a day. You just need to take 1 injection every 2 months. 6 injections in a year and you will be virologically suppressed. Tell me which chronic manageable illness can today boast of taking just 1 injection every 2 months? None. Even diabetics can't do it. So gradually HIV is becoming a chronic manageable illness, so easy to manage that maybe we will have just 1 injection every 2 months and tell the patient that your chance of virologic suppression might be more than 95%. So we can actually eliminate HIV as a problem. If these injectable agents come, just tell our patients take 1 injection, come just 6 times in a year to meet me, take 1 injection and you will be fine. The problem is different. Today, with antiretroviral therapy, my patients are living for decades, not for years. So in US, people are telling their patients that if you are 20 years of age, on antiretroviral therapy, you will survive for 50 more years. Today, our patients are entering their 60s, their 70s, our 80s. We have had a bypass surgery done yesterday for a patient who was 75 years of age and 20 years on antiretroviral therapy. So this is the success. But as the patients are aging, we have found that infectious complications have gone down and our normal medical issues have started cropping up. So today my patients are dying because of heart attacks, of strokes, of cancers, hepatic cancer, renal failure. Today we need dialysis services for our patients who are going into chronic kidney disease requiring dialysis. So HIV and aging especially is a problem, and in the US they are saying that 83% of their patients are now above 50 years of age and 60% of patients have at least 1 comorbidity. So you can see HIV with diabetes, HIV with hypertension, HIV with kidney issues, HIV with liver failure, HIV requiring liver transplant, HIV requiring dialysis, HIV requiring cataract surgeries, HIV requiring hip replacement, knee replacement surgeries. Today is a reality and almost 70% of our admissions are just catering to lifestyle issues. Finally, what about PEP or post-exposure prophylaxis? We are all worried about it. Everybody gets a prick one day or the other. There also the drug of choice is tenofovir, lamivudine, dolutegravir. So the drug of choice now has changed everywhere. Even for post-exposure prophylaxis today we are giving tenofovir, lamivudine, dolutegravir. So in conclusion, dolutegravir and bictegravir are the preferred backbones of first-line antiretroviral therapy for naive patients. TLE 400 is an acceptive alternative. TAF or tenofovir alifenamide fumarate is a new addition, and it's an exciting addition because it will take care of the bone and the kidney toxicity of TDF. Dolutegravir based antiretroviral therapy still remains our top choice for first line and second line antiretroviral therapy, but maybe in the future we will have 2 drug and injectable regimens, and we will tell our patients just take 1 injection every 2 months and you will be fine. Cabotegravir, rilpivirine is the first injectable antiretroviral which is coming, but I am sure in the next 5 years there will be many injectable antiretrovirals. Just like cancer chemotherapy, HIV will also become an injectable antiretroviral regimen, depot preparations, maybe 2 months, every 6 months patients will come and take antiretroviral therapy. However, these drugs are still given to only HIV mono-infected patients. For HIV and Hep B co-infection, still tenofovir based antiretroviral remains a drug of choice. My patients are aging, and with aging comes other issues, medical issues, and they have to be tackled as and when needed. Thank you for your patient hearing, and I'll take whatever questions come my way.
Thank you, Dr. Dravid. A very nice and lucid talk. The complicated things to be made very easy. Now the session is open for discussion.
Yeah. Thank you, Dr. Amit, for highlighting talk and giving the update on the latest development on HIV. I was part of this HIV control program 2 decades ago when Bill Gates started in some 4 South Indian states and 2 Northeast Indian states as a 6 high priority states. So that time the NACO's guidelines are very few. So we are learning from the African and Western countries. So that time it was 500, CD4 count below 500 used to start the ART. Now it is from the beginning. That's the universal ART is in force. And coming to the TB as a co-infection, that is the largest killer of HIV patients. That's the largest, one of the most largest killer of HIV. Now that is also under control. I remember in 2008 I attended a meeting with WHO Geneva, where we brought out 3I initiative for HIV-TB co-infection prevention in developing countries. That is infection control, intensive case finding, and INH prophylaxis. Are we still following that 3I initiatives here?
Yes, sir, we are following, and isoniazid prophylaxis is now a mass program for every HIV positive patient who follows up in the private or the government sector. Every person gets minimum 6 months of isoniazid provided active TB is ruled out.
Yes. So
And we also have now gene expert machines everywhere to pick up for intensive case finding of tuberculosis.
Yes. And other thing to remember from the past is the HIV-TB co-infection. They used to say that ART not an emergency, ATT you have to start first, then you start the ART. What happens if after starting the ART a patient develops TB? Whether you have to stop the ART to initiate, and then after 2 weeks you can restart to prevent IRIS.
Sir, excellent question. So we always say that if you develop tuberculosis after starting antiretroviral therapy, there are only 2 cases in which there is an emergency. Number 1 is tubercular meningitis or tuberculoma, or sometimes there is mediastinal lymphadenopathy which becomes so large that it chokes the trachea. Or severe pericardial effusion which causes cardiac tamponade. In these 3 cases, if you start antiretroviral therapy and these 3 conditions happen, then you can temporarily stop antiretroviral therapy, treat the TB, give steroids, get rid of the iris, and then restart antiretroviral therapy after say 4 weeks. In all other conditions, you treat through. So if you just have mediastinal adenopathy or say inguinal adenopathy or pulmonary TB, after starting antiretroviral therapy, you give antitubercular therapy and treat through. You don't need to stop antiretroviral therapy in that case, because stopping antiretroviral therapy is again giving an invitation to non-adherence and resistance. So these drugs can get resistant. They might not work once started again. That's why only in 3 conditions, which is meningitis, pericarditis or cardiac tamponade, and large mediastinal adenopathy compressing the trachea, all other conditions you treat through. Otherwise, temporary stoppage for 4 weeks.
Another good development on HIV management now is, that time in 2004 when we started, our aim is to integrate the HIV services into general health system. That is, HIV is not a specialized treatment, need not go to ART centers. That should be integrated into the government health services. So any physician should be able to treat. So that time there was a shortage of ART physicians. Then we created a 1-year diploma course in Bangalore, 2 medical colleges, Kempegowda Medical College and 1 in Mysore. So we created 1-year diploma course accredited to Rajiv Gandhi University to create the pool of ART doctors that time. It was a short running. So now the system looks good.
Absolutely.
Thank you, Dr. Amit Dravid, for nice presentation. And my question is, it is a very common observation that we are switching from TLA to TLD regime in our hospital also. Whatever our stock of TLE was there, we have consumed and we have switched over to TLD. One common observation we are observing, we are facing that when we do the viral load and CD4 count during the switchover, many patients, they have an undetectable viral load, but in spite of that, they have a low CD4 count. So it is a very common observation. So how to manage that? And
So this is called as immunologic virologic discordance, where the viral load is suppressed, but the CD4 is not good. Many times this happens because the patient is on zidovudine as first line, because as you know, zidovudine is a bone marrow suppressant. But many times it is also seen with tenofovir. If your patient is symptomatically okay, I would suggest leaving it as it is, just changing him over to TLD, TLD will do its job, and maybe over 1 year, once the weight starts rising, the patient starts feeling better, the BMI is going to rise once dolutegravir is given, the CD4 also will follow. Many times what happens is non-rising of CD4 is linked to when did we start antiretroviral therapy. So if you have started your antiretroviral therapy at CD4 was 4, 10, 20, then even after 10 years it is not going to become normal, because some amount of immunological damage is permanent. That's why we always say that start antiretroviral therapy early, because if you start at 350, you will reach 1000 faster. If you start at 10, 20, 50, it's quite a chance that some of the memory CD4 cells will be permanently destroyed. So this whole concept that the destruction of CD4 cells by HIV is temporary is a myth now. Sometimes it is permanent. Some of the memory T cells are permanently wiped out. So even patients on 20 years antiretroviral therapy we have, who have started at CD4 count of 8, today are still at 160, 170. And once your CD4 count remains below 500, you are at risk for non-HIV related comorbidities. So these patients who are having heart attacks, these patients who are having strokes, these patients who are going into chronic kidney issues, these patients who are going into liver cirrhosis are all those who have a CD4 count less than 500. So getting to 500 fast should be the goal, because 500 to 1500 is a normal person's CD4 count. So if you take my or your CD4 count, just do it in some lab, it will be around 700, 800, 900, this will be a range. Our patients have to reach it to stop all these things. So if your patient doesn't reach it, either because he is not taking antiretroviral therapy regularly or you have started late, this is going to be the issue. So your patients will be in that window where he will not die from TB, he will not die of cryptococcal meningitis, he will not die of PCP, but he might have a stroke, he might have a heart attack, because that residual inflammation, now it is clear that it is not just an infective issue, it is also an inflammatory issue. Just like we realize that COVID has an inflammatory phase, HIV also has an inflammatory phase which goes along with the infective phase. The virus might come down, but the inflammation doesn't stop. The inflammation will continue till your CD4 doesn't get normal. And if it doesn't get normal, the inflammation will continue, your heart attacks will continue. That is the problem. Sir, there have been trials which have shown that in developing countries, giving cotrimoxazole 1 tablet with ART, irrespective of the CD4 count, is actually better than stopping it at 200. So, because it is so cheap, it is just a 50 paisa tablet per day. Giving it in our setting, especially if your patient has not reached a normal CD4 count, makes sense. And we can give it, not a problem.
It's an excellent presentation. As we are dealing, just like sir, we are dealing so many patients on TLD now. So what is your observation of, we are facing two problems with what we are observing is one, those we are having a aging population, increased age population. We have patients of HIV on ART like 10 years, 12 years. So even the young diabetics, if they got HIV, and we started on TLD, so they have a derangement in their blood sugar level, number one. And what is our observation in Medical College Raipur is that those patients, I think, but what does the mean whether we are missed somewhere around 2 years of this COVID, they have more of a nephrotoxicity in comparison to the TLE.
Okay.
So what is my observation? I just in my COE interaction, I just pointed out this event that with TLE, in comparison to TLE, whether TLD has a more toxicity, whether it is because of tenofovir or some dolutegravir is also responsible. What is your experience?
Sir, excellent question. And I'll take that nephrotoxicity question first, because dolutegravir is known to cause a self-limiting rise in creatinine. So if your patient is on TLD today, you start TLD today, his creat is 1. Be rest assured that without nephrotoxicity, his creat is going to go to 1.5. Why does that happen? Is because what dolutegravir does is it prevents proximal tubular secretion of creatinine, so that creatinine goes back into the blood and starts rising. But this is not pathological. So many times I tell my patients that even if you have started your TLD at a creat of say 1.3, 1.5, it goes up to 1.8 or 1.9. We don't change the treatment. We ask the patient, are you symptomatic? If he is symptomatic, saying nocturia, dysuria, weakness, breathlessness, vomiting, nephrotoxicity, change the drug. But if the patient has no side effects, he says, I am doing perfectly fine, I have no nocturia, no dysuria, but still my creat is 1.8, this is just a self-limited rise, you do nothing. So that nephrotoxicity is not a real nephrotoxicity, it's a lab-based nephrotoxicity because of what dolutegravir is doing. Just like in atazanavir we were seeing indirect hyperbilirubinemia, in dolutegravir we are seeing slightly high creatinine. That can be disregarded depending upon the symptoms. So the symptoms are very important. Your patient having no symptoms with creat of 1.8, I would do nothing. But if the creat goes about 2, yes, I will change his treatment. That's where the 2-drug antiretroviral therapy comes in. So the tenofovir gets knocked off, just dolutegravir 3TC, the creatinine will come down. Secondly, about diabetes, many of our patients are having dysglycemia, incident diabetes, deranged lipid profile, weight gain and metabolic syndrome. So now we are going from one end of the pandemic to the other end of the pandemic, where our patients were thin, lean, malnourished, where now our patients are fat, obese, metabolic syndrome and coming with treatment for diabetes, blood pressure and heart disease. So this is just a change. We have to be settled somewhere in the middle. So every time my patient goes on dolutegravir and starts showing dysglycemia, I tell them, control your diet, control your exercise, start losing weight, because if you don't lose weight, then I know where this is going. So along with that, a healthy lifestyle is also important. Initially, we did not harp so much upon a healthy lifestyle. Now with such spectacular virologic suppression rates and with such spectacular improvement in the patient's lifespan, we are talking about 50 years, we have to now start saying that a healthy lifestyle is also very important.
Sir, one line.
Well,
If
thank
the
you, Dr.
patient-
Dravid,
patient,
for excellent exposure of your subject.
Thank you, sir.
The bottom line is only, forget about the CD4 count, hit the virus early and hit the virus hard.
Hard, yes, sir.
Thank you.
Absolutely.
One last question. If the patient is very well controlled on all earlier antiretroviral drug, do we need to change them to dolutegravir? Because these patients have been for 15 to 20 years.
Yeah.
Today we are talking about drug resistance,
Yeah.
the CD4 count's not picking up and all these things.
Sir, excellent question. If he is on TLE and doing well, I would not change. But the problem is the government is stopping the manufacture of TLE.
what, yeah.
So it won't be available very soon. So you'll be forced to shift to TLD.
And
So
one more thing, they're changing over. Sometimes they're giving dolutegravir and they're going back again to the back
Correct.
thing. Is it correct? Or should
no, it is not correct. We should stick to one drug. So instead of giving TLE, you can give TLE 400 because then you are keeping the same drug. But government is very soon going to stop manufacturing of 600. So if your patient is on 600, either he goes to TLD or he goes to TLE 400, but he can't be on TLE 600. That is clear.
I missed your point on cotrimoxazole. Please come again.
If your patient is on antiretroviral therapy and you decide to give all your patients one tablet of cotrimoxazole for their life, you're not wrong. So that 200 ceiling is not, it's arbitrary because our patients still have loose motions, diarrhea, bacterial infections, pneumonia, which all can be prevented, urinary tract infections, where cotrimoxazole is an excellent drug. And with antimicrobial resistance, older antibiotics like cotrimoxazole are now back in vogue. So if you give it for life, that's not a problem, you are doing the right job.
Thank you. Thank you very much.
Thank you. We conclude the session.
Thank you, sir. I appreciate the time you took out for this interesting and informative presentation, which kept the audience glued to their seats and have all benefited. I request Dr. B.B. Karuname, sir, and Dr. S.K. Kirolekar, sir, to please honor our guests. I request Dr. Amit Dravid, sir, to present our chairpersons with a token of gratitude. I request the participants of the MBBS poster presentation to go down to the dining hall for the poster evaluation. I request the judges, Dr. Rajiv Lochan Khare sir, Dr. Yogendra Malhotra, Dr. Chetan Anand to proceed downstairs to the dining hall, Dr. Parag to escort them. Due to time constraint, we will now go on to the next session and you can please take your tea in between. I now call upon Dr. Gayatri to continue.
Good evening to all my respected seniors and my dear colleagues. Today's most awaited topic is on debate on the topic teleconsultation. Due to the pandemic of COVID-19, teleconsultation made its presence noted significantly as a tool for consultation without any form of contact with the doctor. but its history of teleconsultation runs way back to the late 1950s by Nebraska Psychiatric Institute for psychiatric consultations for the first time. With the advent of this, live video consultations have been linked to teleconsultation, gaining a strong foothold in medical sciences. However, there are always pros and cons for any technology linked with manpower, like two sides of the same coin. Here, I welcome our most distinguished speakers, Dr. Dev Sanjay Nag from Tata Steel Plant, to side with the teleconsultation, and Dr. Kaushalendra Thakur sir from Bhilai Steel Plant, who contradicts to our today's topic, can teleconsultation be a part of hospital policy from their own perspectives? Now, I request our Honorable Chairpersons, Dr. Prakash Kudur sir, CGM from Visakhapatnam Steel Plant, and Dr. S.K. Tamer, former Director in charge of Bhilai Steel Plant, to chair our sessions. Sir, please. Each participant has 10 minutes to point their views and 3 minutes is open for discussion.
Hello, hello. Good afternoon, friends. On behalf of myself and my co-chairperson, as we all are waiting for this topic, I congratulate the organizers for choosing this topic. We recall the early morning session, inaugural session, where our chief guest narrated all the difficulties of COVID that we all medical fraternities felt. And this COVID has taught us so many lessons. But there are still many lessons to be learned. One of such lessons was the telemedicine, which came into vogue largely in our country and many other countries. And this is telemedicine. But there have been certain problems with telemedicine. And for this, the organizer has very rightly chosen this topic for the debate. The topic is open, and Dr. Dev Sanjay Nag, Tata Steel Plant, will be speaking for the topic. And after that, Dr. Kaushalendra Thakur from Bhilai Steel Plant will speak against the topic. So, Dr. Nag, the stage is yours.
Thank you so much, sir. And first of all, I'd like to thank the chairpersons and the distinguished guests in the audience and the organizers for making my work so easy. Actually, this slide is a straightaway giveaway which side the balance of this debate is tilted. I think this one slide is sufficient enough to tell you which is better. Should we have a teleconsultation as a part of a hospital policy? Obviously, it's yes. There is no question of a no. So I'll go about my talk with 3-4 topics. One is justification of the need.
Second is what it entails. Third is what are the legal formalities, why it is necessary and why today it should be a part of the hospital policy. And last, as we all doctors know, we practice evidence-based medicine. So what does the evidence say? So this is how I intend to have my talk. And see, I set my context with the WHO because Madam was speaking as the keynote address from the WHO. The UN has actually set out for the Sustainable Development Goals for 2030. Health is actually one of the primary ones. But how do we achieve that? To give the community access to good health care, what you will see is all the 5 pillars which are necessary. Availability, affordability, accountability, adequacy and appropriateness all actually constitute something. The pillars are actually built upon teleconsultation. Now coming to the health crisis in the country, we all know in India the balance of doctors is extremely skewed and we are facing a crisis about providing adequate health care to the community. So based upon these inputs, the Public Health Foundation of India along with Center for Digital Health, they have actually suggested what we should be doing. And 3 of the key pillars of that initiative is create innovative models through digital means, use digital health to promote equitable distribution of healthcare facilities, and lastly improve the quality through tele-education. So all these 3 pillars are actually based upon the teleconsultation. Now coming to the definition, what is telemedicine? Definition wise, it is an innovative system using telecommunication to provide healthcare. But what is of importance here is how the WHO defines it. Telemedicine is delivery of healthcare of services where distance is a critical factor and we provide it through the telecommunication modes. But the last line I think I'd like my co-speaker to read. It is in the interest of advancing health of individuals and their communities. So I'd request my co-speaker not to speak anything which is against the interest of the advancing health of individuals and communities. Now, telemedicine is actually teleconsultation. हम लोग इसको संधि विच्छेद करके नहीं देखते हैं as tele and consultation. It is actually a combination of consultation using AI, using visual technology, using remote monitoring, using even something like an Apple Watch, your remote monitoring of your ECGs. So everything is available and it is disrupting the way we are actually providing healthcare to the community. There are various capabilities which are built in teleconsultation. The primary is the chronic health management. We are now slowly moving towards the aging community. Chronic diseases are coming up in a big way. So chronic health management, care follow-up, hypercare and chronic pain management, all the diseases which are chronic in nature, it is provided through that. Next is throughout care. So follow-up. Many a times a follow-up, it shouldn't entail a visit to the hospital. Telecommunication can be used for that. Next is prescriptive compliance. The compliance, whether your patients are compliant to that, whether telecommunication can put up a pill reminder or not. All these actually constitute telemedicine. Store and forward. We are already always threatened with medical records getting disturbed, destroyed. If it is there on a cloud, it is there for posterity. So the benefits of telecommunication, teleconsultation as we call it is, it constitutes of education of the doctors, of the patients about how to take care of the health, adherence to the healthcare benefit, monitoring as I just said, remote monitoring, patient-physician interaction. My co-speaker might make a passionate plea that the connect is not very good, but actually data and evidence show that the patient-physician interaction increases manifold. The benefits, it reaches out to unserved population, increases the pool of potential patients for the doctors, and the patients also get an increased pool of doctors to consult with. And there are things not only for practice point of view, but lot of it from the patient point of view. They don't have to travel for a repeat consultation. Not waiting as long as to be seen for an element. You don't have long wait times outside your chambers. Not worrying about shortage of local specialists. We all know specialists, super specialists, there is a worry about availability. What are the advantages? So availability, time efficiency, time management and access to electronic health records. These are the keys what we are looking at as the advantages. And increased access to healthcare, convenience, low cost, these are all the advantages telemedicine provides us today. So let us not debate that it is not needed as a hospital policy. The benefits are for clinicians as well as healthcare organizations trying to provide better care, especially like ours, there is a steel company involved. So possibly for the first time on a AISMOC platform, you are seeing artificial intelligence generated answers also whether telecommunication is needed or not. It increases the convenience, increases accessibility, reduces wait time, improves continuity of care, cost savings obviously to the patients, increased flexibility is there. And just to show that we at Tata Main Hospital has been progressing enough also to think about it, before the government came up with this policy, on 24th of March 2020, TMH came out with the teleconsultation policy, and on 25th, Government of India came out with this policy. So telemedicine practice guidelines, which actually is coming out of the Government of India, they are actually giving us the legal framework to practice telemedicine. So there is no confusion that telemedicine should not be a part of the policy. The government has defined it, the courts have authorized it now, and it is within the legal framework. So that is why it constitutes the Appendix 5 of the Indian Medical Council. The NABH hospital accreditation, which TMH is an NABH accredited hospital, and it needs the care of patients. Chapter 1, it says that telemedicine faculty is provided safely and securely based on written guidelines. So the NABH requirement states that you must have a telecommunication policy in place. So where is the question of the hospital not having a telecommunication policy? And this is the Government of India's website. We have had more than 9.2 crore teleconsultations. So what are we discussing, that whether we should have a policy or not? The answer is given here. And we all as doctors look for evidence. There are more than 60,000 publications. But what we know is level of evidence 1 is the highest level of evidence medical science can provide. It is the systematic review analysis. So there are many such examples. This is one systematic review analysis which actually shows that telehealth modalities including telephonic outreach and specialized tools designed to increase health literacy, e-health and telehealth medicine adherence. It improves the MPR. MPR is nothing but medicine possession ratio, and PDC is proportion of days covered by the medicine, especially for the chronic medicines like hypertension and diabetes. So it is given, systematic review is actually showing what the evidence is. Similarly, the review supports that hypothesis that interactive e-health intervention can be effective in improving medication adherence. So we have large randomized controlled trials as well as systematic reviews which actually tell us that telecommunication is the way forward. No hospital can work without a policy which should have telecommunication as the part of the hospital policy. And at Tata Main Hospital, we have actually fortunate enough to have the IT framework and support from the organization. We have the telecommunication modes built into our HIMS modules. We have the video consultations. We have the telephonic consultations on our HIMS platforms itself. So the patients are benefiting out of it. So as I say, the story, the essence of it is in the results which we have the framework, and these are the results. We have seen more than 3.3 lakh OPD telephonic consultations in our hospital. Obviously, you see the peak green graph over there, which is actually indicating the COVID year where the number of telephonic consultations were more. That indicates that we have more telephonic consultations. But we have sustained it even after COVID was not such a worry. And this is the success mantra of having telephonic consultation as a policy in our hospital. So there is nothing to debate on this, I suppose. Thank you.
Thank you, Dr. Dev Sanjay Nag. Well said. I think telemedicine is a gift to reach the unreached by the services and diagnostic and treatment services. Government of India is using the telemedicine in managing the chronic diseases across the states. So I request Dr. Kaushalya Thakur from Bhilai Steel Plant will be speaking against the topic.
बड़ा कर दो।
पीछे पीछे ले छोड़ दीजिए.
Good afternoon. Can teleconsultation be a part of hospital policy? I am against the motion. Telemedicine is defined under the telemedicine guidelines, the delivery of healthcare services where the distance is a critical factor by the all healthcare professional using information and communication technologies for the exchange of valid information for the diagnosis, treatment, and prevention of the diseases and injuries, research and evaluation, and for the continuing education of healthcare provider. Physical examination is a fundamental component of most face-to-face medical consultation, and they allow doctor an opportunity to see the first hand what physical injuries or symptom a patient may be exhibiting. This provides opportunity to take a patient blood pressure, temperature, respiration, and pulse are integral to a doctor's ability to provide patient with a reasonable standard of care. Telemedicine practice guidelines were issued in MCI on 25th March 2020, published in Gazette of India in 2020, which requires doctors to maintain a same standard of care towards a patient during a teleconsultation as they would during an inpatient consultation. In other words, the fact that the teleconsultation took place over a mobile app or email or telephone cannot be taken as a defense by a doctor against an allegation by the medical negligence. Every doctor is expected to know the limitation of teleconsultation and advise or prescribe accordingly. Everyone should know the advantage of teleconsultation. It divided into three broad groups: for patient, for health professional, and for hospital. First, for the patients. Teleconsultation does not allow the doctor to perform the physical examination, which also include palpation, percussion, and auscultation. To the patient, it might feel like that the doctor is not performing a thorough consultation. It means it decreasing the quality of patient-doctor relationship, which is the most essential part to develop a trust between them. Patients who have some disability, such as decreased hearing or seeing ability, might experience difficulty in using telemedicine. Accuracy of diagnosis and then potential treatment for the patient can also be affected. Difficulty in logic aspect like no internet or sometimes not connected, try again, and try again. Most of the elderly grew up seeing the monitor as TV. So for them, not feeling like the doctor actually saw them. Not all might have access to such advanced technology or might not afford it. हिंदुस्तान की बहुत सारी जनसंख्या सुदूर गांव में रहती है, उनका क्या? Using various SMS or application as a reminder can also cause users fatigue, where the patient may stop responding to the interface or worse, or stop using it at all. There are also privacy issues regarding the accumulated data. Compared to face-to-face consultation, telemedicine has increased risk related to privacy and security. ये हमारा मानना है कि पेशेंट और डॉक्टर आमने सामने हैं, पर ये ऐसा सही नहीं भी हो सकता है. Recent example is what happened in Delhi AIMS. Children's health at risk. This is a particularly concerning when we consider the health of children. If a consultation were to take place over the internet, how could a doctor check the child's ear for sign of infection, listen to their chest for sign of pneumonia? Parents may be learned by the time-saving benefit of such a system. However, it's possible they could be putting their children's health at risk by ignoring the importance of face-to-face consultation. How this possible? Next, disadvantage for health professionals might be interpreted as a threat to their current job or autonomy in the remote place. They will be perceived as a mere technicians. Telehealth work poses numerous concerns about malpractice liabilities, including informed consent, guideline and procedure for the practice that are the appropriate standard of care, supervision criteria for the non-physician care providers, availability of insurance coverage for the professional liabilities, the potential for the doctors to misdiagnose patient when the potentially serious and life-threatening condition is not no doubt increased when a patient is only relaying their version of sign and symptom over the internet. Means emergency condition mein teleconsultation is a very risky. Symptom monitoring by the mobile health or M-health intervention can be burden to the medical team because some of the patient might give out false alarm that require immediate attention to their non-emergency situation. कहीं ऐसा ना हो कि भेड़िया आया वाली कहावत चरितार्थ भी हो जाए. As the use of telehealth grows, it also prone to fraud and abuse, we already pointed out. Prescribing various controlled substance for certain condition also need to be addressed. This is perhaps the most significant limitation imposed by the telemedicine guidelines on the practice of the telemedicine in India. Doctor will not able to prescribe medicine over the teleconsultation freely. मतलब डॉक्टर की दवा लिखने की भी आज़ादी पूरी नहीं है. Prescribing medicine without an appropriate diagnosis, provisional diagnosis will amount to professional misconduct. No doctor is permitted to prescribe habit-forming drugs, narcotic or psychotropic drugs. सबसे ज़्यादा जरूरत malignancy और chronic पेट में इसी की पड़ती है. Now, disadvantage for hospitals. Implementation of telemedicine can bring issue to the hospitals and other healthcare facilities related to infrastructure planning and development, certain telecommunication regulation, reimbursement system with government, licensing and credentiality, medical malpractice liabilities, confidentiality. ये सब कुछ मिलाकर क्लास ए सिटी में तो पॉसिबल है, क्लास बी और सी सिटी में केवल मरीजों पे आर्थिक बोझ पड़ेगा, क्योंकि जितना चीज अरेंज हॉस्पिटल करेंगे वो सारा पैसा किसी न किसी रूट से मरीज से ही जाएगा. Lack of knowledge on telemedicine and its benefit and lack of time to learn how to adopt the technology contribute to more training and workshop to be done for the adopter, resulting in increased cost of the healthcare facilities. Lack of reimbursement has also become a problem in adopting telemedicine, since the reimbursement might cover only some of the aspect of the telemedicine while in practice. Despite of its advantage given by my friend, telemedicine application and approaches still have several flaws which deter their use clinically. It is imperative for all sectors to work together to implement, execute, and develop telemedicine to better serve the patient needs. Government need to tackle the legal aspect of telemedicine. Till the time everyone is well versed with all the aspect of the teleconsultation and the infrastructure is up to the mark, I humbly put that the teleconsultation should not be a regular part of hospital policy. Thank you.
Thank you, Dr. Kaushendra Thakur. So after hearing both for and against, if anybody in the audience or from the delegates wants to give any suggestions or any comments, welcome.
Sir, do we have a rebuttal round? 3 minutes was our rebuttal, I suppose.
Dr. Dev Sanjay.
Thank you for the emotional speech, but we would like, as medical professionals, like to be based upon evidence-based medicine and hardcore data. So first, the discussion was never on the point that whether telecommunication has a flaw or not. The discussion was whether teleconsultation should be a part of the hospital policy or not. We are not requesting our doctors to work from home and all the consultations to be online. What we are requesting is to have a policy. A policy defines what you can do and what you cannot do. So please have a policy. Thanks for my co-speaker from reading out the government guidelines, which actually says that you should have a policy for teleconsultation. Digital health systems were actually discussed in the keynote address, as I said. And basically what happens, my co-speaker also mentioned of BP, temperature, respiratory pulse, who will take. I think we are all aware of, even this watch can actually record your ECGs, your saturation, your respiratory rate, throughout my sleep cycle, throughout the day. Those days are gone, where you actually keep your hand on the pulse to count the pulse till 30 seconds. Technology gives you everything. Now, reading out of the beaming of YouTube, when we are having this conference beaming on YouTube, I think it is double standards to say that you will not have connectivity to be in the remote areas and showing whether teleconsultation works or not. And lastly, coming to the fact that it is the remote areas which are the unserved areas where telecommunication will help. You doctors, me, we don't want to work in remote areas, but how will they benefit out of the healthcare which has grown in the country? Actually, we can provide these services to the rural, the underprivileged, the undersupplied areas through teleconsultation. And it is not only here. We have been doing this job for many years now. Even before COVID, this was there. Dr. Saab talked of the Delhi AIMS data breach. Those were all physical walk-in consultations whose data was breached. AIMS was not having And as he said, type B, type C cities will not benefit. There is data to show that class B, class C cities where super specialties are not willing to go. It is not for the first consultation maybe. The telephonic guidelines have actually stipulated which medicines you can prescribe on the first consultation, which one you can prescribe on a repeat consultation. The government has given you very, very clear guidelines. So that is why all the evidence is there. And OPD consulting, I think I'll give you the TMH experience. There was a huge rush for getting appointments because doctors is a resource which is limited. Starting telephonic consultation, most of our repeat medicines for diabetes, hypertension, the chronic medicines, we have been actually for 1 month medicine, we have been able to give them through telephonic consultation. We have been able to create even in our steel plant hospitals an ecosystem where telephonic consultation benefits the patient and they avail it. There has been a request from the community, sir, COVID khatam hone ke baad isko rokna nahi. That means the community wants it. And the government has already given you the guideline.
Your argument, counter argument?
थैंक यू सर। पर सच बात है सर, आप बोल रहे हैं गवर्नमेंट से, पर गवर्नमेंट के बिना रूल्स के कुछ चल नहीं सकता। एवरीथिंग, क्योंकि जो भी गवर्नमेंट के अगेंस्ट जाएगा वो दूसरे दिन कोर्ट ही जाएगा। और जितनी चीज़ हमें पता है कि आप कहना सही है कि रूल्स है, रेगुलेशन है, पर आप किसी भी नेग्लिजेंस से कभी भी टेली कंसल्टेशन से बच नहीं सकते। जब रूटीन कंसल्टेशन में RTI नहीं छोड़ती है, कंज्यूमर फोरम नहीं छोड़ता है, कोर्ट नहीं छोड़ता, तो ये कहाँ से छूटेंगे? अब मैक्सिमम पॉसिबिलिटी इमरजेंसी केस में जब तक आप ये सारी चीज़ें लोड करेंगे, अनलोड करेंगे, डाउनलोड करके भेजेंगे डॉक्टर के पास तक, ये बहुत प्रेशियस समय, बहुत इंपॉर्टेंट समय लैप्स होता है। आपको उतनी जल्दी अस्पताल तक आना है। जितना भी इंफ्रास्ट्रक्चर आप इसको टेली कंसल्टेशन के लिए लगाएंगे, ये क्लास 1 सिटी पॉसिबल है, वो मरीजों से ले लेगी। बाकी सिटी में ये हर चीज़ की कॉस्ट कोई दानवीर कर्ण नहीं है जो लगा दे। हर चीज़ का पैसा मरीज से ही लिया जाएगा। कोई ऐसी चीज़ नहीं जिसका पैसा मरीज से न ले, हर चीज़ उन्हीं के से लेनी है। तीसरी चीज, ये सब ठीक है, पॉसिबल है, पल्स, रेस्पिरेशन, हर चीज घड़ी पे आ गया, फिर भी मैनुअल और विजुअल का कोई अल्टरनेटिव नहीं है, कहीं कोई अल्टरनेटिव नहीं है। आज भी अब किसी पुराने फिजिशियन या किससे पूछे, आज भी वो मरकरी वाले से बीपी नापते हैं, क्योंकि उनको भरोसा है कि वही सही देगा रीडिंग। जितनी भी आपके चीजें हैं, एडिशनल चीजें, वो उसमें फॉल्स पॉजिटिव, फॉल्स नेगेटिव इतना इसका कोई अल्टरनेटिव नहीं है और इसके कोई फ्लॉज नहीं है। जितने रिटर्न कंसेंट लेते हैं कोर्ट, सर्जरी वालों से पूछिए, सारे कंसेंट लेने के बावजूद भी कोर्ट खड़ा कर देता है, आपने ये चीज छोड़ दी, वो चीज छोड़ दी, वहां दस्तखत सही नहीं है, यहां दस्तखत सही नहीं है। और जिन लोग कंज्यूमर फोरम में जाते हैं या आरटीआई का जवाब देते हैं या कोर्ट जाते हैं, वो अच्छी तरह से वाकिफ हैं कि कोर्ट का वकील आपका कोई सगा नहीं होता। ये सारी चीजें देखते हुए मैं अभी भी ये कहता हूं कि जब तक कि सारी चीजें डेवलप नहीं हो जाएं, अच्छे से इंफ्रास्ट्रक्चर अच्छा हो जाए, अच्छे से लोग एजुकेट हो जाएं उस बारे में सब कुछ, तब करिए। परमानेंट या रेगुलर हॉस्पिटल पॉलिसी इसे बनाना अभी ठीक नहीं है। थैंक यू।
Thank you, doctors, Dr. Dev Sanjay Nag and Dr. Kaushalendra Thakur. Very interesting argument and counter argument. Yes, teleconsultation is an opportunity.
एक छोटा सा प्रश्न है हमारे दोनों पैनलिस्ट्स के लिए. What we are discussing here is a consultation between a doctor and a patient. I don't think in our country yet, our patients, especially the patients we are talking about, जो दूर दराज की जगह में रहते हैं, वो इतने अच्छी तरीके से अपनी चीज़ों के बारे में बता पाएंगे या उनके पास टेक्नोलॉजी है. दैट इज़ वन. इफ रादर अगर एक टेलीकंसल्टेशन होता है एक डॉक्टर का विद आशा वर्कर और आंगनवाड़ी वर्कर, दैट मे बी मोर इफेक्टिव. सो एज ऑफ नाउ आई फील डायरेक्टली इंटरेक्टिंग विद द पेशेंट इट मे नॉट बी वेरी यूजफुल थिंग. रादर इसमें काफ़ी चांस है कि चीज़ें गड़बड़ हो जाएँ. Discussing among colleagues, teleconsultation, that is obviously we do. Then बहुत सारी limitations हैं और आगे भी रहेंगी, और हम लोग एडवाइस दे सकते हैं, ट्रीटमेंट शायद इस वक्त नहीं दे सकते. जैसे मान लीजिए किसी के पैर में मोच आ गया, एक एंकल स्प्रेन हुआ, तो फ़ोन आया तो मैक्सिमम हम लोग क्या बोल सकते हैं, भाई आप क्रेप बैंडेज लगा लो, आइस लगा लो, पैर को ऊंचा कर लो और एक्सरे करवा लो और कुछ पैरासीटामोल या बुनियादी चीज़ें ले लो. But we have to advise them that you have to go to a hospital to get an X-ray done. We have to rule out fractures and so many things. So teleconsultation as of now, and I do not see in the foreseeable future that it can replace. Only in certain like you're saying those chronic diseases, patient को reminder भेजना, आप दवा खाते रहिए, checkup के लिए आते रहिए. So I think as of now it is not possible. And the big that is my as a perspective as a doctor, as a surgeon. और एक मरीज के तौर पे I would always like to be seen personally by a physician. He may not be very trained, but still, एक बहुत बड़ा expert अमेरिका में बैठा हो और पास में हो, थोड़ा कम भी जानता हो, I would rather prefer to go to him physically and get myself treated. That's all. Thank you.
Yeah. Again, thank you for the feedback. But I'll tell you, हमारे जैसे देश में जहाँ पे healthcare की availability one of the lowest है worldwide, वहीं पे इस टेक्नोलॉजी की सबसे ज़्यादा ज़रूरत है. हमारे ही देश से लोग विदेश में जाके टेक्नोलॉजी पे काम कर रहे हैं. हम लोग जो डिजिटल टूल्स बनाए, सबसे पहले तो मैंने जैसे अपने स्पीच में बताया कि आप टेली कंसल्टेशन वर्ड की संधि विच्छेद करके मत देखिए. इट इज़ नॉट टेली एंड कंसल्टेशन. रिमोट मॉनिटरिंग, आर्टिफिशियल इंटेलिजेंस, एवरीथिंग इज पार्ट ऑफ टेली कंसल्टेशन. आज आपके पास अगर एक ICU सेटअप करते विथ ऑल द इक्विपमेंट्स, you can have one doctor there and you have the senior most critical care consultants available through a tele-suite, monitoring all those patients and suggesting what to do. It cannot replace a physical consultation, and that is very clear in the government policy कि किसमें हम teleconsultation कर सकते हैं, किसमें नहीं कर सकते. And the policy is because of that. Your resources are limited. How do you best utilize the resources? Rather than that doctor repeating an antihypertensive medicine, let him palpate your feet and see where you have the sprain and which ligament is injured. So use your resources judiciously like you do your OD. No technology is perfect. Even if my car is not a BMW, I do drive it. So it is not anywhere close to perfection. But the point is we have to take best recourse to the resources available to us. And in a developing country like us, I think technology, आपको शायद पता होगा, Government of India, Tata Group की तरफ से, large number of corporate social responsibilities. We are going out into the rural villages through teleconsultation, setting up booths there, consulting the doctors. Even much before COVID, we were doing it. Patients were benefiting. And we have permanent results to show improvement in infant mortality rates, maternal mortality rates. Let us discuss on figures which are debatable and can be argued for and showed as results. Let us not discuss on emotions because which cannot be quantified.
सर मैं आपसे पूरी तरह से एग्री हूँ. आपने सर्जन होके सारी बात कही. ये फिजिशियन से ठीक है, थोड़ा बहुत बता सकते हैं, रिमाइंडर दे सकते हैं, बुला सकते हैं, पर फिजिकल प्रेजेंस का, फिजिकल देखने का कोई अल्टरनेटिव नहीं है. अभी तक तो नहीं है, आगे क्या होगा दैट इज सब वक्त बताएगा. हो सकता है बहुत एडवांसमेंट आए, सब कुछ आए, बट सामने खड़े होके उस कंसल्टेशन का, पहले कंसल्टेशन का कोई अल्टरनेटिव नहीं.
Good evening, sir. I would like
Sorry,
to...
I'll
Yeah,
just
please.
continue with this. What makes you presume that the first consultation is your last consultation?
No,
I
nothing
want
lost.
my patients to come back to me.
Let us,
Okay,
time, let us have a
Good evening,
last
everybody.
question here.
I would, there are few things which is associated with human nature. Being fearful is human nature. Accepting challenge and accepting change is another challenge to all of us. So I would like to say that 20 years back, robotic surgery was not accepted. A lot of papers goes against it, but now we are doing it. There are many things, new technologies coming, we are not ready to accept that. But 10 years down the lane, we will accept it. So I think that you will also be first one to accept those after 10 years. But today, you are fearful, we all are fearful. But we should take up the challenge. Thank you.
सर मैं हम तो पहले ही बोल रहे हैं कि आज की स्थिति में, मैं तो पहले बोल रहा हूँ इंफ्रास्ट्रक्चर डेवलप होना चाहिए.
What I'm saying is we cannot
Okay,
stop.
let us...
हाँ नहीं स्टॉप नहीं.
We cannot stop.
Yes.
We have to go through it. If you are, what comes out of you that we should not do anything at this time, then we will not be going. We have to take a leap to accept this technology.
Okay.
और आज अगर वो गांव पे आधार पे सब्सिडी रिसीव कर सकता है तो टेली कंसल्टेशन भी रिसीव कर सकता है. वो है टेक्नोलॉजी वहाँ पे अवेलेबल. थैंक यू सो मच.
Thank you both the doctors. I just want to close this debate by telling that at the two extreme ends, one at the primary care, other at the super specialty ICU care, both ends nowadays we are using the teleconsultation. For example, many programs, national programs like RNT-CP, TB, where the chest X-ray has been done at a taluka level hospital, but there is no radiologist available in taluka, sub-taluka hospitals. They have been transmitted electronically and they've been read and interpreted from the radiologists from the towns and district hospital and sent back. Similarly, we have a cloud physician called, they're managing almost 30 to 40, 50 ICUs across the country, ICUs, through teleconsultation and artificial intelligence. Last month, I just visited the command and control office in Bangalore. They're managing an ICU in a small hospital in Jharkhand also, where they have a trained nurse and a doctor, duty doctor available there. 24/7 monitoring is happening. And they showed the last 1 year data, the deaths in the ICU has come down by 40% with this cloud physician virtual ICU running. And the cost has come down by more than 50%. There's no need to have each small ICU cannot have the intensivist or emergency physician available there, where a person sitting remotely can manage and help the hospital run. But we have to take care that we have to take the our own safety from the legal issues. I think recently even Supreme Court has come after the COVID. I think there was an indication the Supreme Court said teleconsultations can be allowed.
I congratulate Dr. Nag उन्होंने अपने पॉइंट्स बहुत अच्छे से रखे और इन सब चीज़ों को हमने अपने कोविड के दिनों में महसूस किया है। हमारी हेल्थ फैसिलिटी और हेल्थ सर्विसेज कोविड के होने के बावजूद भी कोलैप्स नहीं हुई और इसका सारा श्रेय जाता है टेलीमेडिसिन। टेलीमेडिसिन के बहाने ही, टेलीमेडिसिन के थ्रू ही जो कुछ भी सर्विसेज हम दे सकते थे वो हमने दिया। डॉक्टर कौशल ठाकुर ने जो टेलीमेडिसिन पे होने वाली जो प्रॉब्लम्स हैं उनको बताया और उनका ये कहना भी वाजिब है कि हम इसके लिए तैयार हैं लेकिन अभी तैयार नहीं हैं, अभी इसके लिए हमें और समय की ज़रूरत है। टेक्नोलॉजी बहुत इम्प्रूव हो रही है, बहुत आगे बढ़ते जा रही है और कोविड ने हमें ये सिखाया इस बीच में कि ये टेलीमेडिसिन को हम सब्स्टिट्यूट करके नहीं, सप्लीमेंट करके यूज़ कर रहे हैं। और इसके लिए आप सब लोगों ने महसूस किया होगा, पूरे महीने 2 महीने टेली ट्रेनिंग चली, टेली टीचिंग चली, टेली स्कूलों में टेली टीचिंग स्टडी चले, ऑनलाइन क्लासेस चले, ऑनलाइन वर्किंग चला, ये सब टेलीमेडिसिन से वो चीज़ें स्टैंड स्टिल नहीं रही है, काम आगे चलता रहा। तो मैसेज इज़ क्लियर, हर इशू के कॉइन के 2 साइड होते हैं, तो दोनों साइड हैं और दोनों साइड की ज़रूरत है अभी, और आगे आने वाले समय में इसको डेवलप किया जा रहा है और गवर्नमेंट ऑफ इंडिया और दूसरे गवर्नमेंट भी में भी इस पे आगे काम चल रहा है। अभी जो टीचिंग है, अंडर ग्रेजुएट की टीचिंग, वो इस तरीके से डिज़ाइन की जा रही है कि उसमें टेलीमेडिसिन का काम आए, उसमें परकशन पलकर्सन ये सब ना रहे और मॉडर्न गैजेट्स के थ्रू उन सब चीज़ों को इनकॉर्पोरेट किया जा रहा है ताकि इस टेलीमेडिसिन को आगे बढ़ाया जाए। जैसे हमारे के इम्पोर्टेंट ऑडियंस से बताया कि रोबोटिक सर्जरी आज दूर से बैठ के कर रहे हैं। तो इस प्रकार इन दोनों में के फ़ायदे भी हैं, लिमिटेशन है, पर दोनों सप्लीमेंट करके हमारी हेल्थ केयर फैसिलिटीज़ को हम काफ़ी आगे बढ़ा सकते हैं और हम सब उस दिशा में काम कर रहे हैं। थैंक यू सो मच।
Now, such a vast topic put in a nutshell, this debate is definitely a brainstorming session with different perspectives, and we still need to think through it. Now, I request Dr. Vinita Dwivedi, CMO of Bhilai Steel Plant, to felicitate our chairpersons, Dr. Prakash Kudur sir and Dr. S.K. Tamar sir, please. Token of appreciation. Debate. Next. Now I humbly request Dr. Prakash Kudur sir and Tamar sir to give a token of appreciation to our speakers, Dr. Kaushalendra Thakur sir and Dr. Sanjay Nag sir. As the saying goes, the more you learn, the more you earn, and more self-confidence you will have. This is the main theme for doctors being lifelong students. Recalling the golden moments of our lives from practical labs and medical rounds behind our professors in early years to prescription and treatment in our final years of medical school, we sure enjoyed a lot. However, due to ever-changing medical sciences, we need to update and upgrade ourselves with recent advances in our fields. Knowledge has to be improved, challenged, and increased constantly, or else it vanishes. Here, the knowledge has to be improved from within, challenged with others, and to increase it exponentially, it has to be delivered. Now, we have the privilege to update ourselves with such delivered knowledge by doctors of SAIL on the symposium, Recent Advances in Medical Sciences. Each participant has 8 minutes for the presentation and 2 minutes for discussion. Now we request our distinguished chairpersons, Dr. M.Y. Suresh sir, CMO from Bhadravati Steel Plant, and Dr. Vinita Dwivedi ma'am, CMO from Bhilai Steel Plant, to chair our sessions.
A very good afternoon to all of you. I take this opportunity to thank all the organizers for giving me an opportunity to chair this session. Since the time is running short, let us straight away go for the symposium. First speaker is Dr. Anirudh Meene from Bhilai Steel Plant, and he will be speaking on skin banking.
Thank you. A very cordial welcome and good evening to eminent chairpersons, honorable faculties, and august delegates. Myself, Dr. Anirudh Meene, will be speaking on skin banking, its need, and our chronicle in establishing one at our institute. Major burns involving near total body surface area are always challenging to salvage because of scarcity of availability of autografts. Skin banking is a facility wherein skin is collected from eligible donor, processed and stored at 4 degrees for 5 years and can be used in such patients. Annual burn incidence outnumbers the burn care facilities available across the nation. According to National Burn Registry, it has profound socio-economic impact because of predominant involvement of productive age group of patients. So coverage of wounds by autografts after early excision is the best treatment option if autografts are available. However, in extensive burns, some form of temporary cover is always life-saving, but unavailability of xenografts in India and limitations in the use of homografts makes allografts as a temporary coverage of choice. So the general indications is therefore to mainly coverage of major wounds apart from the other indications as listed in this slide. Allograft skin reduces the evaporative water loss and exudation of protein-rich fluids. It allays pain, suppresses microbial proliferation, and by restoring the physiological barrier at wound surface, allografts reduce the heat loss and mitigate the hypermetabolic response to burn injury. However, infection followed by rejection is never-ending threat, defeating purpose of allografts use in some cases. The increasing use of allograft skin in specialized burn care center has been major driving forces behind growth and development of skin bank across the nation. Setting up of a skin bank starts with planning, selection of a preservative method, training of designated staff, procurement of instrument, and registration within statutory guidelines laid by National Organ and Tissue Transplant Organization. Being an already functioning burn unit setup, our requirement was reduced to 50%, and we started moving forward with procurement of instrument and training of staffs. And because skin preserved in liquid glycerol was easy to procure, process, and distribute at a lower cost with comparable results, glycerol preservation method proved to be more suitable. we require a fixed personnel who will be assigned for processing, documentation, and overall quality management of skin banking, and a floating personnel for retrieving skin. 6 of our staff were trained at National Burn Center, Mumbai, after acquiring sponsorship from management through training department. Training at National Burn Center bolstered us and gave us a stimulus. Our all staff worked enthusiastically and received Certificate of Excellence for their dexterity from pioneer of skin banking, Director NBC, Dr. Keswani. With the help of management and purchase department, we were able to procure all instruments well ahead of time. After procurement of instruments, we applied for registration to State Organ and Tissue Transplant Organization, that is SOTO, in a prescribed form. The required fees was paid, and following which 3 members of SOTO came to evaluate the facilities of skin banking at JLNHRC. And they issued registration certificate after detailed inspection and scrutinization. The winning moment came on Azadi Ka Amrit Mahotsav, when our director in charge, Sri Anirban Das Gupta, raised the curtain with his shubh hands and wished our team good luck by redemption of manual and catalogs for Skin Bank. This was first officially registered skin bank in entire state of Chhattisgarh, first of its kind in wholesale unit, and 18th registered skin bank in India. Now we all had a daunting task of creating awareness amongst common public for skin donation. We utilized Ganeshotsav and Durgotsav as there was huge gatherings this year post-pandemic. And yes, it started working. We started receiving voluntary donor registration as well as cadaveric donation calls. On receiving a cadaveric donation call, the floating team reaches the place within 6 hours to harvest the skin. And before retrieval, the team leader should doubly check the consent form, get samples for viral markers, re-explain to akin regarding the procedure. The process of retrieving is simple. After proper cleaning and draping, split thickness skin grafts are harvested from bilateral lower limb, bilateral upper limb, back and abdomen. And it is collected in containers with 50% glycerol. It is our humble duty to pay due respect to body. Thence, before handing over to relatives, dressing is done neatly, and we must acknowledge the deed of deceased. The best way is to give written certificate of appreciation. At Skin Bank, skin is rechecked, and now it is lubricated well with 85% glycerol and allowed to mix with liquid glycerol in a shaking incubator at 33 degrees for 3 hours. Following which skin is stored till serological report arrives. Once the reports are negative, phase 3 processing is started, in which graft is meshed in different ratios and some strips are left unmeshed. Labeling and storage is done, and now specimen is ready for use. Data is entered and microbial testing is repeated every 3 months. Once we receive requisition in a prescribed form for distribution, refrigerated skin should be transported in liquid glycerol at wet ice temperature 1 to 10 degrees in an insulated container, thoroughly sealed. The transport time should be minimized to 6 to 12 hours. Skin Bank is a service. It is not a product. It can only work with the cooperation and coordination of the people for the people. And yes, it is only the beginning. The woods are lovely, dark, and deep. But I have promises to keep and miles to go before I sleep. Thank you, one and all.
Thank you, Dr. Anirudh, for giving an excellent talk. Now, house is open for discussion. Any questions, please?
Pardon, sir? Artificial skin substitutes are available. There are plethora of artificial skin substitutes available, sir, but not at the such a lower cost where allografts are available.
Earlier they used to use a potato peel. Is it right?
Sir, it was used, but in my experience, it is not a good. I haven't got a good result using potato peel, or for that matter, fish skin. We have no data recommending that fish skin should be used.
Aniruddin, how much time period an issued specimen should be used? Once issued from blood bank, in how much time duration it should be utilized?
So the transport time is 6 to 12 hours, and within further 12 hours, it must be used. It must be used.
24
The
hours.
out of refrigerator time must not be more than 24 hours.
Okay, thank you.
Thank you.
Thank you, ma'am.
We are indeed proud of our skin bank.
Thank you,
Thanks
ma'am.
to the management. And now I call upon the next speaker for neuromanagement of retinopathy, Dr. Pranay Behra from Burnpur Steel Plant.
Respected chairpersons and delegates, a very good evening to one and all. At the outset, I would like to thank AISMOC for giving me this opportunity. My topic for today, recent advances in retinopathy. This is the brief overview of my topic. I would like to cover my topic under the following headings. Global estimates of diabetes. By the year 2045, 629 million of the world's population are expected to be diabetic, and India contributing the majority of it, and thus emerging as the world's diabetic capital. So what are the challenges that we encountered? The increased prevalence of retinopathy, inadequate screening, treatment burden both in terms of time and cost, durability and the efficacy of the current medication, loss to follow-up, and lack of holistic approach. So moving on to the recent advances, first I would like to talk about artificial intelligence. We had a very nice debate on telecommunication. Now this is a step forward to it. What is artificial intelligence? It refers to a specific field of computer engineering that focuses on creating systems which is capable of gathering data and making decisions or solving problems. Now how does it work? Multiple of retinal images worldwide are analyzed by algorithms and thus identify patterns and diagnose and predicts prognosis. So it gives early warnings to the patient, and we can reach those areas where specialists are sparse. So the artificial intelligence comprises of machine learning, deep learning, and neural networking. What is the scope of AI? AI helps in screening, diagnostic grading, guiding for therapy, automatic identification of the recurrences. We can quantify the therapeutic response, and it can predict and also give prognosis. Now, IDX-DR is one of the first FDA-approved AI diagnostic. How does it work? A trained operator first takes some fundus images, and then it gives it to the IDX-DR client, which analyzes for the signs of DR, and it gives results within few minutes. If the result is positive, that is, if it is more than mild DR, then the patient is referred to an eye care professional. And if negative, patient is asked to get screened after 1 year. Sometimes the images is of poor quality, and that time immediate re-imaging is done. Moving on to the recent advances in imaging, we have OCTA, that is OCT angiography. It is a dye-less angiography which can study retinal, choroidal, and optic disc vasculature. It segments and analyzes at various levels. The principle that it uses is the movement of the RBCs are taken as contrast. It enables en-face imaging and detects decorrelation of the OCT signals. What is the utility of OCTA in DR? It helps in imaging of the microaneurysms, the IRMAs, the capillary non-perfusion areas, the foveal avascular zone, the NVDs, and the NVEs. So what are the advantages? It is dye-less and non-invasive, unlikely that of the FFA. It can be done in patients where FFA is contraindicated, helps in follow-up monitoring, and separate assessment of the retina and the choroid is possible. So what are the limitations? It has got limited field of view, a maximum of 12 cross 12 mm. It does give no information about leakage, unlike that of the FFA. Slow flow abnormalities can be missed out, and it is associated with motion and projection artifacts. So next interesting topic we have is the OCT biomarkers. Now these biomarkers can give prognosis about the visual acuity. If we see drill, that is disorganization of the retinal inner layers, this signifies worse visual acuity. Anything like that of the hyperreflective foci or the outer retinal tubulations, these are signs of neurodegeneration and photoreceptor damage. Grade 1 ELM disruption and the EZ disruption or the ISOS junction, it signifies progression of the disease. Correlation between the macular thickness and the VEGF levels are surrogate markers for severity of DR. RNFL thinning gives severity of DR, poor glycemic control, and it may precede signs of diabetic retinopathy. Next, moving on to the imaging system, we have got ultra-wide field imaging. The Heidelberg Spectralis and the Optus imaging system are the ones which give field of view of around 150 degree and 200 degree respectively. The traditional imaging system has got very limited field of view of around 30 to 50 degree, and most of the peripheral lesions are missed out. So by using the ultra-wide field technology, we can localize and quantify the non-perfusion areas. It guides to targeted retinal photocoagulation, and early detection of the peripheral NVE is possible. Next, moving on to the treatment aspect, we have got Navilas, the navigated laser system, a new treatment paradigm in retinal lasers. Now, it integrates diagnostics with laser therapy. It can be pre-planned and digitally documented, and it is computer guided. Now, how does it work? The image of the retina is first taken, and then the ophthalmologist digitally encircles those areas which are to be lasered. Then the device automatically delivers the laser spots to the specified areas. So the advantages, it helps in targeted laser treatment. It comes with utmost speed and comfort, and it is much more safer to the patients, unlike that of the conventional ones. Coming to the future possible treatments, first candidate, brolucizumab, already been FDA approved for diabetic macular edema in June 2022. It is the smallest of the anti-VEGF, a 26 kilodalton humanized single-chain protein inhibiting all the isoforms of vascular endothelial growth factor A, and thus decreases the growth of the neovascular lesions and resolves the retinal edema. Certain specific properties of it: more drug in a single injection, effective penetration of the retina and the choroid, and rapid systemic clearance. The phase 3 clinical trials for diabetic macular edema, KITE and KESTREL, and early results shows non-inferiority to that of aflibercept. It can be possibly more efficacious, but the early concerns, retinal vasculitis and occlusive events, are to be kept in note. Faricimab, the first bispecific antibody designed for intraocular use. It targets a novel pathway, the angiopoietin Tie2 pathway, and also the anti-VEGF pathway. Yosmite and Rhine are the phase 3 clinical trials which are going on for diabetic macular edema. Result shows non-inferiority to that of aflibercept, already been FDA approved and can be given 1 to 4 months apart. Next, interesting delivery system. The port delivery system enables continuous flow of anti-VEGF system via passive diffusion up to 6 months period. It is a refillable implant that has to be surgically implanted transclerally in an operating room, but the refilling can be done in the OPD itself. Pagoda and the Pavilion are the phase 3 clinical trials, but concerns for endophthalmitis is always there. Next upcoming topic, genetic therapy, one-time delivery with long-term effects. The presence of blood retinal barrier gives the immunological advantage. Terminally differentiated cells ensures long-term expression of the transgenes and less genetic aberrations. Eye being very small in size, small quantity of vectors ensures optimal concentration. It is easily approachable through intravitreal, suprachoroidal, and subretinal route. Non-invasive techniques to monitor treatment response. The candidates RGX-314 ensures continuous delivery of anti-VEGF protein, similar to that of ranibizumab, can be given subretinally and suprachoroidally. And the next candidate, ADVM022 by the Adverum group, ensures continuous delivery of aflibercept protein. So to conclude, retinopathy is the leading cause of blindness in working adults. Real-world evidence shows that we undertreat, unlike that of the clinical trials. Current therapies, while highly effective, have a high treatment burden and have room for improvement. The future is very promising with many new potential therapies and delivery system on horizon. So my final take-home message, the key is early diagnosis and treatment because retinopathy, once diagnosed and treated early, is a reversible one. And the last thing I would like to emphasize is holistic approach that the ophthalmologists, physicians, endocrinologists should all work hand in hand because there is no point in pumping repeated anti-VEGF injections, giving laser to the patients unless and until his blood parameters, blood sugars, BP, and lipid profile are under control. Thank you.
Now the topic is open for discussion. Any questions? I think you completed the full topic and nobody has any questions to ask to you.
So I can, do you know anything in the featureless diabetic retinopathy?
Ma'am?
So featureless retina.
Yes, ma'am. Featureless retina, that is what I was mentioning about DRIL, that is the disorganization of the inner retinal layer subfoveally.
It is on fundus finding. You will see retina, there is no hemorrhage, no exudate, nothing.
Yes,
so
ma'am.
in case of anemic patient, we will find no sign. But it is a severe form of retinopathy. Suppose patient is severely anemic or severely anoxic retina, you will not get anything.
Yes, ma'am. And
we
even in
think
myopic.
that it is a normal retina.
Yes.
So for that case, we have to go for angiography.
Angiography, yes.
Not OCT, nothing.
Yes.
So featureless retina, you must remember.
Yes.
That is my key point.
Thank you. Good evening, sir. Yes, sir, there is role of intraocular steroid in retinopathy, but we are worried about cataract and glaucoma, which plays a major role, the major disadvantage factor. So if the patient is pseudophakic, then we can go for intravitreal steroids. But in a phakic patients, it's better to go for an anti-VEGF treatment than that. But sometimes if the anti-VEGF fails, then we can go for secondary intravitreal steroids, sir. We even have DEXA implants which can be given intravitreally, which stays for around 3 to 6 months period.
How far these technologies are in future? And what are the costs?
Sir, brolucizumab has already been approved and we are using it. So like anti-VEGF injection, which is usually given 1 monthly apart, with the use of brolucizumab, that has come to 3 months. And faricimab is already been approved, but it is not yet in the Indian market. For gene therapy, like after the success of the Luxturna gene, which is used for retinitis pigmentosa, it is under phase 2 clinical trial and not yet approved till now. Like it is still in research because once we introduce those anti-VEGF protein, like we are worried about the concentration, whether the concentration is decreasing over the period of time, and if like we are giving it, like we are introducing this gene into the vitreous cavity, and this vascular endothelial growth factor is also useful. So we are worried about the late complications. Like once it comes to the human trial, then we'll be possibly knowing like how it is going to work in future. Yes, sir. So PDS, it's already FDA approved for age-related, yes sir, it is already approved for age-related macular ARMD and it is under study for diabetic macular edema, but there were more incidents of endophthalmitis and the rate is much more than that of the anti-VEGF injection. So probably it is coming down for retinopathy and it is much more on the side of AMD treatment.
As a pediatrician, we come across this sickle cell retinopathy.
Yes, sir.
So what is your view regarding this anti-VEGF in sickle cell retinopathy?
So for sickle cell retinopathy, there is, I guess there is no role of anti-VEGF. It's the main thing is that we have to treat the disease per se rather than going for anti-VEGF. Anti-VEGF probably has no role in case of sickle cell retinopathy.
Okay.
your topic is perfect for artificial intelligence and whether digitalization of medical field should be done or not. Thank you so much, Dr. Behra.
Thank you, ma'am. Thank you.
Now we'll give a pause for recent advances, and we have a felicitation of judges.
Now I request Dr. Rajiv Lochan Kare, Dr. Yogendra Malhotra sir and Dr. Chetan Anand sir. Sir, please on the dais. Sir, I request Dr. Dave sir to felicitate our MBBS poster judges for today's session. Sorry for the interruption. Now you can continue, ma'am, with your next sessions, please.
Now the next speaker is Dr. Jayant Acharya from Rourkela Steel Plant. He will be speaking on juvenile diabetes recent advances.
Good afternoon all. I will be speaking on the current and the future therapies for type 1 diabetes mellitus. The issue is, can we prevent? So as you all know, type 1 diabetes is an autoimmune disease characterized by insulin deficiency and hyperglycemia in children who are genetically susceptible. Globally, 1.1 million children are affected every year. However, recent studies have shown that type 1 diabetes, the incidence of type 1 diabetes in our country is relatively less than reported in the Western literature. So as I said, coming to the immunopathogenesis of this disease, so two things are there. It is an autoimmune disease and occurs in those children who are genetically susceptible. So these children, group of children, when they are exposed to precipitative environments like exposure to EB virus or CMV virus, or even early exposure to bovine milk, they cause the beta cell apoptosis, leading to the release of the beta cell antigens, which attract the antigen presenting cells, and these antigen presenting cells, they attack the naive T cells in the regional pancreatic lymph nodes, leading to the release of the autoreactive T cells. So these are the main culprits for the progression of the disease, because these autoreactive T cells, they further attack the beta cells and damage them through inflammatory cytokines. So out of all the antibodies, beta cell specific antibodies, ICA and GADA are the most specific ones which are detected. So this disease progresses in 3 stages. In the stage 1, it is only the presence of autoantibodies. Then in the stage 2, there is hyperglycemia but no symptoms. And in the stage 3, there is overt features of type 1 diabetes mellitus. So what is the present scenario? Once the disease is diagnosed, we stabilize the blood sugar by educating the parents and the children and the importance of self-monitoring of glucose. We teach them various techniques of insulin injections, how to calculate the dose, principles of nutrition and exercise, and the management of hypoglycemia. However, apart from this, in spite of all these things, the incidence of long-term complications of like diabetic retinopathy, nephropathy, neuropathy, and coronary artery diseases, as described in various literatures across various countries, the incidence remains very high. So what is the future? Future is immunomodulation therapy, anti-inflammatory drugs, vaccination, and stem cell therapy. So evidence now warrants a focus on the prevention of the beta cell inflammatory damage by various immunomodulatory therapies. So I will be discussing on some of the drugs which have undergone various trials in last 10 to 15 years, and they have given some hope how to regress or stop the progression or cause the reversal of the disease in type 1 diabetes. So there are mainly 4 or 5 drugs like teplizumab, which is an anti-CD3 antibody, oteleximab, ATG, elifasept, which is a CD2, acts against CD2 cells, and rituximab. Coming to teplizumab, it is an anti-CD3 antibody. It blocks the activated T cells by blocking the CD3 receptors. The beneficial effect, this drug has gone a phase 2 trial, and in high-risk children who can develop diabetes, that is the relatives of the children who are having diabetes, and they have shown that a 14-day course can increase, they have documented a benefit of more than 50% reduction of risk of type 1 diabetes mellitus in children. And the results were published in NEGM 2019. Similar advantage was also shown in oteleximab trial. In the results was published in 2014, which completed a randomized phase 3 study, and they have shown that there was a definite decrease in the HbA1c level and the insulin requirement. These studies were done in US and Europe. ATG is a drug which selectively causes the apoptosis of the activated T cells. This also has undergone a 2-year trial, and what the studies concluded that they preserve the C-peptide secretion in older children. Elifasept, again, the mode of action is same. It blocks the activated memory T cells, and in type 1 diabetes, they have concluded in the study that they preserve the C-peptide secretion, reduced insulin use and hypoglycemic events, and induced favorable immunological profile. Similar result was also seen with rituximab. The result was, the beneficial results have been published as early as 2009, and it showed similar preservation of beta cell function over a period of 1 year in patients with type 1 diabetes. Apart from this, there are many anti-inflammatory drugs which have undergone trial in type 1 diabetes, like infliximab, adalimumab, golimumab, and tocilizumab, out of which golimumab is a drug which has shown definite beneficial effect in type 1 diabetes. It has gone a randomized phase 2 multi-center trial, and the result has been published in NEGM 2020. And they have shown that after its use, it resulted in better production of endogenous insulin and less use of exogenous insulin because there was mean decrease in the HbA1c levels. There are other non-immunomodulative drugs like sodium glucose co-transport inhibitors, which have been tried in type 1 diabetes, and GLP-1 receptor agonists like liraglutide. So sodium glucose transport inhibitors in type 1 diabetes, they have shown in the studies that it lowers the HbA1c level, decreases total daily insulin dose, and it has been already approved as an adjunct therapy, add-on therapy with insulin in adults with type 1 diabetes in Europe and Japan. Another interesting drug, liraglutide, which is a GLP-1 receptor agonist, which helps to decrease the postprandial blood sugar in type 1 diabetes by decreasing the hepatic glucose production. When used with addition with insulin, it has definitely shown a beneficial effect. Coming in short about the vaccination to prevent type 1 diabetes, the main aim is to induce immune tolerance. So out of various vaccines, DIPEP 277 and GUARD 65, DIPEP 277 has gone currently in phase 3 trial, which has shown complete suppression of diabetic onset and stop or reverse the progression of the disease. Stem cell replacement therapy is on horizon and it can promise cure. However, immunomodulation will still be required. Although research in type 1 diabetes prevention and disease modification produce encouraging data, none appears sufficiently effective alone. So stem cell replacement therapy combined with immunomodulating drugs are the most promising preventive or therapeutic modules. However, diagnosis of type 1 diabetes as early as possible is equally important to effectively preserve or rescue the beta cells. So take-home message is preservation of insulin secretion is of great importance in type 1 diabetes. Immune interventions can prevent type 1 diabetes in high-risk individuals. Thank you.
Now the house is open for discussion. Any questions, please?
That was really informative. I just wanted to know at what stage do these children need to be intervened?
Yes, sir, that is the most interesting because this disease progresses in 3 stages. The first 2 stages are silent, only the antibodies and the hyperglycemia. There are no overt symptoms. So these drugs can be effective where there is a very effective screening program. Once you screen the population, definitely in last, I don't know, but our personal experience, post-COVID, in last 1 year, the incidence of diabetic ketoacidosis has increased. Admissions of diabetic ketoacidosis in our hospital has dramatically it has increased.
Same all the way.
Yes, and second is low socioeconomic status. Low socioeconomic status children are coming, and very sick children are coming. So definitely, if you have a very effective screening program, definitely these drugs will help.
So I mean to say, if people
So
can
in stage
afford
one,
it, stage one.
Stage one.
So apart from the islet cell antibody, the GAD and all,
Yes.
do you have any other markers which can new markers are coming up to say that these children are going to become diabetic?
So you can only target the high risk populations. If there is a family history and if there is a history of type 1 diabetes also in the other sibling, they are the most important children whom to start.
And this drug, the SGL2 inhibitor is coming up in a very big way, as you rightly said.
Yes.
In Japan, what was the age beyond which it's been approved?
So they have seen it in adolescent children.
So that is
Adolescent.
because I think
Maturity onset, yes.
Yeah, that will be the drug of tomorrow. The
Yes, sir.
GLP-1
Yes, sir.
analog
GLP-1
and
with insulin.
Thank you.
If there are no questions, let us move on to the
Sir,
next
there is a
topic.
small announcement, please. Sir, I request all our HIMs of steel plants to convene in the boardroom in Bhilai Niwas, that is opposite to reception, with our director in charge is about to come in 10 minutes for CPC meeting, which is continued from 6 p.m. onwards. Please, sir. Sir, you may continue with the session, please.
All the HMs have to move to the conference room, please. Now the next speaker and the last speaker for recent advances in medical sciences is Dr. Abhik Chatterjee from Tata Steel Plant, who is going to speak on newer treatment modalities in management of ventral hernia.
स्लाइड चेंजर मत लगाइए, मार्कर दे दीजिए बस। उसमें आ रहा है ना, उसमें आ रहा है, मैनेज कर रहा हूँ, उसमें ठीक आ रहा है। Good evening, everybody. Greetings from Tata Main Hospital and Tata Steel. Today I will be discussing the newer treatment modalities in the management of ventral hernia. Hernia by definition is abnormal protrusion of viscera through its wall by a defect or weakness, and I have enumerated the various types of hernias in the slide. All the ventral hernias are uniformly classified today by the European Hernia Society classification, which uses the location of the hernia, whether it is midline or lateral, whether it is a recurrent hernia or not, and what is the size of the defect. Basic surgical principles which guide us to the management of ventral hernia are reduction of the contents into the abdominal cavity with removal of any non-viable tissue and bowel repair if necessary, excision and closure of the peritoneal sac, reapproximation of the wall of the neck of the hernia if possible, and permanent reinforcement of the abdominal wall defect with sutures or mesh. Various surgical procedures are available today for the management of ventral hernias, but I'll be discussing only the advanced techniques, namely IPOM, IPOM plus, TARM, and abdominal wall reconstruction. Coming to IPOM, it is a intraperitoneal onlay mesh hernioplasty, and it is done using a composite mesh. Difference between IPOM and IPOM plus, when we use the term plus, it means that we are suturing the defect prior to placing the mesh. And complications of the surgery are adhesions of the bowel to the mesh, infection, intestinal obstruction due to the adhesions, and mesh migration. Here is a small video of the procedure. This patient had undergone a lower segment cesarean section with a final state incision and had a big incision hernia in that area. We are using a harmonic scalpel to dissect the adhesions that have formed with the surgical scar. And after that, we'll be reducing the contents into the abdominal cavity. The contents are the omentum. The harmonic scalpel is being used to reduce the contents of the sac into the abdominal cavity. And we have to make sure that there is a fat-free bed around the defect so that we can place our mesh properly and fixate it to the anterior wall properly. After reduction of the defect, I would, since it was a incisional hernia in the lower abdominal wall with close proximity to the bladder, I raised a peritoneal flap so that inadvertently I do not put any tack on the urinary bladder. Here I am raising the peritoneal flap. Oh, sorry. But it's not playing there. इसमें चल रहा है, उसमें नहीं चल रहा. बंद करके दोबारा खोलता हूँ एक सेकंड. सेव किया हुआ है. Sorry for the technical difficulty. So in this case, we are doing the adhesive lysis using the harmonic scalpel. We are removing the omental adhesions to the peritoneum, basically, and to the surgical scar. After that, we'll be reducing the contents back into the abdominal cavity. इसको फास्ट फॉरवर्ड कैसे करूं? नेक्स्ट नहीं हो रहा है? इससे तो आ ही नहीं रहा कुछ यहाँ पर. वीडियो से इसमें कटेगा नहीं शायद. मैं जैसा बोलूँगा ठीक से. अभी कुछ मत कीजिए. उसमें नहीं आ रहा, उसमें आ गया है लेकिन
इसका माउस कहाँ है? कहाँ है सर? पीपीटी खोलिए।
देखते हैं, एक सेकंड।
फुल स्क्रीन कीजिए सर इसको।
उसमें
फुल स्क्रीन कीजिए।
रिहर्स कर देता हूँ ना, इससे हो जाएगा। आ गया ना?
हाँ यहाँ से कीजिए सर, यहाँ से।
मेरा वीडियो प्ले नहीं हो रहा है और फुल स्क्रीन नहीं हो रहा है।
फिर इसे केबल निकाल के लगाना पड़ेगा जितेंद्र को। काट दे उसको पूरा। वो नहीं होगा ना, वो स्टैंड मोड में चला गया। लगाना।
रुकिए, फुल स्क्रीन कर लेते हैं उसके बाद।
एक मिनट सर, एक सेकंड। आप सर नेक्स्ट बस कीजिए और कुछ मत कीजिए। डुप्लीकेट करता हूँ। आप कौन सा
ये वाला है।
जो वीडियो है सर, उसमें आप क्लिक बस कीजिए, वो जब तक रन होगा तो हो जाए, फिर नेक्स्ट कीजिए।
नहीं, मुझे पॉइंटर भी चाहिए उसमें, फास्ट फॉरवर्ड करना है। मुझे इधर भी चलाना है, 10 मिनट का वीडियो है, 10 मिनट तो नहीं चला सकता। हाँ, ठीक है। So after the adhesive lysis, we will reduce the contents back into the abdominal cavity and create a pre-peritoneal plane by dissecting the peritoneum, because we are working in close proximity to the bladder. Here we are creating the pre-peritoneal plane for the mesh bed. After this, we will be suturing the defect using the endosuturing technique. And when we are tightening our stitch, then we have to ensure that we reduce the insufflator pressure so that our defect repair is not under tension. After closure of the defect, we'll place the mesh in the mesh bed, and the peritoneal flap that we had raised, we'll tack it back to the abdominal wall, and we'll fix the mesh using the same tacker. So take-home message for IPOM is that a complete reduction of contents is necessary, otherwise it may lead to seroma formation. All the fatty tissue around the defect needs to be cleared to create the bed for the mesh, and closure of the defect should be without tension, and we have to reduce the insufflator pressure while doing that. Next procedure is the TARM, that is transabdominal retromuscular mesh hernioplasty. It is a laparoscopic procedure for umbilical and paraumbilical hernias as well as incisional hernias, and it is suitable for those cases which have associated divarication of the rectus muscle. It is a procedure similar to that of ETEP. In ETEP and TARM, we both reach the plane between the rectus muscle and the posterior rectus sheath. Just the approach is different. In TARM, we go intraperitoneally to reach that space, and in ETEP, we stay extraperitoneally. And the point to remember in this surgery is that we cannot damage the linea alba while dissecting the posterior rectus sheath from it. If we damage the linea alba, then it will cause the weakness of the abdominal wall and increase the chances of recurrence in these patients. So this is a video showing TARM where we are making an incision on the posterior rectus sheath. We develop the incision on both the sides, and here we are actually trying to dissect the posterior rectus sheath of the linea alba, making sure we do not make any damage to the linea alba, otherwise it will reduce the integrity of the abdominal wall. This is the posterior rectus sheath below, and this is the rectus muscle. The lateral dissection on both sides is limited up to the linea semilunaris, where the nerves and the vessels enter the rectus muscle. We have to be careful not to cross that plane, otherwise the entire vasculature and innervation of the rectus muscle can be damaged, and it again increases the chances of recurrence. Next step would be to reduce the contents and dissect the sac. This is the umbilical pillar that we are dissecting over here. See, here we can see the divarication of the recti. Both the recti on this side and that side are separated. Here we had made a buttonhole defect in the posterior rectus sheath. We need to repair that, because if the opening is left as it is, the bowel may enter through that hole and get adhered to the mesh, and it can create a complication. The next step is suturing of the divarication of the recti muscle. Here we can see both the recti muscles are far apart from each other, and there is a huge gap in between. This defect needs to be closed to restore the integrity of the abdominal wall. And after that, we'll place the mesh in this space, and we'll close the posterior rectus sheath by tacking it to the anterior abdominal wall, or one can use suturing for this step as well. Take-home message for this case is that linea alba should not be damaged while doing the posterior dissection. All the buttonholing should be closed so that bowel does not enter through that hole and adhere itself to the mesh. And it has an advantage over IPOM that it does not require a composite mesh. It can be done with the normal Prolene mesh also. The last procedure that I will be discussing is the posterior component separation with transversus release and peritoneal flap reconstruction of the abdominal wall. It is an open procedure for complex incisional hernias. It is suitable for incisional hernias which have loss of domain and where the anticipated closure will not be possible without tension. It can be performed with a regular mesh, but it is not a good procedure for umbilical or small umbilical or paraumbilical hernias, and it is based on the principles of hernia surgery laid down by Rives and Stoppa. This is a complex incisional hernia with loss of domain post exploratory laparotomy for duodenal perforation repair. The patient had a surgical site infection, after which the wound healed with granulation. And this is the pre-op video, so we can see there is a large incisional hernia in the anterior abdominal wall. This is the technique what we use. If these are the peritoneal flaps, on the left side we make the incision on the posterior rectus sheath so that the peritoneal flap is in continuation with the anterior rectus sheath. And on the right side we make the incision on the anterior rectus sheath so that the peritoneal flap is in continuation with the posterior rectus sheath. So this peritoneal flap basically will form the bed for the placement of the mesh. We have done the adhesive lysis and we have identified the defect. This is the bowel protruding out of the defect, and this is the huge defect in the anterior abdominal wall. This is the posterior rectus sheath along with the peritoneal flap. This is the rectus abdominis muscle. This is the anterior rectus sheath. And in the next step, we'll be doing the transversus release. These are the transverse fibers of the transversus abdominis. Just medial to the linea semilunaris, we make an incision, divide the fibers of the transversus abdominis along with the posterior lamina of the internal oblique. And below the transversus, we enter the preperitoneal plane, which is the plane for the placement of the mesh in this Rives-Stoppa repair. Both the same procedure is repeated on the right side as well, and we create the bed for the mesh. We have placed a 15 by 15 mesh in this space. And after that, we have closed the anterior rectus sheath over the mesh. This is the end result. 2 drains were placed. One drain was anterior to the anterior rectus sheath, and the second drain was anterior to the posterior rectus sheath. This is a photo of the ventilatory machine that the anesthetists use. Before the closure and after the closure, we have to note the peak airway pressure, and it should not be more than 6 millimeters of mercury. If it is more than 6 millimeters of mercury, that means that our tension, our repair is under tension, and it may give way in the post-op period. So take-home message from this case is, it is ideal for complex hernias with loss of domain. All the buttonholing should be closed here also to prevent the adhesion of the bowel to the mesh, and care should be taken not to damage the neurovascular bundle at the linea semilunaris. Monitor the peak airway pressure before closure, because anything more than 6 millimeters of mercury rise in the peak airway pressure will subject the patient to very high chances of recurrence in the post-op period. And Many patients in which we anticipate even after the TAR that the repair will be under tension, they may require Botox injection to loosen the abdominal muscles so that the closure is tension free. Thank you so much.
Now the house is open for discussion.
It was a very good presentation, Dr. Adik.
Thank you, sir.
Two questions I am having. Number one, regarding TAM. What is the selection criteria of the patient for TAM?
The selection criteria of patients for TARM are complex incisional hernia, specifically those cases, sir, which have divarication of recti. If the patient just has a simple hernia with no divarication, then we can go for IPOM. But if the patient has divarication of recti and we need to suture the rectus muscle together, we can use TARM or ETEP, both we can use.
Okay. Now, when you are going for TAM, which method do you adopt? Is it a 3-port TAM or a 6-port TAM?
3 ports, sir. One in the center for the camera and 2 lateral ports for the dissection.
One for M3 also?
Yes,
M3 hernias?
Yes, sir.
And don't you find any difficulty in closure of peritoneum?
It has some learning curves, sir. I would say initially it was difficult, but with practice we can close the defect almost comfortably now.
So you are doing basically always 3-port.
Yeah.
Thank you.
Wonderful presentation.
Thank you.
Thank you, Dr. Chatterjee. So with this, we come to the end of this session of recent advances.
Now I request Dr. Suresh sir and Vinita Dwivedi madam to hand over the token of appreciation to all the panelists. Dr. Anirudh Mene, Dr. Pranay Behera, Dr. Jayant Acharya and Dr. Abhik Chatterjee. Kindly come onto the dais, please, to take your token of appreciation. Now I request Dr. Malini madam to kindly felicitate our chairpersons, Dr. Suresh sir and Dr. Vinita Dwivedi madam. Fourth one, Abhik Chatterjee. Jayant Acharya. Last but not the least, as today's topics were a feast to our knowledge, we would also like to uplift your spirits and imprint your souls with cultural extravaganza. So freshen up a bit and present yourselves at Bhilai Club from 7:30 p.m. for a banquet. Thank you one and all for making today's conference a grand success. Kindly attention please. One of the delegate has lost her